So it gives me great pleasure to introduce our first speaker for the day. Our first speaker is Dr. Bhavesh Polaria, who's a medical oncologist from Namakkal, and he'll be talking on behalf of Roche. This is a Roche-sponsored symposium. With that, we request Bhavesh sir to open the day. Over to you, sir.
Good evening, one and all. At the outset, I would like to thank MOSCON team and Durvalumab, dear friend, for giving me this opportunity. Today, I will be talking about the first-line NSCLC immunotherapy. And without any undue, I'll just share my screen. I hope my screen is visible and I'm audible.
Yes, sir, it's visible and you're audible.
So this will be a very short talk about optimizing the treatment in the first line NSCLC. So I'll give a brief outlook of how the cancer treatment is in how the cancer treatment is developed and what is the disease background, what is the landscape, what are the current first line management guidelines, and I'll be concentrating more on the IM POWER 150 study and later a subset of it like a liver's metastatic and EGFR positive NSCLC. And one last slide of summary to sum up everything. So we all know that lung cancer behaves in a different way. Sometimes it is slow growing, sometimes it is fast growing. It has varied overall response rate according to the driver mutation and the targeted agent which are used. It accounts most of the cancer of lung cancer. Most of the lung cancer are not small cell lung cancer, almost 80 to 85%, and almost 15 to 20% patients are never smokers. The median age globally is somewhere around 60 to 70 years. In India, we found it a little less, almost 10 20 years lesser than the global average. And typically, the patient will present with cough or chest pain or dyspnea. So these are very common symptoms which we see in day-to-day life. But we rarely think that not all patients are going to be cancer, but some of them are going to come out as a cancer in the diagnosis. The worst thing what happens with the lung cancer is almost more than half the patient will be having some distant metastatic disease at diagnosis itself. And many of them progress beyond their treatment to have metastasis. So targeted agents are the latest ones which have improved the survival rate in such patients, especially with those having proper driver mutations and specific personalized treatment has given more survival than the routine chemotherapy. So we can see the landscape of last almost 40 years, and starting from chemotherapy almost 40 years back, that was the only armamentarium with us. Later, depending upon the histologic subtype, we added anti-angiogenic agent in the form of bevacizumab that improved the survival a little bit. And since this new millennium, we have seen a surge of molecular pathology and many molecular targets, including EGFR, ALK, MOSCON, BRAF, and many more. And once we have given a proper targeted therapy for such molecular specific therapy as for specific lung cancer, the outcomes have been much, much better than using a simple chemotherapy, which we used to use almost 40 years back. And in last 5 to 10 years, we have seen a boom of checkpoint inhibitors, which is cancer immunotherapy, and it has actually changed the scenario. Also for those patients who do not have any molecular markers, and hence they are getting benefited with cancer immunotherapy with a different marker called as PDL1, TMB, MSIH, etc., etc. So we can see that these are the various PDL1 selected or unselected phase 2, phase 3 trials. And we can clearly see the difference between the chemotherapy and immunotherapy. There is a difference of at least 3 to 5 months in each study, whether it is atezolizumab or pembrolizumab or nivolumab. And now, according to the histologic subtype and molecular markers, the first line therapy in nutshell is I am sharing in this slide. So starting with the histological subtype, which is the commonest in NSCLC, is adenocarcinoma. and some of them will have large cell carcinoma, and some are not otherwise specified. This will be further tested to find any molecular marker like a sensitizing EGFR mutation. And the first line therapy, we know that there is first line, second line, and third line of EGFR targeted TKIs, Erlotinib, Apatinib, Gefitinib, Osimertinib, which are all approved for first line. Coming to second is a ALK positive, that Alectinib, Crizotinib, or Ceritinib. ROS1, again, Crizotinib is a first line therapy. Those who are having PDL1 as their marker and high positivity of more than or equal to 50%, and they are negative for all other targeted markers like EGFR, ALK, and ROS1, they are the perfect candidate to get pembrolizumab as their monotherapy in the first line. But many of them do not have this 50% and plus marker. So those who are having PDL1 low and negative for other markers, for them, combination of chemotherapy and immunotherapy is the best. So pembrolizumab plus chemotherapy is one option, and another option is atezolizumab plus chemotherapy plus bevacizumab. So I'll be concentrating on study IM power 150, which is the ABCP regimen commonly called as. So what is the rationale behind adding all this thing ABCP together? So we know that in addition to its known anti-angiogenic effects, bevacizumab also inhibits VEGF and has an immunomodulatory effect. With this immunomodulatory effect, it actually enhances the work of immunotherapy and improves the action of immunotherapy on tumor cells. So these are the four commonly known or tested functions. First is the normalization of the tumor vasculature, through which the VEGF inhibition increases and hence the T cell tumor infiltration increases. VEGF blockade can also establish an immunopermissive tumor with a microenvironment by decreasing the myeloid-derived suppressor cells and hence regulatory T cell population. Inhibition of the VEGF also promotes T cell priming and activation via the dendritic cell maturation. And the tumor cell killing by chemotherapy exposes the immune system to high level of cancer cell antigen. All this helps the immunotherapy, and there is a T cell mediated cancer killing which is enhanced through the bevacizumab and reversal of the VEGF mediated immunosuppression. So the study was very simple. They included all stage 4 and recurrent metastatic NSCLC patients, non-squamous. They were all chemo naive. The tumor tissue was available for doing the biomarker testing and any PDL1 IHC status. Stratification was based on sex, PDL1 by IHC expression, liver metastasis, yes or no. Almost 1,000 plus 1,200 patients were randomized into 3 arms, 1:1:1. The first arm, which is arm A, was having immunotherapy, atezolizumab plus chemotherapy, that is paclitaxel and carboplatin, for 4 to 6 cycles, followed by atezolizumab as a maintenance therapy. Arm B was a combination of ABCP, which is the main experimental therapy, which included atezolizumab, that is immunotherapy with chemotherapy, pacli and carbo, and addition of bevacizumab. Again, those patients who did well, they were followed with maintenance therapy of combination atezolizumab plus bevacizumab. And arm C, which was the control arm, which is a standard arm, at that point of time, which was paclitaxel plus carboplatin plus bevacizumab, and followed by maintenance of bevacizumab. So this maintenance therapy was continued till progression, and there was no crossover which was permitted. So this treatment, these patients were treated till progressive disease, or there was loss of any clinical benefit, or patients had some untoward side effects. So intention to treat, all the randomized patients were divided into 2, those patients with wild type mutation and those who are having EGFR and ALK positivity. So in this study, almost 87% were wild type and 13% had some mutation like EGFR and ALK. Those patients with wild type were further divided depending upon the T effector gene signature, whether TF high or TF low, and it was almost equal, 45% and 55%. The co-primary objectives were investigator assessed PFS in the whole population, that is intention to treat wild type, excluding the molecular positive patients. Investigator assessed PFS in the TF high wild type, again those patients who were having probably were going to do the best according to the pre-approved therapy. And overall survival in intention to treat wild type, again. There were important key secondary objectives also, that PFS and OS in whole intention to treat population, all the randomized patient. PFS in the PDL1 positive subgroup. Independent review facility assessed PFS and ORR and DOR as per the RECIST criteria. And last but not the least, the safety in the whole population. So we can see the baseline characteristics were well matched in all the three groups, including the sex, the performance status, history of tobacco chewer, liver metastasis, mutation positive for EGFR and ALK, TEP gene signature, whether it was high or low, and KRAS mutation positivity, and also the PDL1 expression. So this is the first of the results where it shows that in intention to treat population, the PFS was 8.3 months in the arm B, and it was 6.8 months in arm C, which is a standard arm, with a good hazard ratio of 0.59, and it was significant statistically with a p-value of less than 0.0001. So it was positive result in the first. Second was the overall survival. Again, the arm B and C are compared. The control arm C had 33.7% patient alive at the end of 2 years, and arm B, which is the experimental arm of ABCP, 43.4%. There was a jump of almost 10%, improvement in 10% overall survival at the end of 2 years, with a good hazard ratio of 0.78 and a significant p-value of 0.016. And we can see there is a stark difference, almost more than 5 months, from 14 months to 19 months in the median overall survival. Coming to the arm B and C, again the comparative comparison in this was the updated analysis, and the OS benefit was maintained even beyond 20 months longer follow-up, and the hazard ratio was maintained 0.78, and now it is 0.8, but still the p-value is significant, 0.01, and the median total follow-up was almost touching 40 months, and there was a constant maintenance of more than 5 months improvement compared to the standard arm. And sorry. So this is again an overall survival comparison of two arms, 14.7 versus 19.2 months. And the same thing compared with ABCP and BCP regimen, the primary analysis, which was hazard ratio of 0.59. So both PFS as well as OS, both are showing positive results. And that is why this is a recommended first-line therapy in non-small cell lung cancer, those who are having PD-L1 positivity. This is an important slide which I would like all of you to just have a look properly. We can see this a proper comparison of the whole population, that is intention to treat, where the objective response rate was highest with ABCP regimen, 56%, which was not seen with the standard or the combination of immunotherapy chemotherapy arm, which was somewhere around 40%. If you see the PD-L1 positive or PD-L1 high patients, it was almost going up to touch 70%, that is 69% with the ABCP regimen, and it was not, the standard arm was just 49%. If we come to the PD-L1 low, again it was 58% overall response rate in ABCP regimen compared to the 40% in the control arm. And the most interesting is the last part, that is PD-L1 negative. So those patients who were even PD-L1 negative, they had an improvement in the overall response rate compared to the standard arm, which was 30-35%, and now it was 51%. So even in those patients who are PD-L1 negative, probably ABCP regimen is working very well. So in practice, when we sit in front of the patient, there are multiple things we know and multiple things we have to analyze, like disease and patient characteristic, like the patient's performance status and age, what are the comorbidities patient is having, whether patient is having CNS metastasis or not, what is the overall tumor burden, how fast we want the responses, whether the patient is too symptomatic, lung function is not good, the number and the location of metastasis, especially in liver and brain metastasis patients. Then comes the biomarker analysis after we have assessed the patient, the driver mutations like EGFR, ALK, ROS1, BRAF, and others, or else we go to find out for immunotherapy markers like PD-L1 and TMB. There are other factors which are not scientific, but it is very important to consider that what is patient's wish, what is the physician's preference, whether the patient is having social support or not, And definitely that if there are any clinical trials which are present and patient is eligible for that. So after knowing all this IM power 150 in general, we want to focus on two difficult subgroups like liver metastasis and EGFR positive patients who have progressed on EGFR TKIs. So let us see them one by one. So we all know that those patients who are having liver metastasis, they have an increased risk of death compared to other patients who are having metastatic at other sites. So we can see from the first graph, the red line, which is the liver, you can see the liver is the worst, has fared worst compared to any other. Even the brain, even the nervous system progression is better than the liver. Same way, if we see the comparison of number of metastatic site, so those patients having liver metastasis, they actually have significantly more number of metastatic sites compared to the patients who do not have liver metastasis. So this is a simple comparison which is given here. Those patients with liver metastasis, 0 to 1 was only 20%, whereas most of them, almost 80%, had more than 2 metastatic sites. As if we compare with the no liver metastatic patient, also almost similar, 45 and 50%. So this was again a picture where it is showing that in the whole population of intention to treat wild type, the comparison of standard versus ABCP was 0.78 hazard ratio, which included almost 87% of the patient, and there was improvement. This is the overall 5 months improvement. And when we come to the liver specific or liver metastatic specific subgroup, those who were wild type, the hazard ratio was much better. It was 0.54. And we can see almost 4 months improvement compared to the standard arm, that is from 9 to 13 months. Compared to those patients who had no liver metastasis wild type, it was 0.83. And again, there was an improvement of 3 months, 3 to 4 months numerically, even though the unity is crossing, the line is crossing the unity. So this is a graph, Kaplan-Meier graph, which shows an improvement even though there is a liver metastasis with the use of ABCP regimen, and there is a stark difference of almost 4 months from 9 to 13 months compared to the standard arm. And they have also compared the arm A versus the arm C, which was chemotherapy plus immunotherapy versus bevacizumab and chemotherapy, and we cannot see much difference. In fact, the immunotherapy plus chemotherapy arm had fared a little worse. It was 7 months, but again, it is not significant. So we can consider probably it is not having much benefit to combine these two modalities. Now coming to the second subset, which was EGFR positive patients who have already been treated with EGFR positive TKIs and have progressed. So basically, once we have used a second or a third line agent and patient has progressed, we hardly have any option or a good option for such patients. So these are all the studies which are quoted comparing the first line, the second line, and third line agents, and definitely the chemotherapy, which was the age old. And we will go from left to right of the screen, and we can see that the chemotherapy platinum doublet has not given an improvement of overall survival of the PFS survival of more than 6 months. Whereas in first line, second line, and third line, we can see all of them have on an average given a 10 months plus PFS advantage, and the maximum is with Osimertinib. So Osimertinib actually becomes a preferred choice because it gives almost 19 months of PFS. This is a comparison of EGFR wild type and mutated type. We can see very clearly in the wild type, the diamond is on the favor of using PD-L1 inhibitors, and in mutated, again, it is favoring the PD-L1 inhibitors. This is the PFS, which is getting separated a little late, almost till 2 to 4 months, it is almost same, and after 4 to 6 months, it has started separating, comparing the ABCP regimen versus the standard arm. And we can see there is a difference of almost 4 months, maintained 6 months versus 10 months in these two curves, with a hazard ratio of 0.59, which is very impressive. So now this was a comparison of arm B and C with the overall survival, and we can see there is a major difference between the two. Once we use an ABCP regimen versus a standard arm, there was 18 months versus 29 months, so almost more than 10 months difference, and an hazard ratio of 0.6. Again, this is very, very impressive. But same thing when there it was compared with arm A and C, that was chemo immunotherapy arm versus bevacizumab plus chemotherapy arm, and there was no clinical benefit which was observed. Hazard ratio was bang as 1. And practically, the median survival was same. Now we come to the ORR and the DOR, and we can clearly see there is a stark difference between the ABCP and the standard arm. Almost 30% improvement in the overall response rates, and even the CR rates, which was 0% in standard arm, it has improved to 6%. The duration of response is very, very different compared to just 4 months versus 11 months in the ABCP regimen. So what do we conclude from this study? That IM power is a positive study for sure, and it has made itself as a first line candidate for non-small cell with statistically significant and clinically meaningful improvement both in its co-primary endpoints PFS and OS with the use of ABCP regimen compared to the standard arm. It has also given a clinical benefit in the key group, especially with those who are having EGFR ALK positivity and liver metastasis, and it has added years to the life with the use of ABCP regimen. Atezolizumab in combination with this chemo plus bevacizumab is well tolerated. We know the safety profile and it is not having major risks. Additionally, the patient characteristic beyond PD-L1 expression also should be considered when we make this decision for using a combination treatment, which is very, very important, like whether the patient is having liver metastasis or patient is having EGFR and has progressed on EGFR, and then there is no better option available. So here we, after the efficacy, we compare the side effects, and we can see that the side effects are not much different in each arm. It is almost similar when we compare with arm B and arm C. Not much difference in grade 3, grade 4 or grade 5, and not much withdrawals compared to the standard arm. A little bit more, but not major difference. And comparing the side effects with the standard arm and ABCP regimen, we can see those drug-related side effects of immunotherapy are a little higher. But again, those are 10%, somewhere around 10%, and they are very well manageable. Now, after we have used immunotherapy for such a long years, we know how to monitor the patient, when to intervene, when to withdraw the drug, and we are very well versed with that. So I think this 10% patient, those who are having any problem, we can manage them very well. So in summary, this is a phase 3 multi-center international randomized trial, which was open label, and it has compared the chemo-naive patients against the standard arm versus the ABCP. And ABCP has become the first chemoimmunotherapy combination to demonstrate a meaningful overall survival, especially those who are having liver metastasis and progressed on EGFR TKIs. This has also nearly doubled the PFS benefit at 12 months, and PFS, which was 38% with this regimen versus 20% with the standard arm. So definitely it has made its mark in the first line, and it is rightly one of the proper options to be used for first line NSCLC patient. So there is a statistical difference in this column. You can see that in the whole population there was a difference of almost 5 months. In those who have progressed on EGFR TKI, there was a difference of more than 10 months, almost 12 months, I would say, almost a year. And those patients with liver metastasis, which are the most difficult patient to treat, in them also there was an improvement of more than 4 months. So there was a not only improvement in the overall survival, also the overall response rates were much, much higher, which was 56% compared to 40% with the standard arm. So thank you for the patient listening. I'm sure I have convinced you that we have good number of options which are available, and more personalized therapy is the way out for lung cancer since last decade, and the survivals are becoming much and much better. And only thing what we have to see is look for these markers, look for them appropriately, monitor the treatment wisely and give the patient a proper chance to have the best survival. Thank you for patient listening. And if there are any questions, I'll be happy to take.
Thank you so much, sir, for the wonderful presentation. If we have any questions in the audience, we would welcome them. We'll wait for another 10 seconds if anyone has any questions. If anyone has any questions, you can just raise your hand and we will unmute you. Thank you so much, Bhavesh sir. It seems that we don't have any questions. You've explained the concept very well. So we'll move on to the next session. Our next session is sponsored by Novartis, and our speaker is Dr. T. Raja, Senior Medical Oncologist from Chennai. Over to you, sir.
Hi, Kashish. Good evening. Just tell me whether my,
Yes, sir, your screen is visible, sir, and good evening to you. I believe it must be quite early in the morning for you right now.
Yeah, early in the morning, but thank you so much for this invitation. And, I thank Dr. Kripa Shankar for this wonderful invitation, excellent meeting, and everybody is already saying that Kripa Shankar is in beast mode. So I think we are all enjoying the meeting. I'm happy to join at this point in time. And quickly moving on to the topic, I also thank Novartis for this opportunity here. And I thank Kashish and the entire organizing team for me to helping out to be here. And the talk is on targeted treatment for BRAF V600E and MET exon 14 mutated disease. And as Novartis wanted, I am also adding some experience from our own clinical patients. So therefore, Novartis does not certify the accuracy, completeness, and correctness, and some of my opinions. Totally agreed. Disclaimer. So we know that non-small cell lung cancer, we heard the excellent presentation just now from Bhavesh. We know that non-small cell lung cancer is very common. All of us treat this, but why would it become so important to discuss this often, repeatedly? Because of the significant disease burden. And world over, everybody is aware that 2.2 million new cases, 1.8 million deaths, and the second most frequent tumor, and the leading cause of cancer-related deaths. See, these are some of the accolades, or you can call it as dark spots in lung. So therefore, lung becomes everyday problem in the clinic. And this is the European data, more than 50% of them presenting in an advanced disease. I'm sure in India, we see much more advanced disease than that. And we are all aware that heterogeneous, it is not a single disease, heterogeneous disease. And as of now, we realize that 87% of adenocarcinomas and 64% of squamous carcinomas are potentially actionable driver mutation associated. So therefore, something can be done for all these patients. And our focus of interest today is the MET exon 14, and the BRAF MET exon 14 is around 3% among the non-small cell lung cancer and 5.5% BRAF among the non-small cell adenocarcinomas. So that's the from the Foundation 1 and MSK impact data set. And all of us are now aware of utilizing the multiplex NGS, but some questions remain. What sort of NGS? Should it be DNA based or should it be RNA based? We can just quickly say that, of course, DNA based amplicons are the standard available everywhere, but RNA based NGS, if you can do, that is definitely superior to the DNA based NGS in identifying some of these mutations, particularly the MET exon 14. But one important warning is that if the RNA is not of good quality in your tissue assessment, that will put you down, and then the number of identification goes down. So that is something that we need to be aware of. So even though RNA-based NGS is superior, the quality of RNA should be very, very good for us to be very clear. And we are aware of the strengths and weaknesses of using NGS as our upfront option. The weakness is the most important thing to speak about. it is definitely needing a good quality lab, and that has computational biology expertise. But most hospitals in India are now setting up their own good quality NGS testing. And in that setting, Novartis and LalPath have joined together. This is a very good initiative. LalPath, Genevolve, and Novartis have put together this NGS, which is at 8,500 rupees for the test. So that's very nice. You can look at one issue. You see that the DNA-based sequencing may be useful for detecting all the routine things like EGFR, ALK, and KRAS, and BRAF, and so on and so forth. And RNA-based sequencing are particularly useful for ALK, RET, ROS1, and MET exon 14 skipping. So this is something that we shall keep in mind. BRAF V600E mutation in non-small cell lung cancer. We'll first focus on that particular mutation. And it's a serine threonine kinase pathway inhibitor. And here is where the mutation happens, BRAF V600E at the BRAF. And BRAF in general is a frequently mutated entity in cancer, and it is across many cancers like melanoma, papillary thyroid cancers, and colorectal disease, and non-small cell lung cancer. Among that, BRAF V600E is the most common activating mutation among all cancers. Whenever you look at BRAF V600E is nearly 90%. It's a point mutation in the exon 15 of the BRAF gene, where the adenine is substituted by thymine. So this is the mutation that is BRAF V600E. If you look at lung, 50% of all the BRAF mutations are BRAF V600E. The others could be non-V600E. We'll consider that later, but today's focus is V600E, and BRAF mutation account for 1 to 5% of all these non-small cell lung cancers. And this is the data set from across the continents, and they may have some difference in the incidence, but essentially 1 to 5%. But what is important is whenever we are able to target the BRAF, it improves the situation. If you look at the data from China, in patients who are treated with chemotherapy, you have a response rate of 40 to 70%. But whenever you have a BRAF target, you see that the response rate or the disease control rate can reach up to 100%. But this is a very small data set from China, which is about 46 patients. But if you look at the US data set of about 72 patients, you see that not only the disease control rate as reported by the China, even the overall survival can be changed by specifically targeting BRAF V600E. Without targeted therapy, the median overall survival is 27 months, but with targeted therapy, you can really leapfrog to 56 months. And something very curious about this BRAF V600E mutation inhibition. Dabrafenib is an inhibitor specifically of V600E and other BRAF kinases, but if you block as a single agent BRAF inhibition with dabrafenib, you have a paradoxical activation of the downstream pathways like the MERK. So, and therefore you need the doublet, trametinib, which can inhibit the MEK. So you need to have the doublet kind of completely block the pathway. And this is the most important data set as far as BRAF inhibition goes, 3928 BRF11. And this is cohort A, B, and C. The cohort A is single agent dabrafenib. Cohort B and C are doublets, but cohort B is patients who have been pre-treated, and cohort C is treatment-naive patients. And essentially, if you look at the demographics, the median age is above 64. And the anti-cancer therapies in pre-treated patients will be all of them, chemo, immuno, everything has been exposed. So it will be very interesting to see what happens to the response rate after a real life kind of situation. The overall response rate with monotherapy is 33%. But if you look at the doublet, the overall response rate in both pre-treated patients and in treatment-naive patients is above 60%, 68% and 63%. And the PFS is 10 months in pre-treated and treatment-naive with the doublet. But with monotherapy, the PFS is only 5.5. So two things very important is that doublet is essential, and this is borne out in clinics also, not only in the biological pathway. But the other important message is both in pre-treated and treatment naive, it's nice to see that the overall response rate is about 60%. So what it means is, so if you have a patient and if you have put on chemotherapy, nothing to worry. If you use it in second line, you may still get a response rate of about 60% plus. So therefore, NCCN and ESMO would recommend it in first line and also in subsequent line. And if you look at the specific efficacy of the doublet and compare it with Vemurafenib, the other BRAF inhibitor from a basket study, and other treatments like immunotherapy, we'll have a perspective. The doublet has an overall response rate for the BRAF V600E specifically above 60%, as we have seen. And if you compare it with Vemurafenib, you have a response rate of 40%, and immunotherapy response rates are 25%. So therefore, the doublet is superior to, immunotherapy or other inhibitors like Vemurafenib, and you have a PFS of 10 months with the doublet as compared to 7 months and 5 months with Vemurafenib and immunotherapy. And if you have a median overall survival of 17 to 18 months with the doublet. Moving on to MET exon 14 mutated non-small cell lung cancer, the MET oncogenic activation can happen by multiple mechanisms. This is the physiological signaling, but you may have a kinase domain mutation in the intracellular domain of this MET. You can also have amplification, which is what we frequently see in patients who have other mutations like EGFR, ALK. When you treat them, you see that MET amplification is the secondary escape pathway. And sometimes you can have MET fusions, and very specifically, you can have MET exon 14 skipping mutation, where you lose that juxtamembrane domain. And this leads to extended signaling from that pathway. And this MET exon 14 is the most common reported MET mutation, and this is seen in 3 to 4% of non-small cell lung cancer. And what are the most important characteristics of this MET exon 14 skipping mutation? Age, they are all of higher age group. This you would see in MET and also in BRAF. Generally, they are above 70s, and more common in females than in males. And the MET particularly is seen in adenocarcinomas and also across the histologies like sarcomatoid variants and all that. And both BRAF and MET exon 14 are not associated with smoking history, and both of them are associated with aggressive disease. And this is the Kaplan-Meier for overall survival and the DFS. You see that the MET exon 14 is clearly prognostic, and you see that the curves quickly come down whenever you have the MET exon 14, both the DFS and OS. But as soon as you are able to institute a MET targeted therapy, median overall survival can jump from 8.1 months to 24.6 months. So whatever you do, if you're able to target MET, you can really improve the MET exon 14 mutated disease outcome. And some of the commonly previously used options: chemotherapy, overall response rate 26.4%. If you use immunotherapy, 17%. But if you are able to use some other TKIs like Crizotinib, it is 32%. That's what we have so far with MET inhibition. And Capmetinib is the first targeted therapy specifically approved for MET exon 14 inhibition. And when you look at the inhibitors for MET, you have now type 1, type 2, and type 3. The Crizotinib, Tepotinib, Savlotinib, and Capmetinib are classified as type 1 inhibitors. Cabozantinib comes in type 2, and there is actually a type 3 inhibitor also. And again, if you look at their, Capmetinib is the highly potent among them, inhibitor of MET kinase. And if you want to quickly summarize their response rate, you can say that Crizotinib can produce a response rate of 30%, Tepotinib can produce a response rate of 40%, Savlotinib 50%, and Capmetinib can produce a response rate of 60%. Let's see the important data set geometry mono-1 for MET exon 14 inhibition. And this is a 7 cohort study. Basically, this has cohort 1 to 4 are pre-treated patients, and cohort 6 is also pre-treatment. Cohort 5 and 7 are treatment-naive patients. These cohorts are stratified based on whether they are pre-treated or treated, and also based on gene copy numbers, whether it is more than or equal to 4 or more than or equal to 10, and also whether there was a fasting requirements or no fasting requirements. So these are the 3 important broad points on which these cohorts are divided. And then they are clubbed together where they are analyzed as either treatment naive or pre-treated patients. And let's look at what is the outcome of geometry mono-1. If you look at the cohort 5B and 7, which are the patients who are treatment naive, and you look at the response rate, you have the response rate of about 67% and 65%. And this is fasting restriction 67%, no fasting restriction 65%, and the PFS of 12 months and 10 months. And in patients who are pre-treated, cohort 4 and 6, fasting restrictions and no fasting restrictions, you see the response rate of 40% and 50%. So the most important takeaway is that nowadays fasting restrictions are not really needed for instituting this treatment. So the response rates are similar with fasting or without fasting, and actually it's superior without fasting. And there is also a very, very impressive intracranial response rate of 54%. And you can see, a good number of patients having a complete response also. And you also see that 12 out of 13 patients had an intracranial disease control, and 4 out of 13 had a complete resolution of brain lesions, and 7 out of 13 had a response rate that is 54%. And these are some of the images that shows a complete response in a 73-year-old female patient who had multiple brain mets. And the most important side effects of capmatinib are peripheral edema, gastrointestinal symptoms, and increased blood creatinine. And capmatinib, therefore, has demonstrated a clinically meaningful efficacy and promising efficacy, intracranial efficacy, so on and so forth, and it is well tolerated. So it's very nice to have these 2 options for us. And so therefore, today the NCCN guidelines have really brought these 2 important options into the first line as preferred option. If you have BRAF V600E mutated non-small cell lung cancer, dabrafenib, trametinib is probably the treatment of choice, preferred treatment of choice. And if you have a MET exon 14, you have capmatinib, which is the preferred treatment choice in the first line. So let's quickly look at some of our experience in BRAF and MET exon 14 in non-small cell lung cancer. This is a patient who is 74-year-old, and this patient presented to us first in 2019, metastatic adenocarcinoma, treated in the standard way, chemotherapy followed by maintenance treatment. And eventually this patient progressed from 2019, from early 2021, this patient progressed. And when we did the genetic analysis, this is a tissue-based NGS, you see that this patient has got a BRAF V600E, and you can see that this adenine is substituted with thymine. That's what is the most classical of V600E, and therefore we put this patient on dabrafenib and trametinib. You can see the responses here. These are the lung lesions, and you can see the excellent response here, almost not visible, complete response rate, complete responses. Here again, some more images of the same patient with excellent response, and some more images of the same patient with excellent response. Another patient who is 84-year-old male, we saw this patient first in October 2020, very elderly, ex-army man, very fragile, and had a lung cancer. But therefore, at that point, we were slightly worried about getting another puncture from the lung, and therefore we sent for liquid biopsy. In liquid biopsy, you see that the BRAF V600E was positive. So at that time in October 2020, we were slightly skeptical to accept liquid biopsy as our diagnostic modality, even though now There is a large data set, particularly for papillary thyroid carcinomas, exclusive liquid biopsy usage, more than 60 patients with liquid biopsy detected BRAF. So that was published last year. But in October 2020, we were slightly worried to treat based on this. And so therefore, with some counseling and risk, we did a repeat lung biopsy, and that really substantiated the BRAF V600E on this patient. And this patient was put on dabrafenib and trametinib from November 2020. You can see the excellent response. 84-year-old male responding very well. And these are some of the images showing very good partial response. And the other interesting thing, we followed this patient, and this is somewhere in early 2021, and this is September 2021. The BRAF V600E has disappeared, and the patient continues to be in very good response and he has crossed more than 1 year on this combo and is doing very well. Some of our experience in MET exon 14 mutations or MET mutations, we looked at 2 years, 2019 and 20 or 2021, 2 years of our patients with MET alterations. And across various diseases, we could find about 17 patients with MET alteration. And out of that, 5 were lung cancers. And in that, you would see that MET 14 skipping mutations were seen in 3 patients. MET mutation was seen in 1 patient, and MET amplification was seen in another patient. You will often hear from many published data, you would have seen that MET is usually found to be isolated. Therefore, it is a singular driver mutation. But we found that it was associated with different things, and that's what we saw actually. And this is a close-up view of our lung patients with MET. And one patient example, this patient, 55-year-old female, we saw her in Jan 2020, 2 years ago. And at that time,
so
we
1
found
minute left, sir.
exon 14 skipping mutation. And this was confirmed with our NGS. And this patient was started on crizotinib. And you will see that from Jan 2020, May 2020, excellent response. She had a beautiful response, very good performance status improvement, so on and so forth. You could see the scans that show very excellent response. But unfortunately, she quickly progressed from September 2020. If you look at the PFS with crizotinib, it's only 7 months or 8 months. In the data set, that's what we also saw. And this patient progressed in November. I wish we had access to capmatinib at that time. So these are the basic success statements from Novartis on capmatinib and dabrafenib and trametinib. So with that, I thank Novartis for this opportunity, and I thank the organizers for this opportunity. Thank you very much.
Thank you so much, sir. Thank you for the wonderful presentation. We thank our sponsor Novartis as well. We'll move on to the next session. Our next session is on the topic application of genomics in the management of cancer. And our speaker is Dr. TS Ganesan, who's a senior medical oncologist and chief scientist cancer biology from Chennai. Over to you, sir. So can I request you to unmute your mic, sir? Sir, are you there? Sir, can I request you to unmute your mic?
Yeah.
Thank you so much.
Just 1 second. I just want to escape from this and move to the first slide. I'm not able to do.
So can you use the arrow keys?
Arrow keys. Where are the arrow keys? Yeah. 1 second. I'll get to the top.
No worries.
And then start again. Share screen. Then Can you see that now?
Yes, sir, we can see your slides. Thank you so much, sir.
Okay. Good evening to everyone. After that excellent lecture from Rajat, I'm going to give you a little lower down on the scale, more for people who are actually not familiar with all the things which he mentioned. I also thank the Society, Oncology Society, as well as Kripa Shankar, who has been dealing with me for this particular meeting. Now, what is this? How do you go to the next slide?
So can you use the mouse? Are you able to click on it? Or you can use the arrow keys as well.
Yeah, arrow keys are not moving. That's why.
Okay, so probably, so can you click the left mouse? Can you click on that? There you go. Sir.
Yeah, okay. All right, I got that. So basically, all of you know, we sequence the whole human genome and it has got a large number of genes, 20,000 genes at least. The average gene is about 27,000 base pairs. Large amount of the genome is made of highly repetitive sequences. The most important thing to remember is almost all of the genome is the same in all the people, and genes are not evenly distributed over the whole genome. Many genes, we do not know the function. It's very important to remember that. This is going to be a problem. This is not going anywhere. You have to move it for me, I think.
Sir, we'll have to share the slides at our end.
Okay,
so
can you do that? Because
yeah,
there's some problem. Yeah, if I tap on the thing, it moves. Okay, so this is something which I wanted to mention to people historically. The new approach to sequencing, which is called the next generation sequencing, arose from a discussion in an English pub. And the people who actually had that discussion were Shankar and David Kleneman, and they actually worked out, they were not working on identifying a method of sequencing, but they worked out how to go about it. And they sequenced the same bacteriophage which Sanger had sequenced. This led the whole thing of next generation sequencing starting from sort of late 90s. This is a bore. Yeah. This gives you a sort of comparison between capillary sequencing and massive parallel link sequencing. You can see in capillary sequencing, you have to do one gene at a time and you identify the mutation, in this case, A to G. But in massive parallel sequencing, you do over 100 times and you get very confident results. And you can do multiple genes at the same time, multiple samples at the same time by different approaches. I'm not going to go into the details, scientific details of how you do it. So well before NGS started commercially, the Cancer Genome Atlas was set up by the NCI and the NHGRI in the US. And basically this was to try and sequence entirely after the human genome sequence was identified, all tumors. Primarily, they chose poor prognosis tumors and overall public health impact and availability of human tumor and matched normal tissue samples. So this actually also led to another organization which started from England, they used to welcome, and Ian Stratton started this. It's International Cancer Genome Consortium, and they're doing the same thing, but they've distributed the sequencing to different countries. So India actually, for example, is sequencing patients who have got gingival cancer. So this was launched in 2008, and we have published our data. And similarly, TCGI has published a huge number of papers sequencing whole genomes of multiple tumor types. Now, what are the Indian initiatives? It's very important to know that. Basically, we need to know what the normal polymorphisms are in Indian population, which is quite different to the West. So Indigen is 1,008 normal genomes fully sequenced from different parts of India that's published, and Genome India is 10,000 normal genomes, which is being pioneered by the National Brain Research Center. It's still not over. Now, in terms of disease, in the research setting, I'm mentioning only a few, specifically like what TCGA has done. In IGIB, there is a thing called Guardian, and for rare diseases, and there's a private company for sequencing cancer. And of course, there is a collaboration with TCGA and UK. Now, if you look at recently in Nature publications, there was a combined analysis of the TCGA ICGC sets, which was not based on exome sequence, which is what the publications were. This is actually on whole genome sequence, and they focused on 2,600 tumors, 38 different tumor types. I'm just giving you the gist here. People can read the actual manuscript, which is quite dense. There were 4 to 5 driver events, both coding and non-coding for each tumor. Many genetic events that led to malignancy occur very early in the course of the malignancy. There is, of course, heterogeneity. And the core driver genes were very similar across tumors. And 5% of tumors, interestingly, had absolutely no mutation. And of course, some tumors had this sort of chromothripsis, chromoplexy, cattargus, which is actually all different terminologies for catastrophic genomic abnormalities, huge amount of genomic abnormalities in the tumor. Now, as a consequence of this, what are the type of structural alterations you see? Essentially, you have got 2 different varieties. One, you've got the mutations, and then you've got the copy number variations. So in the copy number variations, you can see kidney cancer is very little, whereas ovary is very high. And in the mutations, you can see kidney is very high, but the ovary is very little. So this is actually a fundamental method and differences between tumor types by which tumors alter genes. And that's what we are looking at when we look at the TCGA or the ICGC. Both of them are available on websites, and anybody can access them, CBio portal, for both of them. Now, another little important point is when you actually sequence metastasis, this is actually a lung cancer classical paper from 2012, which showed actually there are different mutations in all these metastases from a patient with lung cancer. And this is what is listed here. And this is actually shown by this nice little thing, how the primary tissue, what are the primary tumor tissue, what are the mutations, and what happens in the metastasis. And they're quite different, how some of them are shared with the primary, shared with the metastasis, some of them are private. So it's not that simple. So you have to know what you're sequencing with the primary tumor or metastasis. It may actually make a difference when you come to treatment. Now, I'm just going to give you some illustrations, so data from my own clinic. This is actually the application is for using next generation sequencing to identify treatments which you want to give to patients. Not like the type Raja said, where we already know MET is mutated lung cancer. This is where we have no idea. So we have exhausted all types of treatment, and we want to understand the biology better. And for sometimes it's for diagnosis as well. Now, when do you do it? Early cancer, undergoing definitive therapy, which is what we all know pretty much. Occasionally in advanced lung cancer, like the MET business, which he talked about, very rare cancers, then for clinical trials, for exceptional responders. And it's not really indicated when you cannot actually do something about what you're going to find. So when you're rapidly progressing cancer, or you've got poor performance status, or a very short expected lifetime, there's no point in doing this. It's academic reasons you can do, but otherwise there is no point in doing it from a clinical standpoint. How do you approach this? You can do as whole exome, whole genome. Will you do whole exome or genome sequencing unbiased? You have no preconception. So it's very good in rare tumors where no knowledge exists. And you can also compare between 2 time points. It's very important to sequence normal DNA, which most people forget because of the cost reasons, because we still don't have a very good idea about our own polymorphisms. Targeted sequencing is what Rajat talked about, where you select your genes to be sequenced in a particular tumor type like lung cancer or breast cancer or colon cancer or ovary, any number of cancers. What genes to include in this panel? Well, commonly mutated genes, which are sufficiently frequent, they're targetable, pathways that are targetable, or you can put genes which are relevant to drug metabolism or toxicity. The number of genes actually vary. For example, the NCI does with 143 genes. Some of the companies in India look at 120 plus, some 600 plus. So it varies from company and what you're using. So it's very important to know what genes you're going to sequence to actually look at the report. What do you need? You need fresh tissue if possible. Paraffin block is okay. It needs to have at least more than 75% tumor cells. You need some peripheral blood or saliva. I would insist on controlled DNA, particularly for rare events which you are taking at. Turnaround time is usually 3 to 4 weeks. It can become faster depending on high throughput. You need quick, good quality DNA. Now, the analysis is the key. So bioinformatics is the key. Most of the doctors do not understand this, I'm very sure, except for the few who are involved in this in a big way. So you need very good people. The company usually produces a report, but you should know how to interpret the report. For that, you need to know how the analysis was done. So this is a standard way where FASTA files are used, then they're aligned with the reference DNA. And then there is actually a particular software called Genome Analysis Toolkit Pathway, which works out what are the mutations between control, copy number variations, everything, and how you decide what mutations may be significant. That's what you see in the report at the end. So I'm going to give you 2 or 3 cases from my own clinic where we did this. This is actually a retired police officer, carcinoma rectum. You can see the story, very rapid progression, chemoradiation, capox, then Kapiri, then panitumumab, irinotecan. So he had all this. So quite a lot of treatment, but very rapid progression. So we sequenced the tumor to see what we would find. And surprisingly, we found some interesting things. APC, of course, was expected, but ERB2 at that time, this was quite a few years ago, was not expected, neither was PIK. And then ROS1. So we had actually drugs potentially for treating these conditions. Another case where we didn't know exactly where the tumor is from. And this is for actually a very senior VIP from Bangalore. And this is a 69-year-old widow. She had a poorly differentiated carcinoma. We didn't know whether it was from the cervix or endometrium. The IHC suggested possibly ovarian. And you can see the treatment didn't work that well. She had some response, but it went. So when we did the sequencing, it was very clear to me, at least, it was from the endometrium and not the ovary. Because you can see p53 is absolutely normal. Now, p53 is usually mutated in 100% of ovarian tumors, and p10 is less so. So p10 also is here. Frame shift means you've lost the function of the protein. FBX also, you've lost the function of the protein. So this is another patient, which is rare tumor, Sodomixoma. HIPEC was not very successful here, and he had different types of treatment. What was interesting was in his particular tumor type, we had a lot of, this is all whole exome sequencing, a lot of frame shift mutations in MUC, and then we had a huge number of mutations for which we could give treatment. And I think he did have BRCA1 and 2, oliparib, missense mutations, and lots of mutations in other genes. So the final thing was a single lady who was operated for a high-grade uterine sarcoma, and one wouldn't predict. She had recurrent disease in the bone, supraclavicular fossa, and lung. NGS showed whole exome on tumors, showed germline BRCA duplication of exon 10 and 11. So this, again, potentially we can use platinum and PARP inhibitors because she had recurrent disease. This was unexpected, what we found. So there are good reasons for doing whole exome sequencing in patients, not just targeted. So the interpretation is very important. Not all mutations are important. Some may be polymorphisms. You have to compare with control DNA. Passenger mutations are common. And software analysis of significance of mutation, this is very important. And this, largely in most of the reports, they are done by scientists. So you have to have an idea of how to go about it. Evolution and conserved residues, and then amino acid change. What is it? What is the frequency? Multiple tumor type. And you can check whether it's a polymorphism in India by going to IGIB database. Finally, if the change is unknown, you have to do experiments to actually work out what it is. Now, I'm going to sort of tell you a little bit about the trials which are ongoing, looking at whole exome sequencing, both the basket studies, which I'm going to skip through these next 2 slides because they're basically the umbrella and basket studies I'm sure you all know, which I got from Illumina. Now, ESMO has created some guidelines on how and when to do whole exome sequencing, and this is what it is. You can check up, it's published now. Tier 1, when there is a clear indication, and Tier 5, when we don't know exactly what it means. And Tier 2 to 4 is at varying levels how successful we think we are going to be with the target. Now, some trials. Now, NCM Match is the first trial, which is very good, well designed, and they've recruited a huge number of patients, and at least 35 patients in each arm, 25% had at least tumors. They only sequenced for 143 genes in 4 centers. Now, this is for breast cancer. You can see the number of drugs which have been tried based on the sequencing of the tumors in individual patients and what the molecular alterations are. This is in breast, it's published. So similarly, they are published for different tumor types. This PIK is very highly mutated in terms of number of patients compared to other genes. And now, as you know, there is a definitive drug for PIK3 mutation. So the endpoints were at least 16% of patients have to have response, and they've had much better than that, about 25%, and some improvement in survival. The interim analysis, the first publication in 2020, which is looking at the whole thing, is actually 37% had an actionable mutation, which is much higher than I thought. Originally, it was supposed to be 10%, and at least 93% could be sequenced. Interestingly, some tumor types like pancreatic and small cell had very low frequency of actionable mutations compared to other tumor types. This is another trial, Shiva trial, where actually a randomized trial where they used NGS to decide what treatment to give in patients with cancer. And here you can see there was absolutely no difference. This is one of the trials which was published, which was actually negative in terms of this is what ultimately we have to do in terms of, but we also have trials where they're non-randomized, where they're looking at only targeted treatments for individual tumor types. And these are some of the trials, Moscato, then My Pathway, and the Tapur study is a fairly big study from ASCO. And I just mentioned that in greater detail. 1,400 patients have been treated, different drug combinations in 44 cohorts. And these are some of the responses, like, for example, pertuzumab and trastuzumab in ERB2 colorectal cancer, and then you heard about vemurafenib in BRAF colorectal cancer, and then pembrolizumab. So these are all trials which actually are interesting in identifying how to use NGS and what are the response rates here. So these are all some of the ongoing trials. People can look at it. Most of them, some of them are not published as yet. Now, what are the issues? Basically, whole genome and targeted sequencing is available in India now. It's largely in the private sector. Of course, some of the bigger public sector organizations like IGIB, Tata, and so on, IIT, and so on, have it, but they're not usually routinely used for routine examination of patients. So it's largely in the private sector that you actually get the NGS done. And for research in the public sector, the cost is quite variable. It varies from, well, for whole exome, anything between 40,000 to 70,000. Quality interpretation is very important, and you have to choose that very carefully. Unfortunately, everybody reads the reports and decides, but you need to go beyond the report. For that, you have to have an understanding of how the report was constructed and an idea of the whole NGS platform. Now, drugs, we do not have access to all the drugs which the Americans have, the Europeans have, not only investigational drugs, but also drugs which are conventionally used for different types. That is our main problem. So for us, it will be largely targeted sequencing, but we can still identify mutations like in BRAF in a peculiar tumor, which you don't normally expect to find. And then you have a drug which you can use to treat. Of course, they may not always respond as the way you think it is. Now, what about the future? Pathology and IHC remain supreme currently and will continue to do so. However, I think sequencing of TIC will become more common as cost comes down. And I give always the example of not treat a patient with leukemia now. Previously, that was not the case. Morphology was the only way. And morphology, as you just heard, from across pathology may determine treatment like imatinib or crizotinib, which are different tumor types. So future is actually, in my view, more and more sequencing will be done and will become part of the treatment. Now, I know that in this meeting, there was a discussion about having a molecular tumor board. You can have that separately, but I think it should integrate into the conventional tumor board, just like we do with pathology and phenotype for leukemia. This should be part of the whole thing. So when we come to discuss a particular tumor type, we have all the information available to make an informed decision about the treatment for the patient. With that, thank you very much. These are all people who work with me, and some have left, some are still working with me, and all my research is funded by different organizations in India. Thank you very much for your listening. And if there are any questions, I will be happy to answer. Thank you.
Thank you so much, sir. We request you to answer any questions if they're in the chat box. With your permission, we'll move on to the next session.
Sure.
Thank you so much, sir. Our next session is on thoracic oncology, and I invite our chairperson, Dr. Karthikesh K, Senior Surgical Oncologist from Coimbatore. Sir, are you there? Oh, sorry, sir. You'll have to unmute your mic again. So sorry.
Am I audible?
Yes, sir. You're audible, sir. Thank you so much for joining us, sir.
Thank you. Thank you very much. I thank the organizers, especially Dr. Krupa Shankar and his team. This is upcoming. I can see it's a very much an upcoming field, and everybody needs to update on this. And happy to be here. And I'll just finish up with one example, and then you can continue the session. Of course, we are aware of almost every surgeon will be aware of this imatinib, especially for the role in GIST. But we had to operate on a locally advanced gallbladder cancer. We gave chemotherapy as a neo-adjuvant, and then we went in. It was unresectable. Then our medical oncologists sent him for NGS, next generation sequencing, and now the patient is on olaparib for last 3 years, and he's absolutely asymptomatic, and his general condition is so well present, is almost living a normal life. So I think this would be a part of the treatment in future. So everybody should update, and it's a good effort on part of Dr. Krupa Shankar and the team to give this. And let's go on to the debate. I don't want to hold back. Yes, thank you.
Thank you so much, sir. We'll move on to the debate. Our debate is on EGFR positive stage 3 unresectable non-small cell lung cancer post-definitive CT-RT. And our first debater is Dr. M. Vamshi Krishna, who's a medical oncologist from Hyderabad. Over to you, sir.
Good evening, everyone. And it's thanks to the organizers for calling me. Just give me a second. Let me share my screen. Yeah. So like we start all our meetings, I hope I'm audible and I'm visible.
Yes, sir.
Okay, great. So I have been asked to speak on this topic of EGFR positive NSCLC stage 3. And I am going to be speaking for Durvalumab. So thanks, Krupa. Thanks a lot. You've given me a tough topic. And initially, I was a little surprised as what to say. But then, when I went when I went through all the topics and I went through it, and I realized that actually I'm doing the easier thing. I'm actually doing the easy topic. And I pity my opponent who has to do the hard work. So when we talk of stage 3 lung cancer, NSCLC, what exactly are we looking at as the base? These trials, though we often talk of CT-RT as being a curative option, when we look at all the trials, what are we actually looking at? We are looking at an overall survival, a median of around 17 to 15 months. A progression-free survival is actually only between 5 to 7 months. So though we keep talking and saying that CT-RT and stage 3 is curative, the reality does not bear out that statement. We are still looking at a disease which is actually inferior to what we see with a stage 4 lung cancer nowadays with all our immunotherapy and targeting. So having said that, in this situation, we do need something that would improve the overall outcomes of patients. And the first study, and really biggest study that has come around till now, is the Durvalumab study. Now, Durvalumab was used after chemoradiotherapy in unresectable stage 3 cancer. This is, by definition, the group of patients that I am supposed to be talking about. Now, I will not go into detail about the trial, but this was a 5-year overall survival data. Remember, 5-year survival outcomes. It is difficult to get trials in lung cancer with such long follow-up. Here, after a median duration of around 34 months, updated OS was 47 months. It's a huge time. 47 versus 29 months. PFS also 16.9 versus, look at this, 5.6 months only in your CT-RT arm, right? So that is the reality of only CT-RT. The 60-month OS is much superior with the Durvalumab arm with a benefit of around 10%. These are numbers where you really can't quibble much. When they had also a study, now this came 2 years back, where they looked at the 3-year survival and again showed that Durva is doing much better than placebo. However, at this point, they also came up with this small data saying that you should not be using Durvalumab in the EGFR positive patient. In fact, you had these kind of hype statements which said that consolidation should not be administered. On what basis was this dialogue made? As usual, the devil is always in the details. Look at this paper. Now, this is not there in the main paper. This is actually from the supplement of the Pacific trial. Only 29 patients in this arm and 14 patients in this arm were EGFR positive. So in effect, you are taking 6% of patients here and another 5% of patients in this arm. Out of your total 700 odd patients, you have 43 patients in which EGFR is positive. The vast majority is actually negative or unknown. Now, we do not know what this unknown is, being as usual as it is unknown as per definition. So the conclusion that they have made, saying that 43 patients only represented 6%, and here there was no difference between Durva and placebo in terms of PFS-OS. However, you cannot reach a definite conclusion. The nicety of putting it as a definite conclusion is hindered by the absence of suitable numbers. And yet, look at the headline. Consolidation Durvalumab should not be administered. Such a big headline based on such flimsy data. What about other papers? Do we have anything else which says, again, you have certain amount of data where you can keep saying, this is just one paper. I'm sure my opponent will show all of these to you and try to tom-tom the benefit of EGFR. But please remember, in the EGFR mutant subgroup, the PDL1, irrespective of that, there is not much difference in the outcomes when you are using consolidation Durvalumab. Again, this is a Chinese paper. And again, look at it, the data. Durvalumab as consolidation therapy in post-concurrent CTRT. PFS, yes, for the mutant and wild type, it is different. But look at this. The overall survival, again, does not really change. In effect, using Durvalumab as a consolidation therapy will not change your overall survival. And definitely with the limited flimsy data available, I do not think we can still conclude that it should not be used. Do we have anything else? We have a phase 2 trial. Now, something that we don't often talk about, the Hoosier study, it's a small study, but that also showed that your 1 year, 2 year, and 3 year OS data is pretty significant if you use the immunotherapy. So for me, immunotherapy still remains as an option post CTR. What about the other side? Let's talk of the TKIs. And for me, that really is a kind of the villain of the show. Remember, EGFR TKI in the adjuvant setting. Now, I'm not talking about ADAURA. Remember, there's a whole bunch of other papers which have come around, all of which are showing you a DFS improvement, no OS benefit in most of the studies. This, remember, is there in adjuvant resected set. Okay, adjuvant resected set. Look at the Osimertinib ADAURA trial, such a big trial, 1B to 3A, again in mutation positive trial. So where is your paper on the stage 3 unresectable paper? You do not have it. The smallest study that I could find was the Kindle study, which again showed that if there are unresectable EGFR mutant, your OS is poorer after EGFR TKI than CTRT followed by EGFR. Again, no trial to show you the benefit of post CTRT TKI. So you have the arms, the scale of Durvalumab of a phase 3 trial, small subset post hoc analysis of EGFR, no head-to-head versus EGFR, versus benefit of TKI only in resected NSCLC, only in terms of PFS, no trial of TKI in post-CTR. So till further evidence, I would like to rest my case. Durvalumab is still the key. Thank you.
Thank you so much, sir. I now invite our second debater, Dr. Rajat Bajaj, who's a medical oncologist from Noida, to present his side. Over to you, sir. Rajat, sir, you'll have to unmute your mic, sir. So can you unmute your mic again, sir?
Am I audible?
Yes, sir, you're audible, so please go ahead.
Just give me a minute. Give me a minute.
Yeah, sure, sir. Sir, if required, we can share the slides. I believe you shared the slides with us.
Yeah, just give me 30 seconds. I'm doing.
Yeah, sure, sir. Sure, sir. No worries.
ये नहीं हो रहा है। कर दिया। हो ही नहीं रहा। Somebody will have to share my slides. I think I'm not able to join from my laptop.
Sure, sir. Sure, sir. We'll just share the slides.
Yes. Good evening, everyone. I am Dr. Rajat Bajaj. I thank the organizers for having me here. And the topic of the debate that has been given to me is the EGFR mutated stage 3 unresectable NSCLC post chemo radiation. What exactly is the way ahead? And my submission in this debate is that I'm talking in favor of Osimertinib. I congratulate Dr. Vamshi Krishna for a very nice presentation of his side of the debate. But I would like to now present my side of the debate and really convince him that his side of the debate was not as what he would have liked to present. So next slide, please. So when I first saw this topic of the debate, like Dr. Vamshi said, I thought that it is the easier side which is being done by me. And actually, the next slide, the first reaction was that this question that we are asking, is it actually even a question now in 2022 when we have quite a lot of evidence suggesting that Durvalumab is not the way to go ahead? Next slide. And also, another thing that came to my mind is that if you at all we're talking about Durvalumab in stage 3 NSCLC in patients who've been given chemo radiation, are we really kidding ourselves? Next slide. And the reason why I say that is first based on my personal experience. Next slide. In which what I could find is that I've treated about 18 patients of stage 3 NSCLC till now with chemo radiation followed by Durvalumab. Durvalumab is an expensive drug, not very freely it is being afforded by our patients. Out of those 18 patients, thankfully, only 4 patients progressed while they were on treatment. We're not even talking about PFS here, but we're talking about progression while on treatment, which was an unfortunate event that happened. And I could see that 2 out of those 4 patients were oncogenic driver mutation positive, which of course we found out later because there is no consensus as to whether we should check for oncogenic driver mutations in stage 3 patients as of now. Next slide. But of course, I agree that nothing can be based on my personal experience, and evidence is something that matters a lot. Next slide. And I also agree that if you are, next slide, if you are listening to wise people, then it is definitely the right thing to do. Next slide. As of now, it may seem that next slide, that Osimertinib is trying way too hard to push Durvalumab away from the scenario in EGFR mutated NSCLC, but in the next 5 minutes, you would say that the fight will become equal. Next slide. Yeah, just a minute.
So can we request you to use, if we can show the slides, because we're running short of time, sir.
Sorry, are my slides visible?
Sir, we've shared the slides, sir, because we're running short of time. Can we use these slides only, sir? What we've already shared.
Yeah, certainly. So Durvalumab pitched against placebo certainly did better, and there were 4 primary endpoints. One was the PFS, and the other was the overall survival. Next slide, please. And we see that the PFS certainly was better. Like my opponent also very correctly described that it was 16 months versus about 5.5 months from, next slide, please, in the experimental and the control arm. And also we can see that, next slide, that the overall survival also was much better in favor of the experimental arm compared to the control arm. But the important thing would start now. Next slide. Yeah, next slide, please. The important thing that would start now is that if you look very closely into the forest plot, which is a very concerning thing for an oncologist, because this is how we come to know as to how the drug is going to fare in terms of various subgroups that we are going to deal in our daily practice. Next slide. Next slide, please. Yeah, so this is important that if you look at the EGFR mutant population, very correctly described by my opponent, that yes, there were less number of patients, but if you see, this is the only subset where the confidence interval is crossing the line of unity, and the highest value of the confidence interval is 1.6. Next slide. So this is something that one has to understand, that why only one subset of patients were not benefiting and the other, all of them, they were benefiting with Durvalumab. Next slide. Also, there are other papers which tell us about these particular important aspects. So this is the paper from World Journal of Clinical Oncology 2020, where diving deep into the Pacific is what they really described this article as, and the important points were that although Pacific trial included patients with and without molecular alterations in EGFR and ALK, immunotherapy is of a limited benefit in these patients, very clearly mentioned. And also very important is about the toxicity, which I'll come to it later as well, that in a subgroup analysis in patients who were predisposed to pneumonitis, it was seen that pneumonitis rate was higher in patients who had EGFR mutations. And the very important thing, the reason was that these patients post Durvalumab received EGFR TKIs, and there was higher toxicity in this group. Next slide. Also, if you look at the NCCN, next slide, it very clearly mentions that if we're talking about Durvalumab, then most patients in the Pacific study, they were EGFR non-mutant, but when there were EGFR mutations, there was an issue. Next slide. Next slide, please. Yeah, can you move to the next slide, please? Next slide, please. Yeah, now if you look at the other paper, which is the Journal of Thoracic Oncology 2015, and mind you, this is before the Pacific trial came. This is the impact of EGFR mutation on definitive chemoradiation in inoperable stage 3 adenocarcinoma. What are the key takeaways? So although it is a retrospective study involving about 100 odd patients, but the median PFSC was significantly lower in EGFR mutant population treated with stage 3 adenocarcinoma in definitive CTRT compared to patients who were EGFR non-mutant. The distant metastases were also more in patients who were EGFR mutant, and the brain metastasis was the most common affected site in EGFR mutated patients. And we're talking about a drug which is Osimertinib, which has got its own importance and is something. Next slide, please. So now probably the fight looks better. But are we done as yet? No, probably not. Next slide. So definitely, I agree. There are no guidelines to support. But next slide. The absence of evidence can never be termed as the evidence of absence. Next slide.
Sorry, sir. Can I request you to conclude, sir? We're running short of time.
Yeah, just 30 seconds. And if you look at the subgroup analysis, the PDL1 with the PDL1 subgroup analysis in Pacific, then the PDL1 less than 1% patients did not benefit. Next slide. And it was very soon acknowledged by the European Union, and Durvalumab approval was given only in patients who were PDL1 positive. So the guidelines can change quickly with time. Next slide. So we don't have any doubt with Osimertinib being medical oncologist with the FLORA study. Next slide. And with the ADAURA study with very impressive PFS and OS data in FLORA and very impressive disease-free survival data with hazard ratios being 0.17 in ADAURA. So there is no doubt that in ADAURA, osimertinib improved the disease-free survival, and also it led to a delay in the CNS progression as well. Next slide. So the guidelines definitely should be followed, but we should definitely keep a close touch with the reality. And the ongoing reality is that if we are using Durvalumab in EGFR mutant patients, we are probably not benefiting our patients. I've also told that there is increased toxicity if we are using osimertinib post Durvalumab, which will definitely be the case if Durvalumab is used in EGFR mutant patients, because the next available drug, best EGFR TKI, is in stage 4 is going to be osimertinib. Next slide.
So sorry, sir, I request you to conclude, please.
Yeah. So this was the last stage. So thank you so much. And I would like to humbly submit that osimertinib is the way to go in this subset of population. Thank you.
Thank you so much, sir. Because of lack of time, can I request Poonam ma'am to please give the expert conclusion? Over to you, ma'am.
Yeah, thank you very much. So both Dr. Vamshi and Dr. Rajat Bajaj have very smartly put forward their arguments for Durvalumab and osimertinib post chemoradiation. And we all accept that post CTRT, we do need medications to extend the poor overall survival, which was there without any further consolidation therapy to target the residual disease. As of now, there is no guidelines, but yes, certainly, as Dr. Rajat said, absence of evidence is not evidence of absence. But as of now, even if the patient is EGFR positive, we would still give Durvalumab, and we eagerly await the results of the LAURA trial. That is the osimertinib to be given post CTRT, and once those results are out, probably then we will have a strong the evidence to say that in EGFR mutated lung cancer stage 3 unresectable disease, we should give osimertinib as a consolidation treatment post CTRT. Thank you.
Thank you so much, ma'am. We'll now move on to our panel discussion. Our panel discussion is going to be on the topic role of adjuvant RT maintenance therapy in resectable non-small cell lung cancer. Our moderator is Dr. Ullas Batra, Senior Medical Oncologist from Delhi, and his panelists are Dr. S. Suresh. Himanshu, can you move to the next slide, please? Dr. S. Suresh, Medical Oncologist from Chennai, Dr. Nagendra Sharma, Medical Oncologist from Gurugram, Dr. Rekha Bansal, Medical Oncologist from Hyderabad. So please note, Dr. Suresh Venkata Chalam will not be able to join us. Dr. Lalit Mohan Sharma, Dr. Sumit Gupta, and Dr. Arum Mugam will try to join, sir. Over to you, sir.
Okay, thank you. And the first news about the surgeon not joining an early stage non-small cell lung cancer discussion is probably signs of things to come. So at present, I think we have who all are present. The panelists, Dr. Nagendra, I can see here.
So Dr. Nagendra, yes, Dr. Rekha, and Dr. S. Suresh.
So Dr. Nagendra, Dr. S. Suresh, and Dr. Rekha are there. Fantastic. Yes. Great. So as soon as the other people join, please let me know.
Sure, sir. And
Nagendra, I think we have made a habit of becoming a moderator and panel discussion. We should get some more roles over there, or maybe you should come to RGCI or I should come to Medanta, and I would be happy to switch places with you though. Okay.
Right.
Chala. So panel discussion on resectable NSCLC and surgeon not present. Anyway, again, as I normally start, my first reactions on panel discussion in resectable non-small cell lung cancer, and my first reactions actually went up to the Australian Open with Rafa Nadal in 2021. This is September 2021. With the Djokovic controversy, probably the controversy that the LAURA and the ADAURA and the IM Passion trials, power trials are doing. And this was probably the score of systemic chemotherapy in the final, or systemic treatment, I would say, with Nadal losing 6-2, 7-6 and trailing 4-3, 0-40. This was basically the state of systemic chemotherapies, NSCLC 2 years back, the pre-COVID era, the era when you all used to meet physically. And my subsequent reactions when I first, in the last 2 years has been like this. This hopefully would be the Nadal as champion. And systemic therapies in resectable non-small cell lung cancer is where we are looking at. So let me start about this question to Dr. Rekha. Dr. Rekha, are you there?
Yes, sir, I'm here, sir.
Yeah, hi. So Dr. Rekha, what percentage of patients in your practice present in early stage?
I would say 5.
5 patients or 5%?
5%.
Less than 5% is the right. Okay. Dr. Suresh?
Yeah, less than 5%.
Less than 5%. Dr. Nagendra, Medicity, come on.
Yes, sir. I do agree. Around 5%, sir. Right.
Around 5%. So I think there was a paper which was done by Tata, and even for them, Dr. Indra Ghai says 35 to 40%. Oh, that's fantastic. Even in Tata, I was about to say around 10 to 20% of their people actually undergo either surgery or RT. But I think with all the noise being created by Pacific and by Adora trial and all, we are actually thinking, initially when all of the patient used to come, we probably, used to treat them with systemic chemotherapies. But now with the advent of newer good treatment and very aggressive thoracic surgeons and better radiation modalities, we are actually getting ahead with more surgeries and radiation. But 5 to 10% is the realistic number depending on which center do you practice in. Now, among these 5%, Dr. Nagendra, how many patients undergo surgery? How many patients undergo RT in the early stage?
Right. So we always discuss these patients in multidisciplinary tumor boards, sir. We will take opinion from our thoracic colleagues, thoracic surgeons, radiation oncologists, and medical oncologists, obviously. So only thing is, a majority of patients, if you are working in a high volume center with the expert thoracic oncology team, majority of patients in early stage undergo surgery. But yes, okay, I do agree that many of the patients, like stage one, it is debatable that even stage 1, the responses of radiation therapy also in early stage are equivalent to surgery. So one can argue, but in a correct setting, majority times patients will go for surgery.
Especially if Dr. Arvind Kumar is there, even Dr. Kataria will fade away over there. So I think it also depends on the surgeon, if you have a very high volume, as you rightly said, a very high volume surgical team, highly expertise surgical team, they will get patients on their side. Dr. Suresh, what is your numbers on these? Amongst those 5% of people, how many surgery, how many RT?
This early stage, 75% will be undergoing surgery, and then only 25 will be for radiotherapy.
Okay, surgery for 25% for radiotherapy. Fantastic. Dr. Rekha?
So I would say, yeah, I guess most radiation over surgery, I would say.
Okay, so there is a probably more radiation oncology dependent, more aggressive radiation oncologists over there. Now that's very important now. How many of these patients are further fit to undergo further chemotherapy or radiotherapy? Let's say somebody's got surgery. So how many people are fit enough to take 4 more cycles of chemotherapy after that? I'll start with Dr. Rekha once again.
So definitely, when they were fit to undergo the surgery, with the recommended gap of 6 to 8 weeks, they mostly recover and they are fit to receive adjuvant therapy.
Okay, Dr. Suresh.
Yes, sir. If there's indication, most of them will be able to take.
Okay, and how many are able to finish the 4 courses of chemotherapy?
You're asking me?
I'm asking you, Dr. Suresh.
Yeah, they will be able to finish. They will be finishing.
Fantastic.
100% will be finishing.
Dr. Nagendra.
May I add one thing, sir? Your question is absolutely correct, but we have to define that the operability and resectability is not synonymous. The patient who is operable may not be resectable, and the patient who is resectable may not be operable.
Fair
because the operability is defined by the patient's characteristics in form of cardiopulmonary function and performance status. Resectability depends on the tumor characteristic, but it depends on the site and size of the disease. So the patient who is operable may not be resectable, and the patient who is resectable may not be operable. So it depends on correct clinical setting and correct assessment.
So let us say a patient who is both operable and resectable, how many of them then get chemotherapy? And eligible patient, node positive, more than 4.5 centimeter. How many of them are fit enough to get chemotherapy and are able to finish all the 4 cycles? Dr. Nagendra? Okay, so I think till the time you get over there, we did a study and only 60 to 70% of all our patients who actually undergo surgery ultimately undergo chemotherapy, and people who start chemotherapy also are not able to finish. More than 90%
of patients which I have seen, right. So
yes,
majority of the patients, majority of the patients are who are having fitness to undergo surgery upfront. They are having good performance status, and if they are resectable and operable both, majority of them are able to undergo adjuvant chemotherapy, the planned 4 cycles. Right.
Fair enough. So Rekha, do you agree that maintenance therapy is an unmet need in early stage, or you think surgery and 4 chemos are good enough?
I would say we need maintenance therapy at least definitely there is a need, sir.
Fantastic.
Fantastic.
So Dr. Suresh, now let us say in your less than 5% of people, people have undergone surgery and they are staged as T2, N1, M0. In an early stage post-surgery, what all biomarkers do you test for in an early stage resectable non-small cell lung cancer? You test for EGFR, PDL1, EGFR ALK ROS. Do you do NGS for everyone or any other strategy that you use? This when you do post-ADAURA.
Yeah, maybe a year back we just restricted to EGFR, ALK, ROS, and PDL1. But now
so
with support programs, we going in for the 12 gene panel test, and then sometimes NGS for all patients.
Okay, so in an early stage lung cancer, you will still do?
Yes, sir. We will do.
You will keep it. Fantastic. Okay, that's nice. That's something that okay, fine. Dr. Rekha.
So the Alchemist data is yet to come, but with the available data, we only have drugs for only 2 targets. So I guess I would test only EGFR. It's good to have extra information, but then we know that tumors evolve over time, so mutations might change. There's no use of additional information right now. So EGFR and PDL1, I guess. Yeah.
So EGFR and PDL1, the first and the second one. Nagendra?
Yeah, I do agree, sir. As my co-panelists have told, that Alchemist data is still yet to come. We are moving towards a race of horses for horses. If you are having EGFR positive, start Osimertinib. If you are having PDL positive, chemotherapy, all these things are there, but right now the data is not mature enough. We are moving towards that. But if you ask me, as of now in your clinical practice, to be honest, what we are doing, only EGFR and PDL, majority times we are able to do. Although there are patients in which coupon testing is available, which is available like limited gene panel, where one can argue for that. But as of now, EGFR we are restricting also.
So I think I also will belong to the Rekha and Nagendra point of view. And in fact, I am all for knowing wherever do you stand. But in fact, in the early stage, I'm actually happy not knowing, whether they are RET positive or whether they are ALK positive. Because one of the major problems is somebody turns out to be ALK positive. And then you don't give them Alectinib or Crizotinib. And then the disease comes back and then the patient will look at you with a very shady eyes, So I actually don't do and actually do just EGFR and PDL1. It also helps us that we are having a lot of clinical trials going on. So, a lot of people go into the clinical trials. So maybe that is why we don't really think much across. But at present, I absolutely agree. EGFR PDL1 is the way to go. So let's talk about the elephant in the house. And the elephant in the house is not me. Elephant in the house is actually the ADAURA trial. So let's talk about the ADAURA trial. When I searched about the ADAURA trial, they were, the word seems to be divided. There are certain people who said, is it time to implement adjuvant targeted treatment? There are certain people who feel that it is not yet time. There are certain people who feel that Osimertinib should be the standard of care. There are certain people that Osimertinib should not really be the standard of care. That word is absolutely divided into 2. So which side do we belong? We will find out in the next probably 15 minutes. So again, Dr. Suresh, your comments about the trial design, the duration of treatment, and the primary endpoint with the DFS is good enough. Dr. Suresh.
Yeah.
So your comments about the trial design, are you happy with the trial design? Or predominantly, let me ask you one particular question. What about the primary endpoint of DFS? The OS was not the primary endpoint. Are you happy with the primary endpoint?
No. This is a completely resected stage, so I would like to have an OS as a primary endpoint.
So not very happy with the primary endpoint and only DFS. Actually, you basically want an OS. Fantastic. Dr. Nagendra?
Sir, in adjuvant setting, no doubt about that we are all chasing overall survival. this trial, DFS was the endpoint, but over a period of time, when the data is more mature enough, maybe we will be happy to use it. But if you ask me per se, I'll be happy if the trial is positive and overall survival benefit is there. Ultimately, we want our patients to live longer, isn't it?
So don't you want your stage 4 patient to live longer with that? So why is DFS okay with them? Why
Right.
only stage 1, 2, and 3 patient this debate?
No, not only stage 1, irrespective of stage, we want to keep this patient as good as possible for as long as possible. And in the early stage, majority of times, intent of treatment is curative. So if patient has achieved cure, they want to stay cancer-free throughout their life. So that's why I'll be happy if overall survival is the primary endpoint.
Have you shifted over to Olympia in BRCA mutant triple negative breast cancer, Dr. Nagendra?
Yeah, you're talking about triple negative carcinoma breast, right?
I am talking about triple negative carcinoma.
Yeah. Yes,
was there an OS advantage?
No. There was no OS advantage. There was
Did you wait? Did you give neo-adjuvant chemotherapy Perjeta 2 years back? You gave. I saw your prescriptions on Medanta.
Right. Right.
So we I think we are being so fair enough. But you actually agree that we should wait for the more mature data, but DFS also can be used as a point. Dr. Rekha, what is your take on this? DFS good, DFS bad?
No, so DFS is not good enough, though the hazard ratios are impressive, but not necessarily that this will convert to OS benefit. Also, the trial was discontinued early and the early unblinding of the trial was done. I wish that did not happen. Then we would actually have OS data. There are certain other criticisms also with regards to the way the trial was conducted. The imaging modalities that they used were not uniform. The PET CTs and MRI brains were not done for all the patients. So we don't know whether we were actually treating a micrometastatic disease early on or So yeah, not happy with the endpoint.
You seem to be reading that JAMA article by Howard West. No, the trial we wanted versus the trial we got actually over there. Fair enough. And that's some really fair points. So there are concerns with the DORA. As everybody said, DFS versus the OS endpoint, whether the TKIs are causing a dormant disease versus the inducing apoptosis. The baseline imaging, as Dr. Rekha very rightly said, was not done properly. Not everybody got a PET scan with MRI. Is chemo necessary in adjuvant setting? That is also one big point. And how did you come at a magical figure of 3 years for Osimertinib? Let us see. Let us just look at for some data basically. One more question. This is to Dr. Nagendra. On a very scientific rationale, have TKIs shown to increase overall survival in adjuvant setting in any other malignancy? Your take. Do you believe that the place of TKIs is in stage 4 and others and not really in stage 1, 2, 3?
Yeah, in other malignancy also there is no, as of to the best of my knowledge, there is no trial in which only Olaratumab in sarcomas, there was a phase 2 trial which was positive, but later on it was withdrawal, phase 3 was negative. So that was the only trial. Otherwise, TKIs have not shown any oral
except for Imatinib and GIST, which was 3 years, and Dabrafenib Trametinib in melanoma, which is also shown to be having some improvement. So there is some rationale of using. Let us not be very harsh on Osimertinib also, but there definitely, as you very rightly said, there are very, very much concerns over there. So this was the DFS data, which basically showed, the graph is huge between the two, the graph separate early. The secondary DFS endpoint, this was the endpoint, people who got chemotherapy versus people who do not get chemotherapy actually. So I'll just I put the pros and cons into what I think about it. It's got a very impressive DFS benefit. As was the previous debate about going on, it crosses the blood-brain barrier. The 5-year DFS is better than the 3-year OS, which was conventionally seen actually. The tolerability was well, only 11% patient had discontinued this is Osimertinib. The cons, as Rekha very rightly said, the PET CT and MRI was not done. DFS, we don't know whether the good marker, bad marker. No OS benefit as yet. Not everybody got chemotherapy, and the financial toxicity definitely is there. So we definitely have to ponder. But I am going to discuss something more further. So let's go to this, Dr. Rekha, in your practice. Tomorrow, if patient cannot afford Osimertinib, will you try with first or second generation TKIs? in the adjuvant setting?
No, sir, we don't have the data. The SELECT, IMPACT, and all the other trials were not looking at this question. They were comparing gefitinib with chemotherapy. So I'm not convinced. I mean, I would want a trial to be conducted.
You would not want, if it is either it is osimertinib or it is nothing. That's far as you are concerned. Fantastic. Dr. Suresh?
So you'll have to unmute your mic, sir.
Dr. Suresh? Okay, I think we seem to have lost him. Dr. Nagendra?
There's no data for first generation or second generation TKI as of now, sir. Osimertinib is the only viable option, but we have to tell both pros and cons to each family or the patient.
Okay.
Because cost is obviously an issue over a period of time. Maybe initially this is affordable, but over a period of time, patient will get financially exhausted and it is not financially sustainable, right? So
fair enough.
This is what happens majority times.
So what about, this is for only two of your remaining here, Nagendra and Rekha. So I think we'll have to make away with you only unless Dr. Somani and the next debaters want to pitch in. What about the KN regimen? I have now got a new regimen over there, not the Keynote 189. The KN regimen is the Kumar Naroha regimen. Why don't we start with gefitinib and chemotherapy followed by this? What is your take on this?
Yes, sir, definitely.
Okay.
I mean, it's an option. Yeah, I would consider this in a fit patient, sir.
So you would consider KN regimen which has not been tried, and poor osimertinib which has been tried, you don't want to try. Fair enough. Dr. Nagendra, your take on this?
Carefully selected patient, yes. Not in all patients, sir.
And where is the evidence, Dr. Nagendra, for that?
Obviously, this is our Indian trial, right?
Okay, but it's the KN, no? That the surname KN, the KN regimen actually counts over there. Okay, Kripa Shankar is asking a question. I'll come to you, Kripa Shankar, on that.
Dr. Ullas, Dr.
Yes,
Ullas,
sir.
Good evening, and sorry to interrupt in between.
Sir.
We all know that it's only the osimertinib which has shown the results so far, and not the erlotinib or the first generation, and the second generation probably in the same context has not been attempted in that way. So I think it will not be fair to go for the KN regime. It's a good regime for our patients, maybe the cheaper, giving the equal results, something like minimum at least to the second generation drug like efatinib, if not like osimertinib. It's better than the first generation drug in combination. But in this context, probably it will not be fair enough. And if Dr. Ullas Batra recommends this, then we have to think about it. Because the message may go in a wrong way.
No. Sir, I don't recommend KN regimen in stage 4 cancer only, sir. Where is stage 1, 2, 3? Okay. I'll show you some data actually in the next slide, sir. Again, Dr. Rekha, will you skip chemotherapy and give only TKIs osimertinib?
Chemotherapy is the only thing which has actually shown survival benefit. But if the PS is not good, then
osimertinib. Patient says, is it going to drive away chemotherapy?
Sorry, sir?
Is adjuvant osimertinib, let us say tomorrow Naresh Somani starts selling osimertinib at 10,000 rupees per month. He's rich, he can afford, if he starts selling this thing at 10,000 rupees per month, patient's PS is not good. Will you give?
Certainly, sir, because in ADAURA, not all patients received chemotherapy.
Okay, fantastic. Okay, Dr. Kripa, what about neo-adjuvant TKIs? We are coming over there. What about other biomarkers? We will come to that. So these are uncomfortable questions, and I understand these are uncomfortable questions. I just show you, I did plan to have some more discussions, but I think we'll stick on to only ADAURA. So these are the 4 major trials which have been there. The first trial was the adjuvant CTONG trial, which compared gefitinib versus chemotherapy. Now, please remember, this is what the first generation that we all were talking about. Osimertinib was after chemotherapy. This trial in 2015 was much ahead of time. There was a DFS advantage. The HR value basically was only 0.79. However, there were no OS advantage. So first generation TKIs, there is no OS advantage. There was a DFS advantage. This was given for 2 years. And then it basically, the DFS advantage frittered away. This was the ADAURA trial. Now, this is where I feel the pemetrexed carboplatin adjuvant chemotherapy with or without gefitinib, the third one. And this basically is the KN regimen, what I basically call as, which was 6 months, this thing was there. The HR value is positive over here. The HR is 0.37. Small study, but this is a study which is actually may worth be doing the KN regimen. Dr. Somani, I am not yet recommending this regimen, but KN regimen, I'm sure Kumar will have one ace up his sleeve. He will show us some data about this over there. Now, this was the neo-adjuvant study, that is the neo-ADAURA study, or the the study which again we are having with us over here in Rajiv Gandhi. And this again, this is a very important study which I wanted to show everyone over here. This study was negative for the overall response rate. So please remember, if you give EGFR TKIs in the initial study, this study basically was actually negative. However, this was positive for the DFS. HR was 0.39. Having said that, I do not want to give away the message that Osimertinib should not be recommended as an adjuvant setting. I would stick my neck out and said, if somebody has money, and I have started offering adjuvant EGFR Osimertinib for 3 years to everybody who can afford, because Osimertinib is not Gefitinib. Please remember, if your HR value, look at the first one, the adjuvant CTONG, the DFS HR was 0.56. Here it is 0.17. Just because Gefitinib did not work in the first 2 years and it stopped over there, Gefitinib also did not cross the blood-brain barrier. So maybe that is why it did not work. There were higher incidence of CNS penetration, CNS metastasis in patients who got Gefitinib. So probably we obviously should wait for the overall survival data, but it is a drug which needs to be offered to patients. Definitely in today's 2022, if somebody has got a surgery and got 4 cycles of chemotherapy with or without EGFR mutation, you should be offering adjuvant Osimertinib over there. One more question, I think Rekha, you asked was early unblinding. This was ethically not right for the patient, for the trial people to, when there is such a difference of HR point for this thing, the early unblinding had to be done. It was an FDA requirement. So this was how to answer awkward questions with confidence. And this is not me who is answering them. This is going to be Dr. Kumar Prabhash and answering to Dr. Amish Vora and me asking questions to them in Oncology Beyond Obvious, April 2022. So we're going to have a session on ADAURA, whether to adore or not to adore. Until that time, I think we'll have to wait. We'll have these debates going on. But to me personally, not recommending KN regimen as of now, not recommending first generation, second generation TKIs, definitely counseling my patients for 3 years of adjuvant Osimertinib. And I think that was the end of, we had more discussions also over there, but I don't think we are going to discuss that. And that was it. So this is my last one slide. Adjuvant treatment, maintenance therapy in early stage lung cancer. We have taken a small step, but a journey of small step from 1,000 miles actually begins with a single step. Thank you. Thank you, Dr. Kripa Shankar, for the invite. And I hope I gave some useful, I was found to be some useful. Thank you.
Thank you so much, sir. And thank you to all the panelists as well. We'll move on to the next session. The next session is debate, role of neo-adjuvant ICPIs in resectable non-small cell lung cancer. And our two debaters are Dr. Suman Kalyan, medical oncologist from Chennai, and Dr. Deepak Koppaka, medical oncologist from Hyderabad. So I invite our first debater, Dr. Suman Kalyan.
Good evening to one and all. So I'll share my screen.
Can the organizers start sharing the screen if he is not able to share it?
Yeah, I'm not able to share the screen.
No, no issue, no issue. From the back office, somebody can do the job.
Yes, sir. We'll just share the slides.
Hello.
Sir, have you shared the slides with us, sir?
Yeah, one thing I'll do is I'll resend the slides.
Yes, sir. I don't think you shared the slides with us. You'll have to share it on your screen, sir.
Can my next speaker carry on?
Yeah, so we'll
No,
ask,
no. That, I don't think that will be the nice, because the pros would be there. Yeah,
Okay.
so I mean, the debate, it's not nice to change the sequence. We'll wait for a few seconds.
So can you share the email? We'll share.
Meanwhile, we can continue to have the wisdom of the Dr. Ullas Batra.
I was saying, sir, मैं debate कर लेता हूँ.
We don't want beyond the obvious. We want the obvious things.
No. So my take on that was, I also did have discussion on the adjuvant immunotherapy. And on adjuvant immunotherapy also, sir, it was shown in that slides that there was no benefit of adjuvant atezolizumab in patients who had EGFR mutation or a biomarker. So I think we need to understand that people who are biomarker-driven NSCLC, they do not respond as well to immunotherapy. Single agent, definitely. Combination, they may respond later on, but they cannot be the first line of treatment for that. So that was my take on that.
So Ullas sir, as usual, great panel and loved it. Just have a question to you. So if your patient can't afford osimertinib in the adjuvant setting, would you try first generation TKIs?
I won't actually. So if you ask this question to Kumar will, and I will not. So there is a difference in the way we work. See, he works in a government. So I'll tell you why you should offer. The 5-year survival over there was, I think, around 40-50%. The median OS was highest around 70 months. This has never been achieved in a early stage resectable non-small cell lung cancer trial. But the point is, I work in a setting where you need to be more evidence. It's not that he doesn't need to be. We are more apt to scrutiny. So that is number one. Second, my point over there is, if somebody develops a brain mets, then what will happen over there? The data for OS is not there. Then why expose a patient to a toxicity? So ultimately, we cannot have, see, for osimertinib, you want OS data, which is not yet there. For gefitinib, there is no OS data and that you want. So we cannot have double standards, in the same breath for two different drugs, just because gefitinib is cheap.
Sure, sir. Got your point. But the only thing is that probably the adjuvant study was underpowered. It was only around 200 patients.
But that's
the
all
primary
that you
endpoint.
Have. That's all that you have.
Correct, sir. And the primary endpoint was only DFS. They did not. Yes. They were not powered adequately to look at overall survival. Yes. So and despite that, probably you can say it was not statistically significant, but 78 versus 66 months probably is new. I mean, like probably clinically meaningful.
So the greatest point against the first generation is that the CNS penetration is poor.
Blood-brain barrier.
So that will I mean, truncate all the benefits the DFS ultimately, in contrast to the third generation.
So if you look at the sites of relapse, there were more brain met relapse over there. And honestly, seeing people with brain mets having radiation therapy and everything, this is going to become a bit difficult. So I think I am a more conservative as far as when the medicines come. If it is there, it is there. If it's not there, it's not there.
It's something like making them selectively having the brain metastasis, something like that.
Which may not be the right thing to do.
So Dr. Suman Kalyan, are you ready now?
Yes.
Yes, so we've received the slides. We'll just are opening the slides and we'll just share it on the screen.
So the 1 minute of the Suman Kalyan will be cut down.
Sure.
Sir, isko neo-adjuvant yes bolna hai na. He doesn't need 1 minute also, sir. He just has to show some NADIM data. He doesn't need more time.
So he needs only 1 minute.
He doesn't need any minute.
One slide is enough. You can see
opponent. Yeah. Okay. Go ahead, please.
Sir, good evening and sorry for the delay. I think my computer updated, and so this is the update. Neo-adjuvant immunotherapy in resectable NSCLC. Do we give? I think yes. I'll just present the rationale and the guideline for that. Next slide. So what is the rationale for giving neo-adjuvant immunotherapy in a resectable lung cancer? So whenever we think of resectable lung cancer, first thing we think is simple surgery. So what are the results with surgery? Next. Result is this: 25 to 70% of people recur and die when we do surgery alone for resectable lung cancer, any stage might be. So 70% that what we do next is we think of chemotherapy. What chemotherapy we give? Mostly cisplatin based chemotherapy. Next. So when we add cisplatin, what's the extra benefit? How many people you are going to save is 4 to 8%. So 4 to 8% people, 4 to 8% is the overall survival benefit when we add chemotherapy to resectable lung cancer at the end of 5 years. So next, moral of the story is, despite surgery and adequate adjuvant therapy, about 20 to 30% of people with stage 1 die, 50%, that is half of them with stage 2 die, and 60% with stage 3A again die within 5 years. So there is a large unmet need when we use surgery and chemotherapy. That will be the rationale for adding immunotherapy to this subgroup. Why immunotherapy? Next. So 15 to 20% survival benefit is there in stage 4, which is well established with different immunotherapy molecules. So that we can take as a rationale. And then even in stage 3, we have this study Pacific, in which unresectable stage 3, the overall benefit, overall survival benefit is 10%. Remember that it is more than chemotherapy. Next. So based on this, exciting data from immunotherapy has already put its strong hold in adjuvant setting. So whenever we have lung cancer, stage 3, stage 2, we do a surgery and then we give adjuvant therapy. In adjuvant therapy, adding immunotherapy is very valuable, as is seen in all these trials. So we have all the big molecules here: pembrolizumab, durvalumab, nivolumab, and atezolizumab. All these molecules are added as an adjuvant therapy. So this is about adjuvant. So whenever we have something which is already proved in palliative setting, next comes adjuvant, and next we come to neo-adjuvant. That's how drugs get approved. So next we have the neo-adjuvant. Next slide. So regarding neo-adjuvant immunotherapy, so these are all the trials. So we can see that neo-adjuvant has been tried in nivolumab, as in nivolumab, atezolizumab, nivo-IP combination. So we have so many trials in which the one thing that to be noted is the endpoint. So the primary endpoint for immunotherapy will not be an imaging thing, because we know that after immunotherapy we don't have a RECIST, we cannot put RECIST criteria for the same. So for any neoadjuvant setting, if it's chemotherapy, we know it is PCR, pathological complete response. But for immunotherapy, it is MPR, which is major pathological response. Why they use this is immunotherapy is totally different. So up to 10% of viable cells is accepted to define this new criteria of major pathological response. So that's how the endpoint of all these trials are there. So this is about neoadjuvant immunotherapy. This is both resectable and unresectable put together. Next slide. So this is about our topic, that is neoadjuvant immunotherapy in resectable lung cancer. So we have students here. We will leave alone the phase 1 and phase 2 trials. Next. So sorry, slide before. So if you take only phase 3 trials, we have all the 4 molecules, namely pembrolizumab, nivolumab, atezolizumab, and durvalumab in the neoadjuvant setting. So all these are phase 3 trials. So these trials, the results, yes, they have not come. But then the endpoint, if you see, we have OS, we have EFS, we have PCR, we have MPR. So these are exciting times in which we're going to use neoadjuvant immunotherapy in these settings. So current approval, no, it is not there. Next slide. So ideal thing is to wait for overall survival benefit in a curable setting, that we already know. But what the smart man does is you take MPR, that is, major pathological response, that is 10% at least viable cells as a marker for getting an overall survival benefit. Of course, trials are already ongoing. Major trials are there with all the 4 molecules. So when we use MPR and use these drugs in the neo-adjuvant setting for resectable, we gain an advantage of approximately 2 to 3 years in which these trials will come out and people will start using. So that's what is my debate for using, or at least thinking of, immunotherapy in the neo-adjuvant setting. So when most of the trials, if we see, it will be chemo with immuno. Where do we use only immunotherapy? It's in these people who are medically unfit. 50% of our patients are medically unfit even before we start treatment. So these are people who will benefit from immunotherapy alone. And any T size which is less than 4 centimeter, they're not going to receive chemotherapy. It's not indicated. So these people also, we can think of giving immunotherapy alone. And always we talk of cost. Cost is a judgment call, because we do have all kind of patients. So cost is the issue. Then something we can do is give only neo-adjuvant. And if they receive, a major pathological response, put them on a clinical trial in which half of them will be not receiving any therapy and the other half will be receiving therapy. So that may be the answer in the future. So if you ask me if neo-adjuvant therapy...
I request you to conclude, sir. We're running short of time.
Yeah, thank you.
So thanks, Dr. Suman. And now I invite Dr. Deepak to counter the neo-adjuvant immunotherapy in resectable NSCLC.
Yeah. To begin with, I would like to thank the organizers for giving me this opportunity. So, just a moment. Yes. So, I'll be talking about the role of neo-adjuvant immunotherapy in resectable NSCLC. So, the 2 points here: neo-adjuvant therapy and resectable lung cancer. So, we're not talking about the borderline resectable lung cancers, the multi-session N2s, or the adjuvant role of immunotherapy. So, it's going to be neo-adjuvant and resectable therapy. So what is the current role, and does this method or this way of giving treatment hold any future? So current role, when I was given this topic, I was a little surprised. I was not sure of any recent US FDA approval consisting the rapid US FDA approvals we're seeing over time, or any new phase 3 study as such in this domain, which has shown that there is benefit of neo-adjuvant immunotherapy per se. So I was a little surprised. So we don't do it in regular practice, and neither was I aware of any data which has come in the recent past. So I've gone back and I've dug into the data on seeing where does this really stand. So before going ahead, the questions which I had in mind was, why do we really need neo-adjuvant chemotherapy? We're not trying to preserve the lobe. We will be eventually doing a lobectomy, segmentectomy, might not be really done in most of our patients. What do I give? Do I give immunotherapy alone, or should I combine immunotherapy plus chemotherapy? What is the role of adjuvant maintenance immunotherapy? So if I start a patient on neo-adjuvant immunotherapy, should I continue that post-operative like pertuzumab in breast cancer? And when I have adjuvant immunotherapy approval, the TISO data based on the IM POWER 010, why am I even talking about the neo-adjuvant IO? Was the questions which I had to establish the role of, not to establish the role of neo-adjuvant immunotherapy in the current practice. So we all know it targets micrometastasis. It helps giving systemic therapy upfront will see that patient compliance is better. This is not routinely seen. Decreased tumor size is not that we routinely see in practice, which I'll tell you in the future. And decreased surgical seeding is not a problem in lung cancer. The cons of giving neo-adjuvant chemotherapy is you delay the most important step of treatment in early stage lung cancer. You hardly see 10 to 15% of early stage lung cancer in practice. And if you do not do surgery, and if this patient falls in unfortunate 20% patients who progress during neo-adjuvant chemotherapy or because of the side effects of neo-adjuvant chemotherapy or immunotherapy, you lose an opportunity of curing this patient. So coming to chemotherapy per se, there were multiple phase 3 trials for highly locally advanced disease where neo-adjuvant chemotherapy was tried. Most of them failed. And later, a meta-analysis published in 2014 in Lancet showed that there was approximately 5% benefit when neo-adjuvant chemotherapy followed by surgery was compared to surgery alone. So if you're not giving any kind of therapy, it's better to give neo-adjuvant therapy. Now coming to the role of neo-adjuvant immunotherapy, single agent therapies. So there was a big hue and cry when the NEJM article in 2018 showed that giving 2 cycles of nivolumab caused a 45% MPRs. Now, MPR is a very vague definition. I'll come to that later, but 45% major pathological response was never heard of. And surprisingly, this stands out even today compared to the other trials. And the latest was the UNESCO study, which was discussed in the ESMO 2020. And this study was closed early because of the untoward side effects seen with neo-adjuvant Durvalumab. How many cycles? Again, that's conflicting. It varied from 1 cycles like the Princeps study to 2 to 3 cycles like in the UNESCO study. Now, what about neo-adjuvant immunochemotherapy? Fine. The NADIM study showed a PCR rates of 75, nearly 70%. So more than 2/3 of the patients when receive neo-adjuvant chemotherapy plus immunotherapy have pathological complete response and a major pathological response to the tune of 85%. So this is never heard of. So why not all patients go on neo-adjuvant immunotherapy chemotherapy will be the further discussion. So definitely after this, we know there is no role of single agent neo-adjuvant immunotherapy. If you have to give neo-adjuvant immunotherapy, combine it with chemotherapy. Now, do you have a phase 3 study to substantiate this? No, we do not have a published phase 3 data saying that neo-adjuvant immunotherapy plus chemotherapy has shown any benefit. How do you go about after surgery? Do you put them on maintenance therapy? The only results which are out are the Checkmate 816 data, and even in Checkmate 816, no adjuvant immunotherapy was given. Probably the Keynote 671 has OS as one of its co-primary endpoints. This will answer the benefit of giving adjuvant immunotherapy. So now when you have data coming from the IM power 010 saying that in patients who have PD-L1 more than 1%, a hazard ratio of 0.6 is like a 34% risk reduction of disease progression, why do we even consider giving immunotherapy in the neoadjuvant setting? This brought in a significant change in the thinking, Checkmate 816. Now, once you go back into the study design of Checkmate 816, we see that it was compared to chemotherapy versus nevo-chemo. It should have ideally been surgery followed by adjuvant chemotherapy or immunotherapy versus neoadjuvant chemotherapy and then surgery to have really shown an event-free survival advantage when comparing neoadjuvant versus adjuvant immunochemo combination. But even in this study, they've seen that though the phase 2 studies have shown significant major pathological response, like the NADIM study showed a major pathological response to the tune of 85%. In this study, a phase 3 study showed a complete response rate of 24%, in contrast to the 75% complete response rate seen in the NADIM study. And the major pathological response was to the tune of 50%. And in chemotherapy, only a 2% pathological complete response was seen. But when you go back to the study, what you see is in patients who receive neoadjuvant chemotherapy, you're denying surgery in around 25% of the patients. If you combine neoadjuvant chemotherapy and immunotherapy, even with the high side effects, probably more patients eventually end up undergoing surgery. But even then you miss giving surgery, the most definitive treatment in 20% based on the Checkmate 816, which is the only prospective randomized phase 3 data we have in this domain. So you eventually miss surgery in around 15 to 20% of the patients, though you have a very good pathological response. Now, currently, why neoadjuvant therapy? Because something is better than nothing. Would you give neoadjuvant immuno or immuno plus chemo? Definitely immuno and chemo. If I even have to give it in practice, what is the role of maintenance therapy? We really do not know. Neoadjuvant or adjuvant, definitely based on the current approval, go ahead with adjuvant therapy if you have a choice. Now coming to in the future, paradigm change. I'll be very quick here. There are no biomarkers which have shown substantially consistent results. All biomarkers in studies have shown variable results, both the PD-L1 and TMB. Choice of immunotherapy is highly varied. I would caution with Durvalumab because the UNESCO study showed that Durvalumab had caused significant reactions with single agent alone rather than in combination with chemotherapy. Timing of surgery is not consistent. And remember this, these patients, though they respond to treatment, do not have radiological response. This was from the NEJM article in 2018. The tumor size more or less is the same, but they have significant necrosis when seen under the microscope. The pathological response criteria are very heterogeneous. You have one, the ISCLC criteria, one, the immune-related pathological response criteria. I'll not go into the depths of this, but just to know that even this criteria has not been streamlined. So the future role is uncertain. The choice of biomarker is uncertain. Choice of neoadjuvant immunotherapy drug as such is uncertain. When do you do surgery after neoadjuvant immunotherapy is uncertain. And also, how do you evaluate this patient before surgery and post-surgery is also uncertain. So it's really difficult to position neoadjuvant immunotherapy in lung cancer currently. And yeah, I would rather choose plan 1 than plan 2. Thank you.
Thanks, Dr. Deepak, for wonderful presentation and giving insight. So we would like to give 1 minute again to Dr. Suman if he wants to say something in favor of the neo-adjuvant ICI. Dr. Suman? So if there is no point, what I understood from both the presentation and with the failed data of the adjuvant ICI so far, and looking at the pathological response and the radiological response, and without knowing at present that what can be the role of the pathological response in case of the NSCLC, contrast to the disease like the breast cancer, as on today in our clinical setting, routine clinical practice, probably the ICI alone or for the chemo plus IO combination in resectable NSCLC is not the favorable option. Those patients who are not fit for the chemotherapy, probably they are not fit for the surgery also. Though radiologically it may be the resectable. So probably there is no point of thinking them as the neo-adjuvant IO. They may be the candidate for the neo-adjuvant, they may be the candidate for the single agent IO, but not to call them at the neo-adjuvant IO. Because if they are not fit for chemo, probably they are not fit for the definitive surgery also. So with that, I would like to go back to the organizers. Thank you.
Thank you so much, Naresh sir, and thank you to both the debaters. We'll move on to our last session for thoracic oncology. It gives me great pleasure to introduce our speaker, Dr. Ashish Singh, a medical oncologist from Vellore, and he'll be talking on the topic approach to the patient with driver mutation negative stage 4 non-small cell lung cancer. Over to you, sir. Ashish sir, can you hear me, sir? No?
Yeah, hi. Sorry,
Hi, sir.
I hope I am clear. I missed the last few minutes
No,
because my
sir,
connection wasn't
please
good.
go ahead, sir. It's your session.
I'll go ahead with my
Yes,
typing.
yes, sir.
Okay. So thank you for the invitation, the MOSCON team, Dr. Kripa Shankar, and all the chairpersons for this session on lung cancer. Now we are just following a debate on immunotherapy, immunochemotherapy in early lung cancer, and I'm excited to share with you my perspectives on treatment of, or rather my approach in driver mutation negative advanced non-small cell lung cancer. Now, if this topic, when it came to me, I was wondering initially, if this same topic was given to me a few years ago, we would have just talked about chemotherapy, and we knew that the outcomes were not so great. Now, before I get into what do we do with a biomarker negative patients, I would probably I was thinking what is an optimal panel, right? So when would you call somebody actually biomarker testing negative? This is after a whole exome sequencing or after a limited panel NGS panel or a PCR panel. And we all know that if you dig deeper, the more the number of genes you look at, the more chances that you will find certain driver actionable mutations, and whether they are the driver mutations or not, that's open to debate. But on your left hand side, you see a list of gene mutations for which we have good treatment available, and some of the ones, especially the KRAS and all, the treatment, I would say, is still in its infancy. Especially with the newer drugs, the median PFS is not as impressive as what we would expect. We have actually begun to expect with things like EGFR and ALK TKI. Initially, the bigger challenge we face when we see patients is that we don't have all this information right within the first few days. And when we do PD-L1 assessment, and we all know why we do PD-L1 assessment, because the entire landscape of patients are we try to divide them into high PD-L1 expressors, intermediate, or PD-L1 negative. And the reason why we try to do that is because you're all aware that there are different combinations which we can try. One of the very important things sometimes we find is that many of the driver mutation positive patients also have high PD-L1 expression. So therefore, whenever we discuss, especially treatments like immunotherapy, we know that they do not have any major, they do not add too much of benefit especially in EGFR and ALK positive disease. So we should not be using these drugs unless we are very sure that these mutations are not there. And so very often we tend to begin the chemotherapy, especially with high volume disease, and make the decisions about adding immunotherapy agents and at a later date. Now, when you want to add an immunotherapy agents, you can do actually three things. One is you can give an IO agent on its own. You can give an dual IO or an IO-IO combination, or you can do chemo-IO combination. And if you see the different trials which have come out, they're all gunning for one thing. They all want to be the preferred option in the NCCN guidelines, and that's how the Western world operates. But here in our practice, what do we do? I mean, approvals is one thing, science is one thing. What do you do for patients sitting in front of you is another thing. So now let us see how good single agent IO is, and this is the first time, especially in this trial when it was Keynote 24, we saw that when all the patients had very high expression, that is more than 50%, your median overall survival was 30 months, and this is pretty impressive. And this median OS of 30 months was in spite of a very poor PFS of about 7.7 months. So what does it mean? It means that it's not that these patients were taking this drug for a very long time. It's just that the initial therapy with an IO agent, Pembro here, did result in a sustained benefit. And this is actually the holy grail of immunotherapy. A lot of people are trying to find out what drives this benefit, even and I think this benefit is even present beyond even after you stop giving immunotherapy. And now people are saying that if you look at the tumor, look at the receptor expression and the drug level, the drug is found on, especially even on your immune cells for a very long time. Now, so buoyed by the success of this single agent Pembro, the company decided to do a trial for all comers. They took the bar down to 1% of PD-L1 positivity. And then the results of Keynote 42 showed that even though those patients did not do very poorly, but if you look at in the overall trial, where these are very characteristic curves, and you see the curves are crossing each other. That's because initially those patients did not do very well, and once you kind of added chemotherapy, maybe in later lines, then kind of the survivals kind of caught up. So the benefit is not so impressive with single agent IO if you are not a high PD-L1 expressor. Similar trial at around the same time was designed by BMS, where they were looking at Nivo-EP, chemo, or Nivo alone for PD-L1 positives. And for a PD-L1 negative patient, they cannot have a IO alone arm, so they had Nivo plus chemo arm. And what we saw that in the PD-L1 positive patients, even a chemo-free regimen to begin with does not necessarily mean that your overall survival is going to be poor. But if you see here again, the green line kind of remains below the blue line, or at par with the blue line, especially in the initial few months. And here, and especially so if you are a low PD-L1 expressor. So here, if you see at the green line catches up with the blue line only at around 1 year. But having said that, just because you are PD-L1 negative does not mean that you will probably not benefit from these agents. And the response rates with EP-Nivo of 35.6% is pretty good, pretty impressive, I shall say, and which is not very different with what the response rate you've got with chemo alone. This is only for PD-L1 more than 50%. So if you have a more than 50% expression, I would say you could use Nivo or Pembro or Nivo plus EP. Now, what is the additional advantage of adding EP in PD-L1 more than 50%? Actually, there is probably no additional advantage of adding EP. So there's a trial which looked at EP Pembro and found there was no difference. So the EP probably contributes mainly for low PD-L1 expression, and that is where it should be placed. Now, we have Nivo and Pembros. So similarly, we also have a lot of other Me-Too drugs, right? We have Cemiplimab, we have Sintilimab. Now there is something called Durvalumab. So all these are kind of developed in the Asian countries, mainly China, and they all have similar results. Now, so the best place where these IO agents combination have two chemotherapy is possibly is in PD-L1 1 to 45%, and be it squamous or be it non-squamous. in squamous, your combination would usually be a taxane, and your overall survival is improved. So there is no doubt that these drugs belong in first line, and you should not be using it in later lines. Similar to that, we also have, these were all PD-1 inhibitors. Now, if we look at PD-L1 inhibitors, we do have Atizo, which again, the curves hazard ratio of 0.79 is pretty good, but the magnitude of benefit seems to be a bit lesser. But that also can be due to the kind of patients who went into the trial, because in most of these registration trial, the company would want to include everybody, and therefore might have ended up in including more patients with the lower PD-L1 levels. The data with Sintilimab is also, it appears to be as good as any other immunotherapy what we have. Now, another interesting approach is to add chemotherapy, but only for the first few weeks, and only in this trial only for the first 2 cycles, mainly because to negate that effect of not having chemotherapy, what we saw in the low PD-L1 expressors, and that's how the 9LA was designed. And here it's Ipi-Nivo plus chemo only for 2 cycles versus the standard of care, which is only chemo. And you see both squamous and non-squamous were included in this trial, and PD-L1 all negative and positive all patients were included. And you see at 1 year the difference is almost like 16-17%. And the median OS of about 15.6 with a hazard ratio of 0.66. And if you kind of divided squamous and non-squamous, you see the squamous group actually seems to do probably much better till about 1 year, and then the curves dropping. This just tells you that in squamous cancer it's very difficult to treat in second line, but in adeno you may still have some options and you could still do something. And in this 9LA, if you look even for PD-L1 negative, that is less than 1%, a hazard ratio of 0.62, very similar benefit you get there as what you have got in the high PD-L1 expression. So whether we should, so EP is again expensive, so it's not that all patients can afford it, but if someone can afford it, then we wouldn't be, at least I wouldn't be giving too much importance to the PD-L1 staining over there. Now, if you see, this is a table which just summarizes almost all the trials. I mean, the list is huge, but what we see is that we have actually lifted the bar in median overall survival to the tune of about almost 15 months in some trials, depending on the kind of patients who went into the trial. So no doubt that we have made advances, and this remains a good option. Now, in a country like ours, where most patients would struggle to afford these drugs, it's good to know there's limited information, but whatever information is there and in our experience also tells us that the efficacy as well as toxicity does not seem to be dose dependent, right? There are a lot of other factors in play here. And if you look at the receptor occupancy, receptor saturation, the half-life, the clearance, even the clearance, like it's been shown that if your tumor responds, those patients, the clearance is delayed, even in some studies almost up to 40%.
So 1 minute left.
Yeah. So once you've got a response, do you still need to persist with the full dose and in the same schedule? That is up to us to kind of think about. And just because a patient cannot afford the approved dosing, should that mean the patient should not get any therapy, or some therapy will still be better than no therapy? And this is the discussion we all have every day, and we make our own adjustment in our treatment schedule. So with that, I'll conclude. And so finally, my approach will be to kind of ensure that my patient is indeed a driver mutation negative disease, and if the initial panel or initial sample was not, you cannot rely or you cannot depend on it. Always, many times rebiopsy will be very useful. And for most patients who can afford an IO drug, they should get it in the first line space, mostly with chemotherapy. And it's only if you have a very high PD-L1 expression, you can kind of take a chance and delay chemotherapy to later line, provided your patient is not at the risk of rapid progression or does not have large volume disease. Second line space, it's nothing much has changed over a long period of time. It's a taxane chemotherapy with or without anti-VEGF therapy, and we still have to make a lot of improvement there. Thank you for your attention.
Thank you so much, sir. We've received some questions from Naresh, sir, in the chat box. We request you to please answer them.
Let me open my chat box. Okay, so chat box, first question is, there is data of poor outcome of using immune checkpoint inhibitor beyond EGFR ALK-ROS. I mean, in case of BRAF, HER, MET, and NTRK. So, sir, I think your question is in the uncommon mutations, is chemo IO going to be better than first line approved TKI? So I would say
that not that way. Suppose you told in the very beginning that the kind of the panel which you are going to do to rule out the druggable mutation. So suppose if somebody has done only EGFR, ALK, ROS1, so is it really essential to start the full panel before you opt for the chemo IO?
Yes. So if you look at the inclusion criteria of most trials, they'll just look at EGFR, ALK. That's it. And they don't insist that you should have tested for ROS or NTRK or MET, right? And having said that, that's because these mutations are rare. So you can risk including even 1%, 2%, 3% patient mutation without affecting the whole trial. But in real life is not a trial. And if I have a patient where, and we all make decisions based on that, but we do also send the larger panel or NGS and then when the report comes back, suppose there's somebody with a MET mutation and I've already started an IO chemo, would I discontinue that and go to TKI? I will not, because we even for disease like MET exon 14, the randomized trials even in second line is only happening right now, right? And we have learned from diseases like melanoma. Like for a melanoma is a good example where you have a BRAF mutation, and still we have randomized trial there showing that you starting with an IO is better than starting with a TKI. So in the absence of evidence, at the moment I'm comfortable in giving chemo IO. I mean, except for ALK and ROS. So ALK, EGFR, and ROS. Yeah.
Thanks.
But having said that, NTRK, the data is fantastic. Like, I mean, I'm not sure if we get that kind of data with chemo. Even NTRK is like finding a needle in a haystack, but still that's.
And I think the BRAF data in the NSCLC, not only melanoma, NSCLC also says that the IO works.
Yes, sir. Yes, sir. So just because you've got a mutation does not mean you will not respond to an IO. So we can't have a blanket rule. Yes.
Thank you.
But we know from EGFR and ALK that they don't respond very well.
Thank you so much, sir.
Sure, sir.
With your permission, we'll move on to the next session.
Yeah.
So this session is sponsored by Eli Lilly, and I invite our first speaker, Dr. Kumar Prabhash, Senior Medical Oncologist from Mumbai, to please start. Over to you, sir.
Hi, good evening. Thank the organizer for the invitation. Maybe go ahead with the next slide, please. Next slide. Next slide. Yeah, go ahead, next slide. So my job for today is to talk about EGFR mutation advanced stage non-small cell lung cancer and what's the landscape in today's time. This is a Eli Lilly symposium, and these are slides provided by Eli Lilly, but sure, I do have my own point of view also. Go ahead. Next slide. This is unfolding of EGFR story. This is relatively fascinating. What we have seen our own time, I can say about myself and people of my age group, that there was time where we didn't have much to offer in lung cancer, and we got EGFR mutation, which was detected relatively accidentally, and now you do have a whole lot of treatment available. And at this moment, we talk about at least 8 options in these patients and try to choose which one fits where. Next slide. Next slide. As the time has gone by, and with time we have realized that in EGFR mutation, we do have a spectrum of mutation. And when we talk about those EGFR mutation in lung cancer, we talk about exon 18, 19, 20, and 21. Here the focus will be 19 and 21 because of obvious reason, and try to see, are all EGFR mutation being different? We knew for certain that EGFR exon 20 is not same, but you do have in EGFR exon 20 mutation also patients who are sensitive to first generation TKI, but we do know that exon 20 mutations, you do have multiple different type of mutations sensitive to different type of therapy, and that becomes important when we make decisions. But that's a treatment. That's a discussion for some another day. Next slide. Now talking about the exon 19, exon 21 mutation. This is the data suggesting what kind of mutation frequency we have in the different population. And if you take India, our data, which we have now almost 9,000 plus patients, suggests that exon 19 may be a bit higher percentages as compared to exon 21 in our own population, but looks like they are evenly distributed. Next slide. Now, again, showing the data from the randomized trials and suggesting, and from the different group, that you do have a different distribution of exon 19 and 21, again highlighting that exon 19 being slightly more, again, in Indian context also, and that's the similar what we have seen in Eastern Asian population. Next slide. Now, EGFR mutation subtype and geographical distribution among and then non-small cell lung cancer patient. This is the data which got published by the other group, and what we see that yes, it can be a bit different from what we have seen in other population. But again, it looks like it is evenly distributed. Next slide. There, why we are talking about exon 19, exon 21, because it does appear that they are sensitive to TKI, and sure, we do know that both of them, if you treat with TKI, starting from the first generation TKI, they are better than the chemotherapy. But we do also know that it appears out of those exon 19 and 21, the sensitivity to the TKI therapy may be different. And here highlighting, it suggests that most likely exon 19 patients, the cells, they are more sensitive to first and second generation TKI. Next slide. Showing the same thing in a different way of presenting, that exon 19 patients, they are more sensitive to when they are exposed to erlotinib as compared to exon 21 patients, exon 21 cell lines when they are exposed to this therapy. Next slide. Coming back to the same theory, that exon 19 patients, when they are exposed to gefitinib, and when we see the amount of drug which is required to inhibit, if we expose to gefitinib, it does appear that exon 19 is more sensitive than as compared to exon 21, and that what we see the value of 0.07 as compared to 0.2, suggesting the sensitivity more for exon 19 cell lines. Next slide. Coming back to the picture we showed earlier, highlighting that exon 19 being more sensitive than exon 21, and do they have a bearing in the outcome of the patients? This was in cell line. Next slide. Showing the data that when we talk about what we saw in the cell line, does it happen when we see the same in the trials data? And what these are all the subgroup analysis, but what it suggests that almost in every study, the hazard ratio for when we expose the patients to TKI as compared to chemotherapy, it does appear that TKI works far better for, especially first and second generation TKI works far better for exon 19 as compared to exon 21 in this population, and hazard ratio consistently better for exon 19 than exon 21, suggesting they do have a different sensitivity to the treatment. Next slide. Showing the same thing with all the different studies, and if we see the distribution for exon 21 and exon 19, again focusing on the hazard ratio, and if we keep comparing, the hazard ratio for exon 19 is far lesser than as compared to exon 21, consistently with various studies, especially with first and second generation TKI. Next slide. Now that brings to the question, and where we will have a discussion, and by Dr. Ganesan Biswas, a dear friend, about if they are different prognostically, could be predictive predictively also, do we need to choose those patients' treatment differently? So Ganesan, All yours.
Yeah, thanks, Kumar. So I am of your age. So as you started doing the same, so we are of the same era. So seeing lots of change, especially in the lung cancer space in terms of understanding of EGFR. So thanks MOSCON and thanks Eli Lilly. So these are the disclosure. Next. So Dr. Suman, next, Dr. Saurabh. So these two colleagues will be with us for the next 20 minutes discussion. Next. So next two are my real life cases. So where actually I had a personal experience of the relay in the right setting. So relaying the relay. Next. So the first case is a 69-year female. So mind it. So this was between the first wave of COVID and the second wave of COVID, when many of us have seen patients coming with dyspnea and lung symptoms. They were thought to be COVID. So, and subsequently we see that it has turned out to be a lung cancer. So this patient came to a corporate hospital with a dyspnea, with a pleural effusion on X-ray. Outside it was done as cytology was negative, hypertension controlled, no addiction, no family history, only gives a surgical history of hysterectomy way back. Next. So we know that these patients were kept in isolation till the RT-PCR 36 hours later came negative. So then it was admitted under a pulmonologist. So this patient had a baseline X-ray. We showed a pleural effusion, massive pleural effusion on the left side. No malignant cells were found. So some AFB was done. And then an HRCT again was done outside. So we showed a pleural effusion with a lung collapse, few lymphadenopathy of almost 13 to 15 millimeters. So there were restrictions of COVID. So they took probably a month or so to, and then by the time we saw the patient, so when I chipped in into as an oncologist just to rule out cancer, so you can see the CT thorax, which was done in the later phase of March 2021. So lots of disease. So bilateral lung mets, effusion, pleural deposit, hepatoskeletal, left adrenal metastasis. So almost like a lymphangitis carcinoma. I saw the patient in ICU. Next. So I saw the patient in the ICU on a NIV. So next, please. So since the hospital did not have their own PET CT scan and the patient was on a NIV, so difficult to transport the patient for a PET CT scan. So the pulmonologist put the intercostal drain, and you can see the baseline subsequent investigations. USG abdomen showed multiple liver lesions, CA of high CA, bilateral breast lesions, some showed calcified lesions, and the USG neck showed a sub-centimeter supraclavicular node, which was not clinically palpable, just detected on the ultrasound. CT-guided biopsy showed a non-small cell adenocarcinoma. So, Dr. Suman, so how do you approach this patient?
Suman sir is having network issues.
Dr. Saurabh?
Sir, good evening, sir.
Good evening.
The patient has a CT-guided biopsy report which shows a small cell adenocarcinoma. Since we could not move out and given the time duration, I would have started off with a permetrexate carboplatin or paclitaxel, preferably permicarbo, given a poor general condition. That would be the most tolerated chemotherapy.
Right. So the same thing I did. So I echo your way. So I started with the PEM-carbo with some dose modification. So that was on 3rd of April. Next. So 5th of April, so I was celebrating my 50th birthday. So I got the Liquicore EGFR, and that turned out to be a L858R. So if I'm allowed to ask a question to Dr. Kumar, so Kumar, do you advocate a liquid biopsy for this patient, especially EGFR? You can get a report in 48 hours, 96 hours. Oh, Kumar is not there. Yeah, Dr. Saurabh, so do you advocate liquid biopsy, especially for EGFR?
No, sir. The thing is, the yield is more in the tumor tissue. Second is, we have already given chemo. So generally, we have 3 weeks time period in which we usually get off the EGFR from the biopsy tissue. But in situations where you think it is going to fail, yes, definitely liquid core biopsy is.
Yeah, so I was probably lucky that these patients, so next 3 days, we have the report of L858R. So by the time we have already given chemo, so we had to wait for 3 weeks. And subsequently, the biopsy report came. We did the at the core. So we did a 5-gene panel with, you can see a PD-L1 of 50%, EGFR exon 21 positive, echoing the liquid biopsy report, and all other 4 markers were negative. So now how do you approach? So with a PD-L1 of 50%, now L858R. So how do you continue the same or change the protocol?
Yeah, the intention of the thing is the relay trial is very conclusive. Exon 21, if you have positivity, there is the best option is ramucirumab with erlotinib.
Right.
So
next slide. Yeah, so we'll go to the next.
PD-L1, I would still go with the ramucirumab with erlotinib.
Absolutely. So this patient was started on the Cyramza 10 milligram with erlotinib 150 for a bone meds. He was started on denosumab. So 3 cycles here means 6 doses. 6 doses. So the patient was still on oxygen. So they carried home an oxygen cylinder. You can see there was a good partial response according to a RECIST. Next. So we continued with the same therapy. So the winning combination. Next. So post 7 cycles, you understand that the Cyramza has a PAP for initially 1+2 and subsequently post 2 purchase is 1+3. So that's how it was post 7 cycle, not 6 cycles. And you can see, so by this time the patient was PS1, or you can say PS0, without oxygen, could walk down to the hospital. So this time, so I did not miss the chance of doing a PET scan. And you can see a PET scan for such an extensive disease, post 7 cycles means 14 doses of Cyramza and ongoing erlotinib. This patient had a good response, almost a complete metabolic response. So how common is in lung cancer with such a response, Dr. Saurabh?
It is very uncommon, sir. But with the, I'll be very frank, with the chemo alone, you very hardly ever see. But with, not only with ramucirumab, but with molecular therapies, whereas with strong PD-L1 positive, like 80, I had a patient who was 84%. So there we some other patients with us EGFR, Gefitinib, somewhat very highly responsive. Typical patients like this female who are 19 positive, and there you can give TKIs. You are starting to get a near or a complete metabolic responses. This is again a very good example, sir.
Right.
The same thing.
So Kashish, Suman has joined. Kashish, Suman has joined.
Not yet, sir.
Okay. So by this time, so this was, you can see on 9th of December, but after this, the patient has already received another 5 doses. So almost like 20 doses. Next, the patient continues to be in a response. Next slide, please. So now, so almost 20 doses. So we are planning for the next evaluation early March. So this is a first experience of a complete response with the targeted therapies. Next. Coming to case 2, so he is a octogenarian, 80 years male, retired government employee, diabetes and hypertensive controlled. Our part of the country, lots of tobacco chewers. So, but he was an ex-smoker, 25 years. Younger brother had a cancer prostate, succumbed a few years back. So this gentleman was diagnosed as a CA lung, left, adenocarcinoma, and exon 25. This is the snapshot. Next. Next, please. So I saw this patient in February 2021, and so he presented with the continuous curve with the thick expectoration, and he also gives a history of a streaks of blood coming for last few weeks. So chest X-ray consolidation, in-situ diffusion, lung mass, sputum negative. Again, the CT thorax was done, so we could see a mass collapse. Next. Since his performance score was good, so he could do a PET CT scan. You can see a more than 8 centimeter mass and a node. And also, if you see a right femur, there was a lytic and sclerotic lesion. But fortunately, this 80-year gentleman did not have a complaint for that bone mets. And the FNAC outside was a non-small cell adenocarcinoma. Next. Next, please. So these are tumor markers. We did a PSA because his brother had a history and also an elderly gentleman. We started with the zoledronic acid. So this time I was not lucky because a liquid biopsy came negative. Next. So again, this patient was started on PEM-carbo, waiting for the biopsy followed by the NGS. So this time, so again, this patient had, and so by this time patient has completed 2 doses. So during the second wave of COVID, So in a tier 2 cities, so getting the biopsy NGS done outside, so it took an extra time. So everybody will understand from a tier 2 cities. So now, so Dr. Saurabh, so this patient has a characteristic history, though it is an exon 21, so you understand the importance of relay, but this patient had a complaint of a hemoptysis. So how comfortable you are starting on an anti-VEGF?
Sir, given the ramucirumab, my use, I have only had, I think, 2 patients only with some degree of, they were all very mild. Generally, the studies have shown that it doesn't increase. So unlike bevacizumab.
Yeah. Next. So rightly said. So we should not be worrying much if there is a hemoptysis. These are disease related. So once this patient, the symptoms, the disease responds, so you will have probably the symptoms are gone. So post 3 cycles means 6 doses. You can see the patient has a good partial response. Next.
So Dr. Suman and Dr. Kumar have logged in, sir.
Okay, please. So post 7 cycles. Next. So you can see. So you can see the July to 21 and the December 21 PET CT. So that very good response. Next. Next. So now, so we continued, and now, so post 9 cycles, the patient started having symptoms, and the last PET CT showing a progression. So this is next. So Kumar and Suman, they have joined.
Yeah.
So
Sorry, sir, I had some trouble with the connectivity.
Okay, Suman. So this is a 80-year gentleman. So exon 21. So with a lung and a bone mets. So they started on Cyramza and Alotinib. So did well for 3 cycles, then 6 cycles, post 8 cycles. No, so now this patient has starting symptoms. The PET CT is showing a progression. We did a biopsy. So now again, so we thought that this patient will have a T790 because in the trial we have seen that even those patients on relay, around 45% will have them T790. But T790 was negative. This patient continued to have an exon 21. So how do you approach this patient? So clinically, progression and a radiological progression on a relay. Suman first, then Kumar.
Sir, you actually done the right thing to do a repeat biopsy. And any other mutation was analyzed at that time?
No, absolutely. So this time, so we did the initial was done at a core, that was the 5-gene panel. So this time we did a 12-gene panel.
Okay. So ideal would be to do an NGS, sir, at this time.
So NGS has been done. So all exon 21 positive and PDL1 this time is 80%.
Okay. But EGFR is positive, no, sir?
The exon 21, the primary report, so that was so a year back, the same thing, the same mutation has come up, but this time, so PDL1 is 80%. So Kumar, if you're there.
Yeah, go ahead, Viswas.
So my point is, even if PDL1 is positive, whenever EGFR is positive, that will be the driver mutation in spite of PDL1 being positive. So I'll still go ahead with EGFR therapy only.
No, so what? So we have now consumed relay. So this is not a primary, this is a second setting now. So the patient has progressed on Cyramza plus Alotinib after say 10 months, 11 months.
Next time ideally would be Osimertinib.
Saurabh? Next.
I would agree with Suman, sir.
Yeah, so absolutely. So I started this patient on Osimertinib. Thank you so much. Over to Dr. Kumar.
Thank you, Dr. Biswas. And from my side, we are understanding that as we understood, all lung cancer are not the same, small cell, non-small cell. Then we realize all non-small are not the same, squamous, non-squamous. Now we are realizing all non-squamous is not the same. So we have all mutations. Now we also realize all EGFR are not the same. And we will slowly learn that all these different EGFR mutation, how do we best manage at this moment? So this was a nice discussion what we had regarding how to choose those different options which is available for these individual patients. Thank you so much.
Thank you so much, Kumar sir. Thank you so much, Ghanshyam sir, Suman sir, and Saurabh sir. We'll move on to our next session. Our next session is sponsored by Pfizer, and our speaker is none other than our program director, Dr. S. Krupashankar, who's a medical oncologist from Coimbatore. Over to you, sir.
Thank you, Kashish. I'll just share my screen and we'll get started. Well, hope my slides are visible.
Yes, sir, the slides are visible, sir.
Thank you. So very good evening and a warm welcome to everybody who's logged in now. So I'm just going to pick, this is a sponsored session, as you heard rightly from Kashish. It's sponsored by Pfizer. So we're going to keep the spotlight on lorlatinib, but that doesn't mean that's going to stop us from talking about all the other options that we have in ALK positive stage for non-small cell lung cancer. We're absolutely spoiled for choices, as we know. So I'm going to quickly take you through how you will navigate the choices and choose the right option for your patient. So this is all how it all began, you know, right from 2005, where we had the ALK inhibitors entering into the clinical development. And then you had the first generation, second generation, and then the third generation, which is lorlatinib. So now we know that all of these are approved options, and lorlatinib is now an approved option even in the first line as well, as with brigatinib as well. But unfortunately, we don't have access to brigatinib as of right now. So this is just to summarize the ALK inhibitors. First generation again was crizotinib. That seems to be everybody's favorite whipping boy, given that it's been compared with all the other second generation inhibitors, and all the second generation inhibitors have been shown to prove better than the first generation crizotinib, and be it with better CNS penetration as well. Alectinib, brigatinib is slightly unique in that it's the only small molecule which has action on both ALK and EGFR. And ensatinib, which is not available here as well. And third generation lorlatinib and entrectinib, which also has action on the ALK. It's basically NTRK inhibitor, has action on ROS1 and ALK as well. So if you look at all the phase 3 trials that have looked at ALK inhibitors in ALK rearrangement, and here when we talk about ALK rearrangement, it is the EML4 ALK rearrangement, or the echinoderm microtubule-like protein, which is actually rearranged, and not the ALK nucleophosphamine or the 2,5 translocation, which we tend to see in lymphomas that are ALK positive ALCLs. So all these trials have consistently shown that there's been a PFS improvement when compared to chemotherapy, albeit to the tune of around 4 to 8 months, be it either with crizotinib based on the profile study or ceritinib as well. So just to summarize all the data that we've had on crizotinib based on the profile studies we had, as I had showed you earlier, all these studies looked at comparing it with chemotherapy, and there was a definite PFS benefit, albeit the overall survival was numerically significant, but not statistically significant. But PFS benefit most definitely was seen, and with a favorable toxicity profile as well. The toxicity profile was much lesser with the TKI. So what about ceritinib? Well, this was the data that led to the approval of ceritinib. Initially, we all know that it was approved at 750 milligrams. This was again compared to chemotherapy. I think the key thing about the ASCEND data is that about 1/3 of patients had baseline brain metastasis. So they did allow for patients with active brain metastasis. And out of those 33 patients, about more than 50% had not received any prior radiotherapy to the brain as well. And again, there was a doubling of the PFS, 16 versus 8 months in favor of ceritinib as opposed to chemotherapy. So when we talk about ALK positive, the non-small cell lung cancer stage 4, I think there are two distinct subtypes. About 30% can present with brain metastasis, and about 70% do not have brain metastasis at baseline. So when we talk about patients presenting with brain metastasis, I think the choice is very clear. You definitely want to choose a second generation or a third generation ALK inhibitor, given that they have much better CNS penetration, and they seem to cross the blood-brain barrier much better, thereby leading on to better CNS response rates as well. So if you look at the data here from SN4, clearly in patients with brain metastasis as well, ceritinib seemed to do much better, 11 versus 7 months, an absolute difference of close to 4 months. So I think that's as far as the second generation TKI was concerned. And this was interesting when they did an Asian subgroup analysis from the SN4 data, which again seemed to show that in fact, the magnitude of benefit was higher in the Asian subgroup analysis. But again, given the caveat that this is only a subgroup analysis, but 26 versus 10 months seems to be strikingly significant. The intracranial efficacy, as I was talking to you earlier, intracranial response rates definitely much better. Again, this is only a cross-trial comparison between SN4 and profile, but you can see clearly that the intracranial response rates were much better. with second generation Tki, which is Ceritinib as opposed to Crizotinib. And then came along the ASCENT-8 data, which actually showed that you could do just 450 milligrams of Ceritinib along with food, which does increase the bioavailability of the drug, thereby leading on to you get the same efficacy with 450 milligrams based on the bioavailability if you take it with food. So this was the PFS, which clearly showed that, I mean, like you can see that the curves are absolutely inseparable. 450 milligrams also, median PFS was on par with what you would get with 600 and 750 milligrams. And the toxicity, well, definitely 450 milligrams, the toxicity was slightly lesser if you look at all grade toxicities and grade 3-4 as well. So, and that led to the approval of Ceritinib at the current dose of 450 milligram once daily. And you could bring it down to 300 and 150 milligram if based on the severity of the grade of toxicity as well, based on the CTCAE grading criteria. And moving on to the next kid on the block, which was Alectinib. And this was the data that led to the approval of Alectinib in the first line setting. And like I said, everybody's been comparing it with the first generation ALK inhibitor, which is Crizotinib, and proving that it's actually better than Crizotinib in the first line setting. So this was the LX data, and this was the updated PFS analysis. You can clearly see that there was a tripling of the PFS, 34 versus 10 months or 11 months. So an absolute difference of around 2 years. So that's pretty impressive data. And even in patients with CNS metastasis, the magnitude of benefit was absolutely maintained. And the overall survival, the updated analysis will, well, we don't have the data still not yet mature, but absolutely you can see that the curves are starting to separate. And again, if you look at the time to CNS progression as well, you can see that Alectinib easily outscores Crizotinib, both in patients with CNS mets at baseline or even patients who did not have CNS mets at baseline. And the safety profile was consistent with what we had seen with the other ALK inhibitors, with nausea, diarrhea, and vomiting being most common. And again, the treatment discontinuation rates weren't much higher as well. So what about Alectinib in Asian subgroup analysis or a trial looking at only in Asian patients? This was the Alicia study, which again looked at Alectinib versus Crizotinib in Asian patients alone. And again, they had a good number of patients with CNS metastasis, and the intracranial response rates were very impressive with the second generation ALK inhibitor. And again, as you can see here clearly, the curves start separating early and they keep separating as we move along as well. So again, if you look at patients who had baseline CNS metastasis as well as even in patients who did not have baseline CNS metastasis, the magnitude of benefit was absolutely preserved. The CNS response rates of around 70 to 75%, very impressive data indeed. And the adverse effect profile was almost consistent with what we've seen with the earlier ALK inhibitors, be it the second generation ALK inhibitors as well, and seem to be much better than absolutely a first generation ALK inhibitor, which was Crizotinib, which was what it was compared to in this study. And what about Brigatinib? Well, this was the data which led to the approval of Brigatinib in the first line setting, the ALTA-1L or the first line study for Brigatinib. And again, the primary endpoint being the blinded independent review committee assessed PFS. And clearly you can see that the curves are absolutely separated here as well. The median PFS hasn't been reached, it's only around 10 months with Crizotinib. So clearly, hands down winner, Brigatinib here as well. And again, as we have seen with the other data with the second line ALK inhibitors or the second generation ALK inhibitors, clearly the intracranial response rates were much better and clearly proving the intracranial efficacy of these second generation ALK inhibitors as opposed to the first generation. ILD or pneumonitis seem to be a concern with Brigatinib. But then again, if you look at the number of patients who actually received dose reductions, slightly higher with Brigatinib as opposed to Crizotinib. But if you look at the grade 3 adverse events, again, nothing much to choose from between both. So moving on to the highlight for today's talk, or the spotlight being on the third generation ALK inhibitor, and currently the only available third generation ALK inhibitor which we have, which is Lorlatinib. Definitely, it's a very selective agent. It's highly potent as well, and we know that it's got excellent CNS penetration. And that we know is probably an unmet need, because if you remember, I showed you earlier that about 30% can present with brain metastasis, and we definitely need an agent with much better CNS activity in the first line itself. So it's like using your best agent right up front. So, and it's slightly different as far as the mechanism of action is concerned, in that it binds with a higher affinity to most of the resistant mutations as well. And in particular, the G1202R mutation, where all the other ALK inhibitors are actually resistant, but lorlatinib works in that particular resistant mutation as well. So I think that's another advantage with lorlatinib. And this was the study which led to the approval of lorlatinib in the first line setting, the CROWN study, which actually led to the crowning of lorlatinib in the first line. So again, the primary endpoint being PFS. And clearly you can see here that the 12-month PFS, absolutely the curves are widely spread. And the hazard ratios being to the tune of around 0.2 to between 0.2 to 0.3. So very clear benefit with lorlatinib as well as opposed to crizotinib. And very interestingly, you can see here as far as the intracranial progression rates were concerned, absolutely much better. But we'll still have to wait for the data to be mature until we get the actual numbers, that is, as far as the overall survival goes as well. So again, to sum it all up, I would say the adverse effect profile, weight gain, hypercholesterolemia, neuropathy, and cognitive effects seem to be a concern with lorlatinib, especially if you're starting off with 100 milligrams OD, as was done in the study. Crizotinib, again, the adverse effect profile was consistent with what we had seen from the earlier data, but clearly lorlatinib seemed to be much better than crizotinib as far as PFS, intracranial response rates, and time to CNS progression was also concerned. So this is just a cross-trial comparison looking at all the available data that we have until now. And again, this is only a cross-trial comparison. Clearly, you can see that alectinib, brigatinib, well, brigatinib, we don't have the median PFS yet. And again, brigatinib also, lorlatinib also, we don't have the median PFS. It hasn't been reached yet. But clearly, you can see that the second and third generation ALK inhibitors seem to outperform the first generation ALK inhibitor, crizotinib. And be it even in patients who have baseline brain metastasis or irrespective of the presence of brain metastasis. So again, just to look at the toxicity profile as well, visual disorders seem to be higher with crizotinib. That's what we've seen as well in practice. Hepatotoxicity, again, another concern with all the ALK inhibitors. Edema and fatigue, I would say probably more with lorlatinib as well. Edema, hypercholesterolemia, and triglyceridemias seem to be a concern with lorlatinib. So what about the NCCN guidelines? Well, if you look at it, the first-line therapy preferred category 1 recommendation is for either of these, the second generation or third generation ALK inhibitor, alectinib or brigatinib or lorlatinib. So, and probably, yeah, we don't have access to brigatinib, so you could rule that out. So it's between alectinib and lorlatinib. And probably if you can put them on your most potent TKI upfront, I think most of us would tend to do that, given that the patients can afford it. So what about the patterns of progressions and mechanisms of resistance? Well, we talk about oligoprogression, or it could be even extracranial progression or intracranial oligoprogression, and then you talk about multiprogression as well. And there are multiple mechanisms of resistance, out of which we know that the resistant mutations forming in ALK absolutely are one of the key factors as far as why they develop resistance. And like I said earlier, they've looked at a lot of these resistant mutations, and probably the one thing that sticks out is the G1202R mutation, where possibly the only drug that works in that particular mutation is lorlatinib. And we know that probably if you start off with a second generation, then your incidence of developing the G1202R mutation is slightly higher as opposed to starting off with a first generation ALK inhibitor. And again, when you talk about resistance and the risk of CNS relapse with crizotinib, well, majority of the patients did go on to develop CNS metastasis if you started off with the first generation ALK inhibitor, which is crizotinib, and that's probably related to the poor CNS penetration of crizotinib. So as I was alluding to earlier, if you start off with the first generation ALK inhibitor, you're more prone to develop brain metastasis, followed by lung, bone, and liver in that order, whereas your incidence of brain metastasis is much lesser if you start off with the second generation or the third generation inhibitor. And this was data from the ClinALK study as well, or the master protocol that we've seen. So what about continuing either of these ALK inhibitors beyond progression? And this was the data from crizotinib. Well, there was absolutely not much of a benefit. The benefit that we see was only in terms of clinical benefit rate, or the time to treatment progression was slightly delayed. But apart from that, not a great option, but probably if your patient can't afford any of the other expensive second or third generation ALK inhibitors, you could give that a try beyond progression. And what about switching to a next generation ALK inhibitor? This is the data from the ClinALK study where you're talking about ideal sequencing strategy. And if they go on to develop particularly sensitive mutations in the second line and third line and so on and so forth, then you're talking about a median survival of close to 7 years or 7.5 years. But I guess that's only if all things fall into place. You need your patient to be fit enough to tolerate second line and third line and subsequently, and also not develop any of the resistant mutations where we know most of the drugs don't work. So we're talking about an ideal world scenario, but then again, yeah, if you're lucky enough to, yes, could do that. What about the activity of the second generation and third generation inhibitors in patients who are refractory to quizartinib or they've progressed? Well, this is the data from quizartinib, where you're talking about a median PFS of close to 6 months and then a median overall survival of close to 15 to 16 months. Well, and alectinib, again, I mean, like if you look at the response rates, and this is again in patients who have progressed on quizartinib, we're talking about probably doing a sequencing strategy. And I'll show you as finally, as well as we move along, as to how I would look to summarizing it. But the median PFS again seems to be around 8 to 9 months in patients who have progressed on quizartinib. And brigatinib again as well, the data. So this is the PFS, again close to 9 months with the control arm. And if you actually put them on 90 milligrams once daily for the first week and then switch them over to 180 milligrams, as was done in the studies, then you're talking about close to a year and 3 months, 15 months. So to summarize all the second generation ALK TKIs in quizartinib refractory setting, regardless of the resistance mechanism, we've seen that the response rates are good, but it's about the duration of response. Most of them don't seem to have a long duration of response, and that's the key reason as to why you're seeing a median PFS to the tune of around 7 to 15 months. And brigatinib, yes, probably seems to be better, the data, as far as in the second line setting. And that's probably because they led in with the dosing strategy of starting off with 90 milligrams, and then for the first week, and then switching it to 180 milligrams. So, but what about if you start off with the first line alectinib? Well, there's not a lot of data for that, and especially in the second line setting, if you start off with first line alectinib or any of the other second line ALK inhibitors, a retrospective analysis looking at brigatinib, and again the response rates again was only around 20%, median PFS being 4 months. But what about lorlatinib in the second line setting? We know that now this was basically a dose finding study as well, where we now know that the dose of lorlatinib that's been approved is 100 milligrams. So again, if you look at it, the median PFS is close to 13 months. So alectinib and brigatinib seem to be quite effective, especially even in patients who have progressed on quizartinib. But again, the caveat being that you will have to look at identifying the particular resistant mechanism before you actually choose the drug. And toxicities with lorlatinib, again, as we had spoken about earlier, edema and dyslipidemia seems to be the key concerns, and CNS effects as well. So to summarize the CNS activity in post-quizartinib setting, well, if you look at the the response rates as well, not much to choose from if you're talking about the second generation and third generation, but probably alectinib and lorlatinib, the response rates seem to be around 50 to 60%. And even in patients who had brain metastasis at baseline as well. So this is how the guidelines have also continued to evolve. Like I said, obviously it depends on the site of progression. Is it a CNS oligoprogression, where you could even look at giving radiotherapy to the brain and then continuing them on the same ALK inhibitor, if it is oligoprogression, CNS oligoprogression, or if you have multiple lesions and multiple progression, then you would definitely want to switch therapy, repeat a biopsy, look for the ALK resistance mutation, and then choose your drug. And if you can't do that, then probably lorlatinib is your answer because it works in all the resistance mutations. So how do we look at optimally sequencing these ALK inhibitors? Is it like a long distance relay race? Probably in our setting as well, in the Indian setting, where probably only around 5% of our patients will be able to afford either alectinib or lorlatinib, 5 to 10%, at least in my practice. I'm not sure about how it is in the corporate setting. Probably there more number of patients might be able to afford that. So I would say probably the first runner is very important. So it really matters that you choose your most potent agent right up front, especially if your patient can afford it, then yes, definitely yes. Alectinib or even lorlatinib in the first line setting definitely makes sense. But otherwise, if your patient can't afford it, and even if they have brain metastasis, then you'd probably have to settle for ceritinib given the difference in cost. And again, I like I was alluding to earlier, the ALK resistance mutations, they're more commoner when you start off with the second generation ALK inhibitor as opposed to a first generation, especially these two, the G1202R mutation and the L1196. G1202R only lorlatinib works. L1196 alectinib is effective in that particular resistant mutation. And this is just to highlight on lorlatinib as well, which, like I had alluded to earlier, is very effective across all the resistant mutations. So you definitely have to look at defining the resistance mechanisms. So you'll have to consider repeating a biopsy, how feasible that is, and how many of our patients would actually get it done in real life. That's a big question mark. But ideally, yes, if you can do it, you would really definitely look at wanting to get a repeat biopsy done. So the points to consider, as far as I'm concerned, as far as selecting a first-line treatment is superior efficacy in the first line, definitely yes. But why? Because most of our patients, or at least some patients, may not be able to go on to receive second-line therapy, especially if they're presenting with brain metastasis at baseline. But if they don't have any brain metastasis at baseline, so you're looking at using at least a second generation or a third generation to make sure that you're delaying the incidence of brain metastasis. And brain metastasis as baseline, I think, it's very clear. If you have symptomatic brain metastasis, go ahead and address with RT. Asymptomatic brain metastasis, go ahead and use a CNS penetrant TKI, be it either alectinib or lorlatinib, depending on your choice of agent and depending on financial constraints of the patient as well. Symptomatic disease, yes, definitely you definitely want to look at the response rates as well. And using an agent with high response rates really matters, especially if you have a very symptomatic patient upfront as well. And probably something that would be key, or something that is worth contemplating is on, just like how we have the data, Indian data, TMH data on TKIs plus chemotherapy. So if you have a patient with a very high volume of disease or a burden of disease, we don't have the data, it's not yet approved, but would you look at doing an ALK inhibitor plus chemotherapy? I think that's food for thought. And second line agent, post progression, definitely depends on your choice of first line drug, and also depends on your repeating a biopsy and identifying whether it is a resistant mutation or not. And ideally, you would like to repeat a tissue biopsy rather than only a liquid biopsy, because a tissue biopsy would give you additional information. If there have been instances where patients have gone from non-small cell to small cell lung transformation as well, so it would be helpful in identifying that. So, but if you look at the most practical approach, I would say what proportion of our ALK patients actually reach second-line TKIs, especially if they have brain metastasis at baseline. I would say the ballpark figures are around 50% gone to receive second-line TKIs. But if you look at only patients who have baseline brain metastasis, I would say only 1/3 go on to receive second-line TKIs or ALK positive TKIs. And how many actually undergo repeat biopsy and mutational testing at progression? I think that the numbers are really low. I would say ballpark numbers would be less than 20%, at least in my practice. And again, the most key important question is, how many of them can actually afford alectinib or lorlatinib? So, which is why probably, the sequencing strategy holds good as well, especially in the Indian setting if your patient can't afford it. But again, if your patient doesn't have any financial constraints, because you're talking about reaching the same amount of PFS with just a single TKI or a second generation ALK inhibitor. And so this is just to put it all in a nutshell. So if you're going to start with any of the second generation or a third generation ALK inhibitor, then, that's as good as probably sequencing it. The sequencing strategy, the only problem is that you're relying on a lot of factors to go your way. One, the patient has got to be fit for second line therapy. And number two, obviously, you're looking at the resistant mutation being favorable as well. And also the patient actually having a site which is ideal for repeat biopsy as well. So you're talking about a lot of things falling into place if you're looking at an ideal sequencing strategy. So no financial constraints, go ahead with the second or third generation ALK inhibitor. And we don't have access to brigatinib, so I would say the choices are between alectinib and lorlatinib. So to summarize and finish, I would probably end up by saying that crizotinib, probably, I think, we've seen across the board from all the studies that I've presented so far, that all the studies have shown that as far as the PFS is concerned, and also as far as the intracranial response rates are concerned, the second and third generation ALK inhibitors are much better than crizotinib in the first line. And we need a lot more drugs that are actually capable of crossing the blood-brain barrier or with better CNS penetration. And that seems to be the need of the hour. And also drugs which are capable of working against all the resistant mutations. Ceritinib, it's approved at 450 milligrams with food, thus increase the bioavailability and the efficacy remains the same. Alectinib versus crizotinib, brigatinib versus crizotinib, same story, longer PFS, and obviously better CNS penetration as well. Both are FDA approved options. Lorlatinib, again, now has been approved in the first line setting, seems to be a very good option in the first line setting. And probably the one thing that works in its favor is that it's also active against all the resistant mutations, including the G1202R. With that, I'd say thank you for your patient listening and hand it over back to Kashish. Be happy to take any questions if there are any.
Thank you so much, sir. If you have any questions from the audience, we request you to please raise your hand. There's a feature on Zoom where you can do that, and we'll unmute you and you can ask your question.
Kashish, Dr. Vora here.
Yes, sir.
Hi,
sir.
Hi. Awesome lecture. Just wondering, since last 1 year, is now crizotinib limited only to patients who get free drug or cannot afford? In all practical sense, to me, looks like that, it's like sort of everything else is superior to crizotinib. Do you still use crizotinib, Dr. Krupa, if patient can afford alectinib, ceritinib, or of course, lorlatinib is later, but if they can afford alectinib or ceritinib, do you still use crizotinib in certain populations scientifically?
Well, not really, sir, because I think, like you rightly said, if the patient can probably afford it and has got no financial constraints, you would definitely look at choosing a second generation or a third generation ALK inhibitor right up front. Because I think we've learned that from the EGFR story as well. Probably we're all intent on using our most potent weapon right up front, rather than relying on the sequencing strategy. Because the only problem with the sequencing strategy is that we're relying on a lot of things to actually fall in place. Like, for example, the patient developing a CNS metastasis and how fit are they going to be to tolerate second-line therapy, having an ideal resistance mutation as well. So a lot of things actually have to fall in place if you're looking at the sequencing strategy. So I think that's the only reason, sir. Yeah, please go ahead, sir.
Dr. Krupa, I completely agree with every word what you said. But if you look at the data, the mature data of 8 years and 9 years, there is, a median survival of 7 years has been reached when a patient has used crizotinib followed by second generation and third generation. That is the data what we have, because crizotinib is there since a long time. Of course, we all know that by the time alectinib is matured for 7 years, probably it's going to be better than that. But if I tell you that patient does not have any CNS metastasis, patient does not have any other activating, resistant mutations upfront, for example, crizotinib followed by alectinib or followed by lorlatinib, do you think that still that makes any sense, or no, we should stop doing that? Your opinion.
So my take on that would be, sir, I think, if the patient can afford it in the second line, probably, I would probably push them towards using it in the first line setting itself.
Okay.
So I think, even when I showed the last, slides, sir, I think even with the ideal sequencing strategy, you're talking about the ClinAlk data, which actually showed a 7.5 year, 89 months to be right. But you're probably right in that once we have the data to be mature from the second generation and third generation, we'll probably see the same magnitude of benefit with them as well, and without having to sequence one after the other. So that's just my take on it, sir.
Right. No, I agree. Thank you so much.
Thank you so much, sir. With your permission, we'll move on to the next session. Thank you so much, sir. So our next session is on head and neck oncology, and it gives me great pleasure to introduce our two chairpersons, Dr. Arvind Krishnamurthy, Senior Surgical Oncologist from Chennai, and Dr. Raju Titus Chako, Senior Medical Oncologist from Vellore. Over to you, sir. Raju, sir, you'll have to unmute your mic.
Arvind, please start.
Yeah, great. Thank you for the organizers for the opportunity, and looking for a power-packed session of 1.5 hours. And in the interest of time, I would just ask Dr. Venkatraman Radhakrishnan to kickstart the proceedings. Venkatraman works with us, and he would start his talk on the role of induction chemotherapy in operable head and neck cancers. Over to you, Venkat.
Thank you, Dr. Arvind, sir. Thank you, Dr. Kripa, for this opportunity. Wonderful conference. So today I'm going to talk to you about induction chemotherapy in squamous cell head and neck cancers. I'll digress a bit. I'll also include in inoperable so that the residents get a full picture of what is the role of induction chemotherapy. So I'll come to my last slide first, which is the conclusion of my talk. So what are the consensus guidelines about use of induction chemotherapy in head and neck cancers? So currently, there are no randomized clinical trials showing superiority of induction chemotherapy over concurrent chemoradiation, which is the standard of care. Recommendations are for oropharyngeal cancer, it is category 3. That is, most of the NCCN people did not agree. They were fighting with each other. For glottis, supraglottis, larynx, and hypopharynx, it's category 2. Means some of them managed to agree. NCCN says that preferred induction chemotherapy is TPF, which is docetaxel, cisplatin, and 5-FU. There's lack of consensus on what chemotherapy you should use with radiotherapy after a course of induction. NCCN says carboplatin is preferred. If you want to use cisplatin, use weekly cisplatin. 3 weekly is not at all recommended. It's very toxic. And patients who are cisplatin ineligible, you can give cetuximab. They also mentioned that induction chemotherapy should only be given in specialized centers due to a significant amount of toxicity. So these patients need special care. So why is there so much interest in induction chemotherapy when all the guidelines say it's not of much help? Over the years, there have been improvement in surgical techniques and we are achieving better loco-regional control. Many patients are having distant recurrences, and there is evidence that induction chemotherapy might reduce distant metastasis. And also there's significant long-term morbidity with concurrent chemoradiotherapy, and therefore it is believed that using induction chemotherapy might help us in reducing these morbidities. And there are a lot of questions about induction chemotherapy. What's its role in organ preservation? How many drugs do you use? Do you use induction chemo followed by RT or induction followed by CT-RT? And what is the role of a targeted agent like cetuximab with induction chemotherapy? And I will be looking at all these questions now. So this cartoon perfectly illustrates. We have the one side of the boxing ring CT-RT, which is the main contender. And other side, we have induction and we have various options. You can give RT, you can give CT-RT, you can give cetuximab with RT. We don't know which drugs are the best. We don't know which drugs to use with RT. What is the RT dose and schedule? So there's a lot of chaos on the induction chemotherapy side. Induction chemotherapy came into being about 3 decades ago because it was found to help with organ preservation, especially in laryngeal cancers. And we know that organ preservation is important to maintain the quality of life of patients. It helps in breathing, eating, and speaking. And the 2 pivotal trials which residents have to remember is the Veterans Laryngeal Cancer Study Group and the EOTC trial. The patients in these arms got either surgery followed by RT. Obviously, there's no organ preservation in the surgery arm, or induction chemotherapy followed by radiation. Here, a 2-drug PF was used. There was no survival advantage of either of the arms, but almost 50% of patients in the induction chemotherapy arm, the organ could be preserved. And then they said, let's see if whether, the PF where we had a 50% organ preservation can be improved to more than 50% by addition of a taxane. And that's how your tax, initially the GOTEC trial came. It showed that, the legend, you can see the left-sided graph, the Kaplan-Meier, there's almost a 50% survival advantage with, TPF over PF, not 50%, about 25%. But there was no disease-free survival or overall survival of TPF over PF. Then came the famous TAX 324 trial, simple design, taxane, platinum, and 5FU versus platinum and 5FU, followed by radiotherapy with carboplatin. Carboplatin was given AUC weekly 1.5. And in this study, actually TPF showed a survival benefit over PF, both EFS, that is PFS, and OS. And again, the organ preservation rate in this study was 75%. That is almost 2/3 of the patients, the organ could be preserved. And there's data from India as well. This was just published a few months ago from Tata Memorial, a phase 2 trial where patients are randomized between surgery or 2 cycles of induction with TPF followed by surgery. They looked at mandibular preservation, and almost 50% of patients in the induction chemotherapy arm, they could preserve the mandible, and no difference in DFS was seen. So this might be one indication where induction chemotherapy might be helpful, especially in mandibular preservation, where you're not able to give chemoradiation because of the bone involvement. The next question is, okay, you have been talking about induction chemotherapy. How does it compare to chemoradiation or radiation alone? And the best answer for this would be the MAC-NC meta-analysis. And you can see that the absolute benefit with chemoradiation in terms of survival is about 6.5%, which is significant. But when you look at induction chemotherapy, it's just 2.4%. So induction does not help in terms of survival when you compare it with concurrent chemoradiation. And this also holds for loco-regional failure and event-free survival, not only overall survival. You can see all the places concurrent chemoradiation is better than induction chemotherapy. The only advantage of induction chemotherapy was in distant failure. Obviously, you're giving systemic chemotherapy. So if you see the right-hand side graph, you can see almost a 5% benefit in distant failure with induction chemotherapy, whereas concurrent chemoradiation showed a significant almost 9% benefit in terms of local failure. One of the trials which contributed to the McKinsey analysis was the RTOG 911 trial. A simple trial compared induction chemo followed by RT versus CT-RT with RT. And the trial results were not surprising. Chemoradiation trumped. It was better than induction chemotherapy and radiotherapy alone. There were better organ preservation in the chemoradiotherapy arm. Surprisingly, the mortality due to non-laryngeal cancers were more in the CT-RT arm. So things are getting even more complicated. So people said that, yes, we know CT-RT works better. Why not add induction to CT-RT to see, is it better than CT-RT alone? So people didn't give up. And there are two trials. One is the DECIDE trial and the PRODIGE trial. So they looked at this question of giving induction before concurrent chemoradiation. The DECIDE trial used a complicated regimen of, with radiotherapy, which was docetaxel, 5-fluorouracil, and hydroxyurea. I don't think so anybody uses. And it was a twice daily radiation. As expected, there was no difference in survival with induction chemotherapy, and the toxicities were twice as more with induction arm versus concurrent chemoradiotherapy arm. And then came the PARADIGM trial, which was again like the DECIDE trial, but they had a better, arm in terms of radiation, either carboplatin or docetaxel based on response after TPF versus cisplatin with RT. Again, no improvement in survival. Actually, the graph showed that the concurrent arm had slightly better EFS and OS than the induction arm, and there were more febrile neutropenia and toxicities in the chemoradiotherapy arm. So, the induction chemotherapy has been buried and laid to rest in all the trials have shown. CT-RT has been the winner. So people said, okay, induction chemotherapy is failed. Now let's try adding cetuximab and seeing if that makes a difference. So there are two trials. One looked at induction followed by cetuximab RT versus CT-RT. And then one tried looking at, induction followed by cetuximab RT or induction followed by CT-RT. The first trial was a GOTEC trial. Again, there was no benefit of, TPF followed by cetuximab RT versus CT-RT as expected. So again, laid to rest. They surprisingly found that if you gave cetuximab RT, you had lesser distance metastasis-free survival, but again, no OS benefit, and more TRM in the TPF arm. Then the other trial was the Trampoline trial. Again, TPF followed by CT-RT versus cetuximab RT. No differences in toxicity between the two arms, and no differences in outcomes between the two arms. So far to summarize, induction chemotherapy, yes, does improve organ preservation when you use a substandard arm just with RT. But when you compare induction chemotherapy with CT-RT, none of the trials have shown any survival benefit. When you add cetuximab also, no survival benefit seen. So people decided, okay, let's make a khichdi and add all arms. Let's have induction versus no induction, chemoradiation versus cetuximab RT. So this was the head and neck 07 trial. And surprise, surprise, they showed that induction chemotherapy is better than no induction chemotherapy. But I have to take you back. One of the arms is inferior. Obviously, we know that cetuximab RT is not as good as chemo RT. So obviously, the trial results are skewed. So they managed to show it OS and PFS. But I will take this trial with a bag of salt. It's a very complicated trial and confusing trial. And finally, coming to our real world data, this is our institute data, about 26 patients. 57% of patients we could give TPF. That means almost half of the patients are not fit to get a 3-drug regimen. We could operate 40%. These patients were inoperable upfront. So we could operate 40% of this patient, which is a good number. There were 2 deaths. So TRM is important. The patients who underwent surgery had a median PFS of 12 months, and patients who did not undergo surgery had a median PFS of 8 months, which is quite good in patients with advanced disease. So to conclude, as a medical oncologist, there is enough data that induction doesn't improve survival. It is not better than CT-RT. It is more toxic. We still don't know where to use it. Probably the only area where you would use it is the mandibular preservation, which Tata Memorial is used. In all other areas, CT-RT would be the go-to. Why add one more additional form of treatment when you can, and lengthen treatment when you can get same or better results with CT-RT alone? Thank you very much.
Great, Venkat. I think you really managed to sort of elegantly sum up the vast data of induction chemotherapy versus CT-RT in the time provided. So to sum it up, can I conclude that, say, other than in the unresectable. Of course, if it's unresectable technically or otherwise, considering the various definitions, you would give induction. But the other thing would be in organ conservation, right, Venkat?
Yes. Yes.
I think so. But there is possibly a small other window before I just want to make one comment before I throw it to everybody else. Maybe in undifferentiated sinonasal carcinomas, NUCs, there is a slightly evolving role of giving induction chemotherapy, and based on the response assessment, you try to decide whether you do things. Apart from that, I think that is your comments on that, Venkat, and then I will ask Dr. Titus.
This was only for head and neck squamous cancer. So sinonasal, yes, and obviously nasopharyngeal cancers, induction chemotherapy is the standard of care. That is GemCis followed by CTRT is the current standard of care. So I didn't address those. I just wanted to look at the controversial area. So definitely in those places we have to offer induction chemotherapy.
Great. I'll throw it open.
Thank you. Thank you for that excellent lecture. If I may just ask one last question to you. You know, one of the problems that we have is the whole issue of no operating time. So somebody comes to you with operable disease, and the surgeon tells me that, look, my next operating date is 2 months away. What will you do, Dr. Venkat?
Yes, so this is a common scenario which we face. Again, depends on whether the patient can be given. It's a site where CTRT works well and can be given. We also have to remember there's almost a 10% mortality with induction chemotherapy, and especially when your patients are malnourished and you have problems with supportive care, that should be kept in mind. There's also a small chance of progression with induction chemotherapy. So I would take it on a case-by-case basis. Otherwise, we will end up having all patients before surgery getting induction chemotherapy. That would not be the answer. You will have more failures. So I won't go by the approach. I'll try to push my surgeons to get to the patient to the table as quickly as possible.
Thank you. All right, let's get on to the next session. And we have an exciting debate. This is with regard to weekly versus 3-weekly cisplatin for adjuvant or a concurrent CTRT. Weekly cisplatin, Dr. Vishwanath Satyanarayan, medical oncologist from Bangalore, and 3-weekly chemotherapy, Dr. Kripa Shankar. So let me call on Dr. Vishwanath Satyanarayan to please start off the debate. Vishwanath.
Thank you so much, sir, for this opportunity, and thank you, MOSCON. Let me share my slides. Yeah, so interesting debate topic, and I will be talking on weekly cisplatin for adjuvant concurrent CTRT head and neck, and my good friend Dr. Kripa Shankar will be we'll be talking on 3-weekly. So weekly cisplatin with radiation is widely used in the post-operative high-risk squamous cell carcinoma of the head and neck. And I think most of us do agree that it's become a norm in most large cancer centers. And evidence is currently based on multiple retrospective studies, prospective studies, and also a recent randomized trial data, which I'll be presenting. It has a good radiosensitizing effect when administered during radiation. And when we look at the dose intensity in weekly versus 3-weekly, weekly it's 40 milligrams per meter square per week, and in 3-weekly it's 33 milligrams per meter square per week. So it's higher in weekly. And superiority has been documented when compared to radiation alone. And definitely it's much safer and very feasible. And to drive home my point, I'm going to use this trial, the recent Japanese trial, which got presented by Dr. Naomi Kiyota in ASCO 2020. And this was from 28 large centers, and it was a phase 2, phase 3 trial, post-operative high-risk squamous cell carcinoma of the head and neck, stage 3, stage 4, all the high-risk features, and most notably, all subsets of the head and neck. Patients were randomized to 3-weekly, 100 milligrams per meter square of cisplatin with radiation, and arm B was cisplatin plus radiation. Please note this, 40 milligrams per meter square with radiation. And the phase 3 part actually looked at the non-inferiority of weekly versus 3 weekly. The primary endpoint was overall survival and several secondary endpoints. And look at the patient characteristics, very well matched, excellent matching, and as good as these wrestlers, excellent matching. And what about the other patient characteristics as far as the high-risk features, the T stage and the nodal stage? Very well matched too. And look at this, 3-year overall survival. Look at the Kaplan-Meier curves. The pink one is the weekly, 71.6% in the OS versus 59.1% for the 3 weekly arm. Look at the separation of curves and look at the p-value and look at the hazard ratio, 0.69. Excellent hazard ratio for a solid malignancy. And look at the relapse-free survival, 0.71 hazard ratio for weekly. And you can look at this nutrition support-free survival. This is something which we have problems with the head and neck malignancy, treating head and neck malignancies. Nutrition support-free survival was also better in the weekly arm. So definitely I would say the clear winner is the weekly. And what about the toxicity? Toxicity was much lesser in the weekly arm. Lesser dysphagia, lesser nausea, hyponatremia, renal impairment, hearing impairment, neutropenia and febrile neutropenia, all much lesser in the weekly arm. So the 3 weekly arm, coming to the 3 weekly cisplatin, for my good friend Dr. Kripashankar, has significant toxicity and acute toxicity of at least grade 3 or more in 77% of the patients, more than 3/4 of the patients. And can we afford to have a toxic death in a patient who we are treating for adjuvant setting? 2 to 4%. And greater than 50% do not receive the planned 3 doses of cisplatin. And we do know that cumulative cisplatin and the dose intensity are very important. 200 milligrams per meter square is the golden number which we need to achieve. And more than 50% do not achieve this 200 milligrams per meter square in a 3 weekly arm. So is there any point continuing this debate? So appearances may be misleading, just like this cartoon. And that's one of the reasons I'm going to present this trial, which is very deceptive. Single center, with all due regards to my colleagues in Tata Memorial, single center study, and 93% were for the high-risk post-operative arm. And you can see that patients were randomized to 3 weekly cisplatin, the usual dose of 100 milligrams per meter square, versus cisplatin weekly. What is this dose? 30 milligrams per meter square. It's not 40, it's not 50. And the patients were then followed up. And look at this. 91% were only oral cavity. What about pharynx? What about larynx? It's only oral cavity. And don't you think it's a very skewed data? 91% only oral cavity. And what about the toxicity? 84.6% versus 71.6% of grade 3 or more toxicity. And what about the hospitalization? I'm sure Dr. Kripashankar is going to talk about the cost factors and all, and use of growth factors was much more in the 3 weekly arm. So we don't want patients to suffer like this. And what about the disease-free survival, progression-free survival, and overall survival? Don't you see there is no difference in the Kaplan-Meier curves of the 3 weekly versus weekly arm? All the hazard ratios are more than 1. P-value was not statistically significant. And where do these non-significant results go? They go into this trial. So I'm sure Dr. Kripa is going to talk about bioeconomics, more frequent chemotherapies in the weekly arm. But what about, are we not talking about supportive care, growth factors, hospitalization, ICU care? So what about that for the 3 weekly? To conclude, I would say weekly cisplatin is definitely a better choice. Randomized control supporting it, ease of administration, better compliance, reduced RT interruption, lesser intensive care, decreased toxicity, the list goes on and on. And of course, lower overall cost. And real world, I'm sure all of us will agree that Dr. Kripashankar's case of 3 weekly is going to be only in the minority and we are the majority. Thank you so much for a patient listening. And I look forward to the Tom's failure talk, that is Dr. Kripashankar's talk. Thank you so much.
3 weekly, Dr. Kripashankar, all yours.
Yeah, thank you. Thank you, sir. Thank you, Vishwa, for that entertaining 5 minutes. You had your turn, so, wait and watch. So I think you rightly put up the Tom and Jerry, but I'll tell you what, I'm the Indian Tom and you're the Japanese Jerry. All that I could see was only Japanese data. But anyway, I think it's been an age-old debate, raging age-old debate. I think we settle it today, right here, right now, Vishwa. And I'll show you why 3 weekly should be the standard of care. I think the evidence and data is absolutely weighed in favor of 3-weekly cisplatin. And I'm sure the debate is centered around only in the adjuvant setting. I'm not even going into the definitive setting because it's not fair to you, Vishwa. I think, high dose cisplatin clearly in the definitive setting is a hands-down winner. So the last time I checked, Vishwa, my good friend Japanese Jerry, I could only figure out, that patients were either cisplatin eligible or ineligible. I could not come across any criteria which said 3-weekly eligible or weekly eligible or vice versa as well. So I'll be more than happy if you can tell me, if there's any specific eligible criteria for 3-weekly versus weekly. All that I do know that, and all that we do have is either cisplatin eligible or ineligible, Vishwa. So there is your fundamental drawback. So, and you conveniently only focused on the Japanese data, but let me remind you, there's a lot of data apart from that as well. So let's start with the McKinsey meta-analysis. Even though there are only a few subset of patients who had adjuvant chemoradiation, those patients had only 3-weekly cisplatin, number one. And again, I think this is something that we all know. The benefit is around 6% at 5 years. And this is in both put together, both the definitive and the adjuvant chemoradiation arms. So don't worry, Vishwa. I think that might be your reaction right now, but don't worry, I'm not done yet. And let's look at all the major trials that have looked at adjuvant chemoradiation, the URTC study and the RTOG study as well. Clearly, I don't see any of those trials having used weekly cisplatin. So I don't know whatever gives you that false impression that weekly cisplatin is absolutely the gold standard. That's definitely not the case. And if you've not had enough, well, there's more to come. Let's look at all these studies. Again, the RTOG trial, the URTC and the Bajaj study as well. All of them have clearly used only 3-weekly cisplatin, have shown an improvement in DFS and local regional control clearly. And you might say that, okay, the overall survival is not statistically significant, but to me, this looks like it is statistically significant. I think you conveniently forgot this data, Vishwa. And let's look at all the other, I can just go on and on. There is so much data, and it's not necessarily all Japanese as well, Vishwa. So, and again, I think, let's talk about, being vocal for local and being desi. Let's not disregard Indian data. Like I said, I'm the Indian Tom and not the Japanese Jerry. Yep. So this is again the data which Vishwa also rightly pointed out. But let's look at the editorial, which says that high dose cisplatin still lives on for head and neck cancer. And you rightly said that this study looked at about more than 90% of patients received only adjuvant chemoradiation. Right. So this was the comparison. You spoke about 30 milligram per meter squared not being the ideal dose, but again, you also said that the cumulative dose is what really matters. And here they've looked at, most of them went on to receive at least 7 cycles. And I'll show you that data as well. And you spoke about, is it actually safe? And what about the safety concerns? Well, there you go, Vishwa. Compliance, 95% went on to receive more than 2 cycles, thereby reaching your cumulative dose of 200 milligram. That is your magic numbers. And look at the median cumulative dose, much higher with the 3-weekly cisplatin. Yeah, agreed, grade 3 toxicity was slightly higher, but your magic numbers of compliance and median dose of cisplatin goes for a toss. And this is real world data, as real as it gets from TMH, our own Indian data. And this was the primary endpoint of the study, and that was reached. You're talking about median overall survival. That was not the primary endpoint of the study, my dear Vishwa. So, I think they could not prove that weekly cisplatin was non-inferior, and that was the end take-home point for me from that study, and that should be yours as well, Vishwa. So finally, I'll get back to your study, and this is for the final nail in the coffin. I think this is the reason why we're having the debate as well, right? So the JCOG, the Japanese study, the Japanese study is what we are. Let me remind you, Vishwa, that is only a non-inferiority trial, and you're using a non-inferiority trial to show that it is actually superior. That's number one. And again, if you look at all the patients, the post-op high-risk features as well, what percentage actually had post-op high-risk features? Do you have the entire trial published yet? We're only relying on an abstract. Do you have the entire publication? I don't think so. The primary endpoint, and again, let me tell you that this was a phase 2/3 study, right? And you have a very short median follow-up of only 2 years. So hold your horses, Vishwa. I think, we need long-term follow-up before we even talk about long-term toxicity. You're only talking about short-term toxicity, but what about long-term toxicity? Do you have that data yet, my dear Japanese Jerry? No. So this is what you very clearly highlighted, saying that it's probably, much, much better. But let me remind you again, this is only a non-inferiority study, and looks can be absolutely deceiving. And these are the limitations. Like I said earlier, it's only a non-inferiority trial, and only the abstract is available. And the compliance, again, if you look at the median total dose, the median total dose was higher in the 3 weekly as opposed to the weekly subset. And again, very short follow-up. And you just claim that it is less toxic. But let me tell you, people coming in for weekly hydration and getting in their weekly regimens, yeah, it does take its toll on them. And that's the real world data as well. And if you talk about completion rates, I'm sure they'll at least complete 2 cycles of 3 weekly rather than complete all 6 cycles of weekly. And that's for sure, Vishwa, you can take that. So I think, and look at what the NCCN has to say as well. Clearly, I'm not even looking at the, definitive setting, because there's a clear winner. High dose cisplatin category 1, definitely. I'm not even going there. But in the post-op setting as well, yeah, I think it's definitely very clear that 3 weekly cisplatin is the standard of care. So to conclude, I think Vishwa, the key thing is that there is no 3 weekly versus weekly cisplatin eligibility criteria. It's either eligible or ineligible. And you have a lot of phase 3 RCTs, which you conveniently forgot about. The ORTC, RTOG, all of them have used only 3 weekly cisplatin. And the Indian data was also overwhelmingly in favor of 3 weekly cisplatin. And the cumulative dose was easily received as well. Toxicity, not a concern. You could do a 2-day split dosing as well. And so I don't think an abstract, and that too a non-inferiority abstract, can be practice-changing, my dear Japanese Jerry. So with that, I'll hand it over back to you, Vishwa, for your rebuttal, and then back to me for my rebuttal.
Yeah, thank you so much, Tom. You did try your best, but I have a few concerns with your talk. First of all, the EORTC, RTOG, and the McKinsey. So EORTC and the RTOG trial did look at 3 weekly plus or minus radiation. There was never a weekly arm. So it's absolutely beyond the scope of the debate. So was the McKinsey analysis. There was absolutely the authors did conclude that we could not compare the weekly versus 3 weekly. Again, beyond the scope of the debate. And then you yourself did claim that 84% toxicity was higher in the 3 weekly arm, and you yourself claimed that it was higher. And NCCN is usually very biased towards the Japanese jury and the Indian jury. They're usually very biased only towards an American jury, I would say. And then coming to the cisplatin eligibility and ineligibility, of course, those are all guidelines, but in real world, would you actually focus on those kind of guidelines? I wouldn't. I'm sure the majority wouldn't. Thank you so much.
Sure. Thank you, Vishwa, for that. I'll just quickly share my rebuttal slides as well, if you don't mind. So I think, Vishwa, you again said, spoke of the URTC and RTOG, but it's very clear that even those studies did not use weekly cisplatin. Agreed that they didn't compare between weekly and 3 weekly, but they did not use weekly cisplatin, and they did that for a reason. And again, what about the uncertainties about the dose of weekly cisplatin? We know that you yourself rightly pointed out in your debate as well, as to you can use the dose from 30 up to 50 milligrams. So what is the ideal dose? And the TMH data is not a weak comparator arm, because close to 90% received the cumulative dose. And the median cumulative dose, as I pointed out, was higher in the 3 weekly arm. So 3 weekly, if you're saying it's more toxic, you look at the dose reduction and treatment discontinuation rates from that study, Vishwa. They're absolutely similar. And you also spoke about the data being skewed because oral cavity, it had around 90% with the oral cavity. But that's the data. That's more a reflection of the real world data, even if you look at the Globocan 2020 data. If you look at lip and oral cavity, that seems to be the most commonest. And the TMH data, the results are applicable to both the HPV positive and the negative subsets, which I think you conveniently forgot about as well, Vishwa. Even though the incidence of HPV positivity is lesser in India, it's only around 20% across the board. And the primary endpoint of, again, loco-regional control was definitely statistically significant and in favor of the 3 weekly arm in the TMH data. Secondary, let's not talk about the secondary endpoints, PFS and OS, because they were definitely not powered adequately to answer that question. And better loco-regional control in the 3 weekly arm was definitely shown. Non-inferiority of the weekly regimen could not be proven. And again, to conclude, Japanese data, that's again only non-inferiority data. It's only an abstract. Definitely not practice changing. So I don't think you should claim superiority based on that. But then I agree, desperate times calls for desperate measures, Vishwa. So I think we have a clear winner. Okay, back to the organizers.
Thank you. That was indeed a very lively debate and a lot of points brought out from both sides. I'll call upon Dr. Vijay Patil, if he's there, to please give us his expert comments.
So Dr. Vijay has not logged in, sir.
Oh, okay. Dr. Arvind, you want to say something from the surgeon's perspective?
No, I think I really enjoyed both the points. Look, ideally, to sort of, we need an overall survival difference between, say, 3 weekly and weekly to actually give you solid evidence to choose one over the other. And when you don't have, I think I really enjoyed both the perspectives, and I think I just leave it to you. I think it just practice, like in the adjuvant setting, it all boils down to how fit the patient is. All those issues are important. Of course, we tend to use the 3 weekly whenever the patients are fit. But again, this is something that a lot of practitioners do use it, the weekly regimen as well. So I think there is a room for both. The guidelines also sort of, say at least the NCCN also says you have a category 1 and category 2B. I think both the options are viable options. You'll have to choose it in a case by case basis. And back to you, sir.
Indeed. I don't know whether there's a clear winner or loser in this debate. I think both of you have really won, bringing out, the points on both your sides very well. Thank you for that very lively debate. Let's go on. And our next session is a panel discussion on head and neck squamous cell carcinoma, biomarker-driven approach, sequencing treatment options. And our moderator is Dr. Amish Vora. Amish needs no introduction to this group. Vocal, debater, speaker. So Amish, all yours.
Thank you, sir. I have just been told that out of the panelists, I think, okay, Dr. Prabraj has joined. Kashish?
Not yet, sir.
Not yet. So we have 4 panelists, and I would request Dr. Raju Titus, sir, to give his opinion in between whenever. But before I start my talk, I just want to say something. Ever since I have seen Dr. Kripa Shankar in a nicely shaven beard, it reminds me of Pushpa fever nowadays in India. Like Pushpa is everywhere, so is Kripa is everywhere here. And so Kripa, you are also will be required in the panel in case, if it is there. So be there. And it's always good for the panelists to switch on their video. So always adds flavor to it. So topic today is biomarker-driven treatment sequencing in head and neck squamous cell carcinoma. And specifically, I have been given the topic of R-M, that is recurrent metastatic setting. It means that surgery and radiotherapy is no longer an option available. So we will be discussing about the systemic treatment. Can I have the next slide, please? So I understand Dr. Prabgar Manikam and Dr. Ayyappan CP are not there. Next slide, please. I was thinking, how do we change the way we are looking at it? So we all know that Keynote 048 have 4 years of follow-up. And 2020 NCCN guidelines did not have Pembro chemo as a category 1, but 21 and 22, we have category 1. Cetuximab also is category 1 as an established treatment, but it is in the special considerations. Next slide, please. So this is what I was talking about. Suddenly, we have IO as the preferred first-line treatment. Next slide, please. So this is where I would request the panelists to look at. This is the overall survival of various subgroups of Keynote 048. And the last right-hand corner, the bottom graph, I have put 2 arrows and 1 box. 19% of patients in cetuximab arm were doing very well. They were alive at the end of 2 years and then followed by 3 years. 35% of patients in the IO plus chemo arm were alive at the end of 2 years. And we all know it's 32% at the end of 4 years. So you always wonder, in my clinical practice, I always wonder that who are these patients who fall into these 19%? 35%. And the most important is, who are the other patients who are not going to respond to either IO or cetuximab or chemotherapy? And that is when the biomarker approach comes in the picture. Next slide, please. So I would start with Dr. Jagan Nivas. Dr. Jagan, I hope that is the correct pronunciation of your name.
Yes,
Dr. Jagan,
Jagan Nivas.
in your practice, yeah, can you, I always remember Dr. Advani sir always used to say that the patients who have received radiation in the past do very well on immunotherapy in head and neck cancer. I want to ask you that we all have patients doing extremely well on immunotherapy in head and neck cancer. Have you correlated any of the clinical features of these patients, Dr. Jagan?
Generally, we say any whoever have a smoking history, they may have a high mutation burden. Those patients may do well with immunotherapy. There is a normal general statement actually. And other than that, that is what the clinical thing we generally correlate, sir. And after radiation, as you said.
Correct. Dr. Vijay?
Yes, sir.
Would you agree on the same, or have you noticed something else in your practice? Male sex, younger patients, or anything, any specific subsite like oropharynx?
So far, what I have seen is patients were doing okay with cetuximab. I'm yet to see so many patients on IO for me to comment on that, because most of the patients go into oral metronomic. So to my experience, cetuximab has been doing well in certain patients. IO with few patients.
Which are those certain patients, Vijay? Yeah, which are those certain patients?
Really, who are able to tolerate chemo with cetuximab, the younger population. Has been doing well for quite a longer time than actually what we expect, because we don't really compare in this real world data. For what we expect, they are being doing good, tolerating the cetuximab along with chemotherapy. To the few patients with IO which I have seen have actually had a bad disease. So whether at all it was the bad subset which the IO did not work was not clear for me.
Absolutely right, Dr. Vijayan. That is why we are here, that we really don't know who are these patients who are not going to do well on the so-called category 1 ka bhi category 1 based on Keynote 048. Dr. Dhanraj, your opinion. I would want every panelist, we have 4 panelists, I would want all the 4 panelists to comment. Have they noticed any clinical characteristics which is correlating with response either to cetuximab or immunotherapy? Dr. Dhanraj? We have Dr. Dhanraj.
Dhanraj sir, are you able to hear us?
We have Dr. Shaufij.
Yes, sir.
Yes, Dr. Shaufij, please tell me.
Sir, IO, I don't have much experience in head and neck cancer per se, but if you look at the literature, HPV positivity is one thing which can be looked into in connection with the IO in head and neck cancer. Some literature says is HPV positive, then chance of working IO is little more compared to HPV negative subset. Other than that, I don't have any real world experience on that.
You don't have any. No. Correct. Dr. Shaufij, you are absolutely right, and we will come to HPV very soon. So there comes our Pushpa today. Dr. Kripa Shankar, your experience?
So I would probably add to what you just said as well, sir. Apart from the patients who've had prior radiotherapy, I think smokers, majority of them would have been smokers as well. And we know that obviously the mutational load is probably much higher in patients who have a history of smoking as well. So those patients also can respond better to immunotherapy. And again, this is based only on subgroup analysis that we've had so far. So I would probably take that as another factor into consideration. And then the biomarkers that we have, like the PD-L1 as well. We know the higher your PD-L1 expression, the better your magnitude of benefit is going to be with your upfront IO options. And if PD-L1 negative, then probably you lead in with cetuximab. And that's how I would look at it.
15% of PD-L1 negative responded on IO treatment. Let's not forget. And that's why we want to find out who are these patients. Dr. Raju sir, in your practice, whether it is oral metronomic genomic treatment or whether it is a high dose cisplatin treatment or cetuximab or IO, have you any correlation? Because biomarker is to identify the select group of patients which will respond to select treatment. Before we move on to biomarker, do you have any clinical experience, sir? Sir.
So really, my experience with these, especially cetuximab and the IOs, is very little for me to make generalizations. Just on a humorous note, all this depends on how deep the patient's pockets are to be able to actually afford it. So that's one part. But other than that, I really can't, point my fingers to any particular clinical correlate that says, okay, this patient is going to respond or this patient is not going to respond.
Right, sir. So, but if you see majority of India, they work on CGHS, ESI, Bharat Yojana, Prime Minister Yojana, multiple things. In fact, people with deep pockets are not as deep as these people, but that is discussion for some other topic. Can we have the next slide, please? Okay, so in this version 1 of 2022 NCCN guidelines, I see only 2 places where there are biomarker-driven treatment approaches. One is where I have put the red box, red arrow, and the second is at the right and bottom of this pembrolizumab for MSI high. Otherwise, everything else is non-biomarker driven. Next slide, please. Okay. But, and here comes, do we still have Dr. Dhanraj joining? I have not heard from him. Okay.
Hello.
Dr. Dhanraj, yes, we can hear you.
Yes, sir.
So, Dr. Dhanraj, this is the sentence which I have put it in the blue. Next generation sequencing may be considered to guide patient treatment options. And that is what Dr. Krupa wants us to do. How many times, Dr. Dhanraj, do you do NGS in head and neck cancer patients?
Not even for a single patient, sir. That's for sure.
Not even for a single patient.
Yes, sir. So as of now, the data is very strong.
Dr. Jagan, do you do NGS ever in the natural history of head and neck recurrent metastatic disease patient?
Very rarely, sir. 1 or 2 patients we have done. Those are very highly affordable. In those cases, if they pressurize, they themselves will come with the opinion, please do all these things, then we will do. Normally, we don't do more than this PDL1.
More than PDL1. Dr. Shafij? Dr. Shafij, we can't hear you.
So I have not done for anybody so far in my clinical practice for head and neck cancer.
Not done anybody so far for clinical practice. Can we have the next slide, please? Okay, so the biomarkers which are available and which probably we should all be aware about is PD-L1, HPV, or P16, depending on the test which you perform, MSI, microsatellite instability, tumor mutation burden, and neurotropic tyrosine receptor kinase is NTRK, what is famous as. Next slide, please. So this question is for Dr. Krupa Shankar. A recurrent metastatic head and neck cancer patient, first line treatment, MSI is high or tumor mutation burden is say 20 mutes per megabyte. Pick any one of them. But PD-L1 is negative. Would you give first line IO to this patient?
No, sir. My choice would not be. If this is a de novo patient, or if it is a de novo, I'm assuming that this is a patient with de novo metastatic disease.
This is a de novo patient.
Perfect. So again, I would probably go with the extreme or the TPEX strategy here, TP extreme strategy here. I would much rather use cetuximab rather than go on to pembro here in this setting.
Cetuximab rather than go on the pembro. But PD-L1 more than 20% single agent pembrolizumab is category 1. And we all know that MSI high is a better biomarker for immunotherapy response. Krupa, CRC, initially it was third line. Now it is first line. And there is a tumor agnostic indication for MSI high based on keynote, I think 177. So why would you not use when Pembro already is approved as a first line? This is a better biomarker.
Very true, sir. But the problem is we're extrapolating from colon to head and neck. So that's like from, for me, as far as I'm concerned, probably apples and oranges. So I think we really have to wait for that data unless and until we have something of the similar sort in head and neck as well. I think because we're probably using such an expensive drug and we'll have to justify the cost to the patient as well. And you'll have some data to go by. At least if you have a PD-L1 of more than 20%, you would say, okay, fine, I'd expect so many of you to respond and the duration of response to be for such a long time. So I think it makes sense for me to do it, at least for the time being now, sir. And probably in the future, we might have MSI high and TMB as well as markers.
And TMB as well. Dr. Dhanraj, you would agree with Dr. Kripa?
Definitely, sir. Definitely. Right now, only PD-L1, no MSI, no TMB.
No MSI and no. And I think, we will not take this forward. We'll move on. And I agree with all of you. Next slide, please. I was looking at that tissue agnostic approval, which was there in 2017. Next slide, please. Okay. And in this, I was surprised that there was not a single head and neck squamous cell carcinoma patient involved. Next slide, please. So let's look at the other scenario. Dr. Shofich, we all know that in 2017, pembrolizumab, 2018, larotrectinib, and 2019, entrectinib. These are the three tissue agnostic approval is there. If NTRK is positive, assuming that 1 to 2% of your rich patients have got NGS done, suddenly out of the blue, NTRK is positive. Would you offer larotrectinib or crizotinib if it is available as the first line?
Sir, no answer. I'm not prescribed for anybody so far, so no idea.
Not prescribed anybody so far. I have been doing NTRK. I have yet to be, sort of fortunate. The point is that this is the biomarker available. It has been approved as a tissue agnostic. And remember, in a phase 2 data, the response rate was close to 55%. Clinical benefit ratio was close to 89%. But as Dr. Krupashankar said, we do not have the data in the first line. And in the first line, this biomarker is not there. Next slide, please.
I think the approval is only for salivary gland tumors, not even for head and neck cancer.
You are absolutely right. In head and neck tumor, NCCN guideline is not there, but only issue is that it is a tissue agnostic, all solid tumors, if you see the FDA approval. But I completely agree with you. None of the guidelines have taken NTRK. I had one patient who was referred by another medical oncologist and another medical oncologist. And his NTRK2 fusion was positive, and that's why I put that here. Okay, let's come to the crux, which is important for India. And I will start with Dr. Jagan. Yeah, Dr. Jagan.
Sir, regarding the previous answer, when the MSI is high and TMB, then the PD-L1 is negative, if the patient wants or if they are not willing to take chemotherapy, in that case, it's a practical thing I'm telling, not based on any scientific.
Yes, your NCCN guideline mentions that in a special consideration, special circumstances, pembrolizumab in MSI high. Dr. Jagan, my personal experience, I get mad when I see MSI high report. Almost all the patients are doing well, whether you give Pembro, whether you give Nivo, they all are doing well. And MSI high is a different disease altogether. So Dr. Jagan, to you, do you routinely do HPV testing in all your recurrent metastatic head and neck cancer?
We are doing, not in all patients. Not in all patients we are doing, but frequently we are nowadays asking for HPV just to tell about the prognosis. But every patient we are not able to do it.
Okay, tell about prognosis. Dr. Vijay, what about you?
I am not doing that as a part in metastatic cancers. So anyway, it is a single patient. I don't know how to prognosticate them. It's telling you will be better than the HPV negative is hard for them to accept.
You are so right, Dr. Vijay. And ICRIN data of adjuvant setting, we are, I think, waiting for decades and ages for it to mature in adjuvant setting to see for radiation dose. Next slide, please. So, again, Dr. Shofij, before Dr. Shofij, let's go to Dr. Dhanraj. He has spoken very little so far. Dr. Dhanraj, HPV P16 positive. Will that change your treatment decision in the recurrent metastatic head and neck cancer?
No, sir. So it is not a predictive, it's just a prognostic. So the treatment will not be changed based on HPV or P16 positivity. Either IO or cetuximab 2.
Okay. So, Dr. Dhanraj said, Dr. Shofij, you agree with Dr. Dhanraj?
Sir, in literature I read that it is, if it is positive, then IO can be preferred. I don't know. I not used it, but
if it is positive, IO can be preferred. Kripa, we have one more biomarker other than PD-L1. What is your thought about it?
So I think in the metastatic setting, probably we can't use it for decision making. So that's that would be just my take on it. Because number one, I think as far as the incidence of HPV positivity in India is concerned, I think it's much lesser than in the Western countries. And that's something which we have seen as well. It's more of the tobacco-related malignancies here, which actually contribute as the key factor. So, I mean, like, to me, I wouldn't use that as to make my decision between IO and cetuximab. Wouldn't rely on just the HPV status.
Shankar, I have a complaint against you. In your debate also, you used that HPV incidence is too less. Here also you are using. We are in MOSCON right now. We are looking at 5%, 10%, 15% scenario. And look at ALK positivity in non-small cell lung cancer, and we have debates after debates on that. We will not go into that. Dr. Ghanshyam Biswas is trying to do P16 in all non-tobacco, and he thinks that HPV positivity means cetuximab will not work. Dr. Ghanshyam Biswas and Dr. Kripa, my molecular oncologists, do not agree with either of you two, and I'll tell you why. Next slide, please. So this was a meta-analysis which said that HPV negative did fare poorly with IO compared to HPV positive. But the interesting fact comes the next slide. Can I have the next slide? This is Checkmate 141 NEJM publication, which I have taken, and I have put the box in the bottom. Okay, PD-L1 negative, P16 negative. And look at the third column, median survival, 7.1, and median survival with standard chemotherapy 7.4. This is the only subgroup which did not benefit with IO. PD-L1 negative and HPV negative. But the other way around, and as one of our panelists said, look at one row above. P16 positive, but PD-L1 negative. The median survival is 10 months, which is the highest in all the subgroups. Please do not read too much into this because the numbers are less. As you bifurcate the subgroup, the numbers are less. Point is that, biomarker-driven approach will help us if we look at these. Next slide, please. So, Dr. Ghanshyam is here. Dr. Ghanshyam, let me get you, unmute yourself. If your patient is PD-L1 negative and HPV negative, would you ever offer IO to that patient?
No, so if I have an option for a cetuximab-based therapy, so I'll go with the cetuximab-based therapy.
You will do cetuximab-based therapy. Any of the panelists disagrees with that? Because I agree with that. Based on the current, this and biomarker-driven sequence approach, if PD-L1 is negative and if HPV is negative, I think IO takes a backseat compared to cetuximab or other chemotherapy options. If any of the panelists disagree, or they agree, then I'm happy that we have reached the first consensus in biomarker driven. Next slide, please. Can I have the next slide? Okay, so another scenario. Again, anybody who is NGS, this thing, Krupa, again, you are this. So first line treatment, PD-L1 CPS is 7%. NGS shows, I send you the paper and you say, sir, aapke paas to sare Amir patient Delhi mein hote hai, and this one of these Amir patient comes with NGS report of STK11 present. But CPS is 7%. would you offer IO to this patient?
So again, I think we have a lot of data from the lung cancer setting as well, where patients with STK11 and KEAP1 mutation, these two mutations, they don't seem to derive that amount of magnitude of benefit as opposed to the others when compared to patients who don't have an STK11 or a KEAP1. But having said that, I think the numbers are too small for us to make any meaningful conclusions from only that subset of patients, sir. So I think I would definitely look at IO as an option based on the PDL1 alone. I wouldn't read too much into the STK11 or the KEAP1 mutations.
Read too much into the STK11. Okay. Dr. Krupa Shankar on one side says that he will not extrapolate data from one to another, but here he won't mind doing that. Okay. Dr. Vijay.
Yes, sir.
STK11, have you come across any of these? If you have not come across, it's okay. These are all very rare, and because I have been given this topic, so I have to prepare. So don't worry if you have not come across any of these situations.
To be very truthful, I don't even do NGS in a head and neck setting. Only for PDL1, if rarely some HPV. That too, I don't think practically is.
You don't think of this. Dr. Dhanraj, you have any experience or anything to say in this?
No, sir, no experience at all, except for PDL1 CPS.
Nothing at all except for the PDL1. Okay, perfect. The next slide, please.
One question, sir. STK11 and another mutation. I could not get that one. That will work.
That's what is written here in this slide.
Okay.
So this was November 2021, 3 months back. And this is very interesting. I didn't know this. I always knew STK11 and KEAP1 means don't give IO. But this paper said that in lung cancer, STK11 and KEAP1 will reduce immunotherapy efficacy only if KRAS mutant lung cancer is there. If the KRAS is wild type, these mutations does not matter. And you can continue doing immunotherapy based on your algorithm of PDL1 or any other criteria what you are following. Next slide, please. So, I think, we all are, sort of very naive, and this is, I wanted to, again pull leg of Krupa, but we will keep it for some other time. Prevalence of KRAS mutation is 3.5% to 5% in various. So this is not a less amount. The idea is that if any of you ever get any of these mutations, especially Dr. Jagan, since you asked that question, if you have either STK11 or KEAP1 or any other mutation like that, which come in the future, kindly look at KRAS mutations also. If there is a KRAS mutation, probably IO will have an inferior efficacy. Next slide, please. Okay, NRAS mutation present. NRAS mutation, again, Dr. Jagan. Yes. KRAS, NRAS, PNRAS mutation, colorectal cancer, no for cetuximab. Would you do the same in head and neck cancer? This is again one more biomarker.
Actually, I don't have an idea. Just now we were saying we should not use IO. That alone I know from the previous one. I don't know about the cetuximab.
No issues. These are all something new. I think after 5 years or 6 years down the line, we will be much more wiser, and there will be more data also. These are basically just to keep all these things in mind, so that if an affording patient spending a lot of money, we should be more careful in offering them. And that's the reason these sort of discussions are there. Kripa, would you give cetuximab when NRAS mutation is present? We don't have any data in head and neck.
Correct.
Don't extrapolate.
Correct. So yeah, so I would probably end up giving cetuximab, sir, irrespective of whether the patient's got an NRAS
mutation. You will end up giving cetuximab. We have our friend Dr. Ghanshyam Biswas still there. Ghanshyam, would you give cetuximab if NRAS is there?
Yes. Yes.
You would give cetuximab. Okay. Next slide, please. So this is a Cancer Biology and Medicine original article that what are the biomarkers where cetuximab resistance is there in head and neck squamous cell carcinoma. So we are not extrapolating, we have, and this is a very nice article from France. Next slide, please. And if you have RAS and PIK3CA, we all know PIK3 is the downstream pathway, of the RAS, and if you block RAS or if you have blocked PIK3, the effect is the same. Look look at the wild type and the mutated type. In fact, cetuximab has inferior most outcome. Look at this data. I knew about NRAS because NRAS is more common. I didn't know about PIK3CA, but yes, nowadays we are seeing a lot of PIK3CA. Like we used to earlier say, used to see TP53 mutation in earlier set of NGS. I'm seeing a lot of PIK3CA, probably because of downstream pathway getting affected. So if your patient has NGS done, or if you want to get an NGS done, or if you really want kisko cetuximab do, kisko immunotherapy do, probably PIK3CA or RAS gene mutation can be helpful to patient. And this can answer why only 20% are benefiting cetuximab, why not 80%? And STK11 and KRAS can tell us why 65% are not benefited by IO. This is a major chunk and a huge amount of money. Next slide, please. I think I'm last on my last 1-2 slides before Kashish tells me to wind up. Next slide, please. Yes, sir. Within 1 minute, I'll finish. So this is my last slide. And then I would like Dr. Raju Titus Chako to summarize and give his comments. So first line treatment, NGS, if possible, I personally think will be afterwards. If HPV negative and if PD-L1 negative, rethink about immunotherapy. If RAS or PIK3CA is positive, I think I would not give cetuximab there. If STK11 and KEAP1 positive for mutation to generate the data in head and neck cancer, because Krupa Shankar wants those data, put them in a clinical trial. That is also one of the top on this time. MSI high, I agree, it is still in the second line, but as Dr. Jagan said that if patient does not want chemotherapy, we are justified in giving pembrolizumab in the first line. TMB, again the same thing. No, I'm not very convinced about the TMB data as yet. NTRK, we do not have enough data in head and neck cancer, so that is something which we need to keep aside for the time being. This is what the clinical scenario right now as biomarker-driven approach. Over to Raju Titus, sir. Thank you so much, Kripa, for giving me this opportunity.
Thank you, Amish, and all the panelists for that great panel discussion. Amish actually, kind of summarized very well. Really doesn't require me to do more of a summarizing. I would say that, head and neck cancer being a major problem in our country, it would certainly be great to get biomarkers done here to figure out, which of our patients are going to, benefit from which treatment. But as of now, what was discussed in the panel is what we have. Well, looking forward into the future, I'm sure all you young guys, we're going to get much better at this. And when we have the same discussion, maybe a few years later, we will have much more to say. Thank you. Dr. Arvind, please take over.
Yeah, I think we'll move ahead with the. We have one more debate. Okay, so, PD-L1 positive de novo metastatic cancers. And just to add to the previous thing, I think I enjoyed the panel. It's just that we need the good biomarkers in head and neck. Unfortunately, we don't really have many apart from the clinical stage and maybe HPV. Somehow we don't really are we looking at the wrong targets is something that is there. So PD-L1, of course, is a good biomarker, and now we have two wonderful debaters. One is Dr. Abhi Chandrakant. He is going to speak on the Keynote 048 regimen as was discussed, and next would be Dr. Bharat, who would speak on the PX regimen. And I think Dr. Chandrakant, are you going first? I could call this from Dr. Chandrakant, you there?
Yes, I am there. I am just sharing.
Yeah, please go ahead.
Yes, sir. Okay, sir. I think thanks, Arvind, sir, for the introduction, and I would thank Krupa for the opportunity. So, well, I think we've already discussed and everybody knows what is the thing for debating and for keeping it a little interesting. I've made few slides. I think maybe that will serve the purpose. Well, we should, before I start the debate, I would request everyone to again read the debate topic. It is role of immunotherapy in PD-L1 positive de novo recurrent metastatic head and neck cancer. So, the moment you look into the title, I think it's almost about match fixing, probably a fixed match with Krupa. You can see two things, PD-L1 positive, the criteria is there, and I have two strong players. I have both Pembro and I have Pembro chemo. So when it is PD-L1 positive, the pitch is mine and the players are mine. So I don't think I'm going to lose it, but doesn't matter how strong I am when the opposition is there. Definitely, whatever it is, in whichever ground you play, whatever fix you do, probably I will lose. So this is what I probably think, and this is the scenario where I am in when I look at Bharat sir being there in the other side. Well, so these are the two strong players I have. If I look at Pembro versus Pembro chemo, so Pembro will anyways defeat the competing extreme regimen in terms of overall survival, and Pembro chemo will defeat extreme regimen in terms of response rates and progression-free survival. And instead of showing multiple slides, this is all the final scorecard of Pembro IO versus extreme, and this is the scorecards. You can look into all the three: overall survival, progression-free survival, overall response rates. In each, you can look into the scorecards. If it is CPS more than 20 or CPS more than 1, the scorecards are better for IO versus extreme. You can see 14.9, 10.7, 5.8, 5.2, 54, 50, 42. So in all the scenarios, IO is the winner when compared to extreme. So this is all it says, and I don't think there is anything to debate, but still I will show you the few curves. This is Pembro mono versus IO, overall survival in more than 20%, 14.9, 10.7. And again, this is the overall survival in patients who have CPS. And then this is the toxicity. You can see if I use Pembro chemo versus extreme regimen, look at the toxicity. Toxicity is far less. You can see the blue one, the dark blue one going up, and the light blue is less. So Pembro is far safer than extreme. And then this is the conclusion. In CPS more than 20 or more than CPS more than 1, Pembro is a winner over extreme regimen. So, well, if you look into the overall survival of Pembro chemo versus extreme in CPS more than 20 or CPS more than 1, in both, you can see Pembro chemo being the winner. And you can see the subgroup analysis, irrespective of any subgroup, irrespective of where you stay, everything, Pembro chemo is the winner when compared to extreme. And this is the hazard ratios for progression-free survival. I agree, if you take Pembro mono, then probably extreme would have been a winner when you come to PFS. But if I take Pembro chemo as the competitor, then you looked into the scorecard where Pembro chemo is still the winner when compared to extreme regimen. Response rates, I did show the scorecard. Response rates, Pembro chemo is the winner over extreme. Whether it is CPS more than 20 or CPS more than 1, Pembro chemo is in par or at least better than the extreme regimen. So, and if you look into the subsites, Asian subset was there, but India was not included. So we cannot take the Asian data onto Indian data. So if you look into the Asian subgroup, Pembro mono has done better over the extreme, whereas if you look into Pembro chemo versus extreme, somewhere there was no overall survival benefit, but it's only Asian and not Indians. So, well, what are the points probably against immuno-oncotherapy? Probably if I use Pembro mono, less response rates and less PFS because of crisscrossing, but that can be overcome by using Pembro chemo. So in bulky disease, I want rapid responses. You can see the scorecard, comparative responses in a PD-L1 positive subset. Asian, no overall survival, probably we are not pure Asians or we are not Caucasians, we are in the middle. Cost, so Pembro is as expensive as cetuximab, so cost is not an issue. 5FU we will not use. That's fine. We have data for taxane platinum Pembro in other sites, probably taxane platinum. Just like TP extreme, we have
TP Pembro, I think that should do well. And sequencing is another one where I use for subsequent line. It makes much more sense when I use the best therapy in the upfront setting to get overall survival. So be careful if you ask for a second chance. It's not the same as the first one you screwed up. The bar is set much higher. It is difficult to treat in the second line than in the first line. So do not listen to fancy things like better responses, better progression-free survival, crisscrossing. Be calm and listen to overall survival, which is the gold standard endpoint. Be patient and use the best drug to get the overall survival. So thank you. I think I made a very crisp and short. There's nothing much to say. And I'm very interested to listen to Bharat sir than myself. Thank you.
Over to Bharat sir.
First of all, are my slides visible or am I audible?
Yes, sir.
First, let me thank my organizer for a kind invite. Let me thank Chandrakant for putting a very good point. But let me tell you what is the right approach to be, and I'll be telling you, Joe, people don't see. So let us understand that whenever we talk about more than 1, more than 20, we need to understand what about 1 to 20, and that is the crux of my presentation. In fact, in the next 7 minutes, I'll be telling you my good points, and let me tell you what are the other drawbacks of the other study. Let me thank my dear friend Kripa for the kind invitation. So I am talking about vehemently about TP Extreme. Now, you know this famous movie, which is called as Anand, and I don't know, at first time when you see, you realize who is the hero of the movie, but subsequently you realize what I say, and I'll prove it in the next 6 minutes. Now, when you treat a cancer, what are the goals of treatment? Simple, what Chandrakant said, good, better response, stop progression, quality of life, and survival. So when I talk about TP Extreme, I am discussing about a drug which is a single day, contain active principles of dosi, cis, cetuxi followed by cetuxi maintenance. So a single day, first advantage. Now, when you look into the phase 2 study of GOTEC, 44%, 6.2, 14, please try to concentrate on these landmarks rather than anything. You should be at the end of the day, you are looking at OS. And this was the earlier study. Now, when you look into the TP Extreme data, which compared with Extreme, a single day, only 4 cycles of cis, dosi, cetuxi followed by cetuxi maintenance. Now, let us look into the response. 46% response overall, not being achieved with a keynote 048. Always more than 20, more than 1 was being discussed. OS 14.5 months, as good as more than CPS 20's data. It is a single day versus a 5-day schedule. And more importantly, lesser toxicity. Now, let me talk about toxicity of TP Extreme. Delays in administration, 10%. Toxicity, only 34% grade 2, 3, 4. So you are looking at a drug which the grade 3 to 4 is only 3 of the 10. 73% of the patient were able to go to the maintenance. So a drug which is tolerable, efficacious, and more importantly, less of a toxicity, and more of the people are able to tolerate. Now, this is something that we keep on discussing, that there was no improvement in OS. Please remember, the extreme arm did well. What we are discussing about TP Extreme is a 46% response with a median overall survival of 14.5 months when we discuss about keynote data. Now, this is something which we never discussed. What was the overall endpoint? When we look into the treatment or the trial, we look into OS. So what about the treatment endpoint of those who took IO in the second line? Please remember the drug, probably a patient affordable or patient who were able to take IO. These were around 17% of the patient. And when you look into it, you are getting a OS of 21.9 months. Please remember 14.5 for those patients who are able to take both the drugs. It is 21.9 months. That is something which is amazing and has need not to be forgotten about. The same thing re-emphasized. If you are able to give your IO post a cetuximab, probably it works better. And that is a concept that I am to discuss. Now, why does it happen is because of immunoadjuvant effect of Taxol and cetuximab. Basically, what happens is when you give a chemo with this, there are more number of inflammatory milieu in the cell and less of a Treg. So probably a combination of Taxol and cetuximab provide a better immune environment. And that is why probably the IO works well. What about quality of life? So a better quality of life in terms of global physical role. Again, about emotional cognitive. So in all, a good drug, better drug with a maintained or a better quality of life. So this data suggested that 14.5 months is the OS. Overall, 21.9 months when you are able to give IO in the second line, and more importantly, improvement in quality of life. Now comes, do we have an Indian data to it? So I will remind my friend Chandrakant, who was a second author in the study of cetuximab with IO in the second line. He has only published it, I am not telling. This study also suggests that there was 20.6 months OS when Taxol cetuximab was given in the first line, followed by IO in the second line. So it's two data suggesting that 21 months, this has never been reached in any of the studies. Now let me discuss in 1.5 minutes about Keynote 048. Please remember, you have already read what ESCO says, but you have never read about what they have submitted to European Medical Agency. This is a 165-page dossier. Please review it. There were 10 amendments which was done by Keynote 48. When you look into the gross amendment, they did not randomize. For the last 180 patients, they took patients only with a strong PD-L1. So the first diagnosed 10 amendments, they started with TPS, changed to CPS, took CPS 10, then ultimately lead to CPS 20. And drawback 2 was last 180 patients were purposefully taken who were PD-L1 and enriched. Now everybody, I'm agreeing it is more than, it is positive, but you include 1 to 20 also. So this was something that was submitted by the IMA from the author. Up less than 20 and less than 1. So if you look into the serve, now look into the OS. Single agent Pembro 10.8 with chemo 12.7, which is much less than what you are talking about. So my point is the entire benefit of study was driven by patients with CPS more than 20 only, with minimal less than 2 months improvement or no benefit in patients with less than 20, which constitutes up to 70%. So you are looking at CPS less than 20, which is 70%. And if you see the quantum of benefit, take out more than 20, and you see the quantum of benefit is very low. The same thing has been told here. 12.7 when chemo with immuno was given, and 10.8 with a single agent Pembro. And when you look into the overall intent to treat population, it was higher in intent to treat. So what you look into 1 to 20, the combination of chemo with IO does not give a benefit. You see about your progression. So hyperprogression, again, a very big headache in head and neck cancer. In fact, everyone will agree that hyperprogression is probably more commoner in head and neck cancer than any other cancer. Around 29% of the patient had hyperprogression. And that has been substantiated in various trials. Now, the most important thing, again, when you look into 4-year survival and when you look into the number of patients, out of the 22 patients in CPS more than in Pembro mono, around 17 patients were those with CPS 20. So only 5 patients out of 257 had a survival of 4 years with Pembro mono. Same thing here. Only 7 patients with a chemo IO in those with a PD-L1 1 to 20 had a survival at 4 years. Again, I am trying to re-emphasize that long-term benefit again only in patients with CPS 20, more than 20. 1 to 24 or 7 patients were surviving at 4 years. That is the point. You should always read between the lines. Remember your latest Checkmate 649 study, which suggested the same thing, that you should read 1 to 20. Is there a response or is there a OS advantage? So my last slide is, why should I choose TP Extreme in the first line? Overall, a drug with a better response rate, 46%, 6.2 months, PFS and better or equivalent OS in the entire population, which is irrespective of PD-L1. So you don't have to depend on any biomarker. Your survival is 14.5 months. For the subset of patients who are sequenced from cetuximab plus taxane, followed by immunotherapy, that was 20 months, and it was 21.9 months in the TP Extreme study. Data from the Indian population, which my dear friend MV Chandrakant has only published. I'm not telling you. Overall survival advantage of second-line immunotherapy is utilized in the better way. Only one study in a phase 3 in a second-line Checkmate 141, that is Nivolumab, which has a category 1 recommendation, and that has used immunotherapy. 1-day schedule against a 5-day schedule, and last but not the least, for a Garib Indian Janta, PAP is always available, which is 1 lakh per thing. So if I have to summarize my take-home talk, I agree Keynote 048 is a good data, but only for patients of more than 20. I have put my long-term data, I have put my all the data. So sequencing by utilizing all the active agents in the better way leads to improved overall survival. You have 3 active drugs you have to utilize. So the best sequence should be cis-dosi cetuxi, followed by nivolumab as well as Checkmate 141, and followed by a metronomic therapy. I had shown you the movie of Anand, but you realize who is the ultimate and evergreen superstar? It is Amitabh Bachchan, and Amitabh Bachchan is TP Extreme. So I end my talk with a famous quote of William James: act as if what you do makes a difference. Certainly it makes a difference. You need to sequence your treatment by getting all your active agents, and don't go into the overall subset. Try to look into the subset who really work in Checkmate 048 and or I beg your pardon, Keynote 048, and then make a final opinion. I thank the organizer for a kind invitation.
Any brief rebuttal?
Okay, sir. I think it was wonderful, sir. I expected that CPS 1 to 20 would be the target, but Bharat sir has looked into, but I don't understand why NCCN guidelines have not yet still looked into it. So even now, the preferred regimen in the NCCN guideline is the Keynote regimen, and cetuximab comes in the other recommended regimens when this is not preferred. So this is one thing which I would bring. And secondly, we have comparison of the Keynote regimen with the extreme. So we should have a TP Pembro versus a TP extreme. Only then I can say that probably TP extreme is better. So we cannot compare cross-trial comparisons and say that TP extreme is better. But having said that, what you need is a tail in the tail, So you want long-term survivors, and you should get the best drug in the ultimate. You cannot keep it reserved, because we see the 30% patients in head and neck cancer do not even reach the second line setting. So with this, again, I would rebut that we should be using Pembro chemo, even if CPS is more than 1. But I totally agree with Bharat sir. If you have to have a conclusion, CPS 1 to 20, the benefit is not that great, and I agree with that, sir.
Dr. Raju, because he has agreed with Dr. Bharat. So I guess you and then maybe Arun can sort of sum it up. So
you want to say something?
Sir, I agree with what Chandrakant said. The main point is that the entire benefit of Keynote 048, the problem was that the data which I had submitted was submitted later on, because IMA insisted on it that please tell us the outcome of 1 to 20. And here the real facts come out. Everybody knows that higher the PDL1, the better. But in this trial, if you go through the details of the trial, even in a tail of a tail, what he said, only 4 patients in CPS 1 to 20 with Pembro mono, and only 7 patients out of 150 patients in PDL1 1 to 20 with chemo immuno was surviving. So the problem again comes is how you interpret your data. More than 1, or you should have 1 to 20. So probably in future, when we look into data, rather than looking at more than 1, more than 20, we should look at less than 1, 1 to 20, and more than 20. And probably where the quantum of benefit, we will realize what it is. And sir, one more thing is, sir, in clinical practice, nobody gives a 4 or 5 days infusion nowadays. So when you talk about strictly Keynote 048, hardly anybody of us is following 4 or 5 days, a 5 infusion that were, and with immuno. Most of them, they follow what Chandrakant said, that TP Pembro. And I probably think a future trial, if you can have both the drugs, I think both will be equal, sir. But you have to, I think the only marker, what I agree with Mura, sir, is more than 20, yes, go ahead with the immuno combination. Less than 20, yeah, you have to see a bulk of disease, a highly fastly growing tumor, a very extensive metastatic, probably cetuximab should take over because it has a better response and probably a faster response rate. So you have to, as per a scenario, I think so, the treatment should be even in 1 to 2.
Thank you, Bharat. Points well taken, well made. Can I ask Dr. Rajkumar Ramasamy if he is there to give his expert comments, please?
So Dr. Arun has gladly agreed last moment to give the expert comments.
Okay, Arun, please go ahead.
Hello, sir. Actually, it's wonderful. Actually, both of them have nicely enumerated all the points. And as both the debaters have said, it's about CPS score 1 to 20. That's where all the discussion was. One point is the immunotherapy, what we have is a durable response when compared to the cetuximab. Although the response rate, if you come head to head, you compare, you get more durable response with immunotherapy. And definitely 1 to 20 is an area where we should put our minds into it. And probably if the disease is bulky, we want rapid response. Definitely we should add chemotherapy if immunotherapy is planned. Otherwise, definitely other alternative is cetuximab. And CPS score less than 1, I don't think there is much of debate. And CPS score more than 20, definitely immunotherapy as a single agent. Or if we need a rapid response, adding chemotherapy to it will be a wise choice. Okay. Thank you. It's wonderful, actually, wonderful debate by both of you. Thank you.
Thank you, Dr. Arun. Let's go on to the last talk of the evening. HPV-based escalation, de-escalation strategies in head and neck squamous cell carcinoma. And Dr. Arun,
yes,
who just gave those expert comments, is now going to take us through the next 15 minutes or so. Arun, please take it.
Yes. Are you able to see my slides?
Yes, we are.
Okay. Thank you. I thank Dr. Kripashankar for this opportunity. Wonderful conference. And I think this is the last session, so I won't take, most of us are hungry, so I won't take more than 10 minutes. I'll try to wind up in 10 to 12 minutes. So the topic is HPV-based escalation or de-escalation strategy. So in head and neck malignancy, particularly oropharyngeal cancer, we know that evolution, how it all happened. Initially, it was definitive radiotherapy. Then we all turned to function-preserving surgeries. Then after MAC-NC meta-analysis came, where concurrent chemoradiotherapy was used. And now, last 10 years, if you see, we know that the HPV positivity, particularly by IHC and P16 positivity, as a significant prognostic and predictive marker. So now a lot of de-escalation trial, particularly in oropharyngeal malignancy based on HPV positivity is happening. And next few slides, I will try to enumerate all the trials, all the key outcomes of the trials, and we will see how much we can use that in our clinical practice. So head and neck malignancy, we know, is the most common malignancy what we see, particularly in our area because of smoking and tobacco-related product usage. And two key factors that has both prognostic and predictive is smoking and human papillomavirus infection. If you see the smoking, and most of the trials have used smoking, particularly more than 10 pack years, is a high risk for poor outcome, and HPV has shown to be a good outcome factor. So all the epidemiological association, we see nearly 70% of the oropharyngeal cancer associated with HPV positivity. And if you take all the head and neck malignancy, almost around 20% we see HPV positivity. And if you see the response rate, this and all the meta-analysis you see, the HPV positivity has a significant better outcome, both in terms of overall survival and progression-free survival. This is a RTOG trial where the overall survival is 82% in comparison to HPV negative group, which is 57%. And all the meta-analysis has proved the same. So if you see approximately 25%, we see greater survival in HPV positive population. So you have a good subset where particularly HPV positive patients are doing very well. So on other end, we have the toxicity, both acute toxicity and late toxicity. So ultimately, most of the trials have focused whether we can reduce the toxicity by reducing the dose of definitive treatment, but we need to preserve the long-term outcome. So various strategies has been used. So all the strategies of these de-intensification studies are either they reduce the radiation volumes or they try to reduce the dosage from 70 gray to 50 gray, and they try to alternate the chemotherapy to cetuximab. They try to reduce the dose of chemotherapy. So these are the various ways they try to de-intensify the treatment, and they try to see whether by de-intensification they are able to maintain the same outcome but decrease the toxicity and improve the quality of life. So this is the crux of all these trials. So if you see the first term, surgical resection, so many of the trials post-surgical resection, they risk stratified into low risk and intermediate and high risk. In low risk and intermediate risk, they try to de-escalate treatment, but in high risk, they try to maintain the standard arm. And in clinical risk stratification, all cases based on the T stage and nodal stage, they try to risk stratify. And in induction chemotherapy, post-induction chemotherapy, based on the clinical response, they try to risk stratify. And again, in low risk, where they had a good response, they try to de-escalate treatment. So two important trials, for me, two important trials are these two trials, where both the trials try to replace the cytotoxic chemotherapy cisplatin with cetuximab, and they try to assess the outcome and toxicity. This is the RTOG 1016 and de-escalate trial, very important trial. So first, let us go to the RTOG trial design. So they selected all HPV positive, P16 positive oropharyngeal cancer. They stratified and they randomized into cetuximab arm versus cisplatin arm. Here they use cisplatin 100 milligram per meter square for 3 doses they used, along with accelerated IMRT 70 gray. So if you see in RTOG study, there was a significant difference that cisplatin arm did better. That 5-year survival of cisplatin arm is around 85%, whereas cetuximab arm was 78%. And again, this PFS also was much better with the cisplatin arm, and it was inferior with cetuximab arm. So definitely, cisplatin did better to cetuximab, both in terms of OS and PF in HPV positive oropharyngeal cancer. So other thing is toxicity. The main aim of replacing cetuximab for cisplatin is whether we will decrease the toxicity. But unfortunately, in this study, if you take grade to grade toxicity, there was not much difference between cetuximab and cisplatin. And what they found is the pattern of toxicity was different between cetuximab and cisplatin, but there is not much difference among the grade 3 and grade 4 toxicity. So overall, this was a negative study. This study proved that we cannot replace cetuximab to cisplatin in case of HPV positive oropharyngeal cancer unless the patient is not fit for cisplatin. So the next study is de-escalate study. So similarly, in the de-escalate study also, so they used cisplatin and cetuximab, and cisplatin 100 milligram per meter square, 3 doses. In RTOG study, they used 2 doses of cisplatin. 200 milligram was the cumulative dose. In this study, it was 100 milligram per meter square, 3 doses, 3 weekly for 3 doses. They compared with cetuximab. And again, this was a negative trial. If you see the hazard ratio, it was 5 with a significant confidence interval. So cetuximab did worse in compared to cisplatin arm. Even in case of systemic recurrence and local regional recurrence, cisplatin arm did better than cetuximab arm. So again, de-escalate trial proved that cisplatin is much better than cetuximab. We cannot replace cetuximab for cisplatin. And the toxicity profile was not much different. The pattern was different, but if you think of the all-grade toxicity, it was not much difference. So this is one side. The other side is reduction of radiotherapy dose following induction chemotherapy. This is the other way where a de-intensification trial were designed in case of oropharyngeal cancer. So there are 3 trials. So all these 3 trials in HPV positive oropharyngeal cancer, they gave induction chemotherapy. Post-induction chemotherapy, they assess the response, and based on the response, they try to reduce the dose of radiation. So the whole study design of all these 3 trials were similar. So post-induction therapy, based on the clinical response, they classified as low risk, intermediate, and high risk. Based on this, they omitted or reduced the dose of radiation from 70 gray to 50 gray. And all these trials were positive trials. They proved that, yes, there is a possibility that we can select out patients based on the induction response, and we can de-escalate trial. But the problem is how many patients we use induction chemotherapy in oropharyngeal cancer. That is one. Second thing is all these 3 trials are small trials, so we need a larger data to really see whether we can extrapolate these data in clinical practice. Then third approach, what they tried is surgical approach. So many of the trials, particularly in HPV setting, what they tried is they tried minimally invasive surgical techniques. That is transoral robotic surgery was used. So most of the trials, they selected the lateralized tumor, T1, T2, and N1 disease preoperatively, and they tried minimally invasive surgical techniques. And post-surgery, again, based on the post-op histopathology report, they stratified into group 1, group 2, group 3, or arm A, arm B, arm C in 2 different trials. And again, in this trial, based on the post-op histopathology, they proved that we can reduce the dose of radiation. We can omit chemotherapy and reduce the dose of radiation in low risk. That's what they tried. So all these trials positively proved there is a chance of de-intensification when we select upfront surgery, particularly minimally invasive surgery, and base our treatment on the histopathology examination findings. But again, the problem is these studies, we in clinical practice using minimally invasive transoral robotic surgery, how much is it feasible? And all these studies are smaller studies, and whether in clinical practice we can use, again, larger data needs to be seen. So these are the 3 ways they try to de-intensification. So if you see, They use clinical factors. So upfront chemo arm, they use clinical factors based on the T stage and N stage. They use smoking history. And in dynamic biomarkers, where they used a response to induction therapy, based on the response, they were risk stratifying. Then they use serum biomarkers. Certain studies use serum biomarkers. They use HPV serum DNA levels to risk stratify and de-intensify treatment. Some trials use genomic biomarkers, particularly P53 inactivation, PIK3CA mutation, MATS3, and estrogen receptor expression. All these genomic biomarkers were used and select out good subset of patient, and this good subset they try to de-intensify. Again, all these things, all these trials, some trials are smaller trials, some are ongoing trials, and definitely we need to wait for the larger meta-analysis or larger study to before we use these data in our clinical practice. So ultimately, this de-intensification strategy, the principle is we need to reduce the toxicity, maintain the same outcome, improve the quality of life. This is the crux of these de-intensification surgeries. The strategies employed is in primary chemo RT, they tried to replace cisplatin with cetuximab, which didn't work. 2 trials was negative trials. They tried to reduce the dose of RT dose and volume was tried. They tried to modify the chemotherapy dosages. Some trials used to try to omit the chemotherapy arm. So these are the various strategies were used. Many trials are ongoing, many trials are published, but still strong, robust data is awaited. Then post-surgery adjuvant setting, where they use minimally invasive surgery based on the post-op histopathology, low risk subset, they try to reduce the RT dose in adjuvant setting. They try to omit the chemotherapy in adjuvant setting. So these are the ways where de-intensification or de-escalation trials were designed. So ultimately, I think we all know that HPV status is most important prognostic and predictive marker. But what we should understand is whatever outcome we achieved, okay, it is based on the standard chemo radiation we used, and it is based on the 7th edition AGCC staging. It is so now a lot of de-intensification happening, but whatever outcome that has been now quoted is based on the standard chemo RT that has been used. So second thing is definitely 2 large studies have shown that we cannot replace cetuximab with cisplatin, and definitely cisplatin is the gold standard. And most important is when we apply this de-intensification study in clinical trial, we need to be extremely careful. We need to be extremely critical until we feel that patient is not fit, we feel that patient's long-term toxicity is high. Those are the time where we can extrapolate these trials in clinical practice, and larger data is required as far as the de-intensification trial is concerned. And last but not least, apart from the HPV positive, there are other markers are required. We know that HPV positive patients are doing good, but there are certain patients, subset of patients among HPV positive, they are not doing so. We need more robust markers among HPV positive oropharyngeal cancer to select out good subset among them so that we can confidently de-escalate treatment in that particular subset. Thank you very much. I think I completed in 10 minutes. Thank you.
Thank you, Dr. Arun, for that very informative lecture and for keeping it in 10 minutes as well. Thank you so much. Well, I don't have much to add to that. That was really, really good and covered the whole topic. So I will just say thank you to Dr. Kripa for inviting us to this session. Good night, and I'll hand it over to Dr. Arvind for his final comments and to close the session.
Sure. Yeah, I agree. I think at least these 1.5 hours was really good. And so was the entire conference. I'd like to thank Kripa, the organizers of MOSCON, for the opportunity. Arun, your talk also was, I really enjoyed. I think, as I said, we really need good biomarkers in head and neck cancers. Unlike many other solid tumors, wherein you have good biomarkers and you have good therapeutic responses, somehow we are not able to get that much therapeutic responses in head and neck cancers. HPV, of course, is really good in the sense we know that these cancers are good prognostication wise. I think these cancers, irrespective of what treatment we give, these cancers seem to do well. At least the HPV oropharyngeal cancers. But I think the results, as you mentioned, of de-escalate in RT-OG was really surprising to say to an extent. I think that adds to a note of caution that we can't really sort of, all the de-intensification strategies have now needs to be studied, as you rightly said, under the context of a clinical trial. And for now, we'll have to stick to the standard treatment arms. Hopefully, I think the other strategies of de-intensification, as you said, with induction chemotherapy or surgery, we just need to really wait with bated breath for the results. And for now, I think we'll stick to our standard practices. I think with those words, I will close. I enjoyed this session, and back to you, Kripa, for the final concluding remarks.
Well, thank you so much, sir, for those kind words. And I'm sure we've come to the end of the head and neck and the thoracic oncology sessions for today. And what a wonderful day we've had until now. So I must thank all the chairpersons, all the moderators, all the speakers, the debaters, and the panelists wholeheartedly for making this a grand success and for contribution as well. So please do join us tomorrow at 5 p.m. for the GI and GU oncology sessions tomorrow. Hope to see all of you tomorrow. Thank you, and signing off for now. Night.
Good night.
Good night, sir.